Sir, we are live now.
Sir, please go ahead.
Okay. So let's start the session then.
Yes.
Akanda Mandalakaram Vyaptamena Characharam Chakshurum Militam Ena Tasmai Shri Guruve Namaha. A very good morning, ladies and gentlemen. On behalf of Department of Psychiatry, Kasturba Medical College, Manipal, I welcome you all to the Psychiatry Update 2020, the annual CME event conducted by our department. We have gone online this time owing to the global pandemic. However, we will strive to maintain the standards we regularly aspire to. The theme for this year's update is Psychiatry and Endocrinology, an interface. Though we regularly encounter clinical problems encompassing both these disciplines on a regular basis, we understand them but poorly. So, in the CME, we aim to provide informative and comprehensive sessions to improve our understanding of this interface between psychiatry and endocrinology. Now, I request Dr. Samir Kumar Praharaj, Professor and Head of the Department of Psychiatry, KMC Manipal, to address the gathering.
So, good morning, everyone. I welcome you all the delegates, our alumni, all the guest speakers, and all other students who have joined today for this program. So, Psychiatry Update, this is a program that we have been having for years together. I think it is one of the first department to start a program like this. I think it has been running since 1990s. Last 10 years, I have been witnessing this program. So it is very popular among students, specifically postgraduate students who benefit a lot from this program. Usually we choose a topic of interest and we try to make it interactive. Many a times we hold workshops and we have hands-on training. This time because of the COVID pandemic, so we could not hold a on-site seminar, so that's why we are having this online version. This time we choose another interesting topic, which is the interface between psychiatry and endocrinology. Specifically, we'll be focusing on thyroid and diabetes, their interaction. And we have a host of speakers, not only from our department, psychiatry, but from other departments, other specialties like from medicine and even endocrinology. So hope we all benefit, we all learn from this today's program. So I want it to be interactive, so you can ask questions. I know it will be difficult for us to interact face to face. I mean, you cannot ask questions live, but then you can ask questions in the chat box. Further instructions will be given by our moderators. So once again, I welcome you all for the today's program. So thank you.
Thank you, sir. Now I request Dr. Sonia Shenoy, Associate Professor and the Organizing Secretary of the Psychiatry Update 2020, to propose the vote of thanks.
Thank you, Dr. Rashmi. Good morning, everyone. I thank all the delegates for registering and showing interest in attending our CME. We are grateful to the Dean, Dr. Sharad K. Rao, and Manipal University for the constant support and encouragement. I wish to thank the Sun Pharma Company led by Mr. Mahantesh for helping us in organizing the CME. I wish to thank Dr. Samir Kumar Praharaj, Head of Department Psychiatry, for his words of introduction for the CME today. This year, the theme of our CME is Psychiatry and Endocrinology, an Interface. We have 6 scientific sessions lined up on this theme over the weekend. On day 1, eminent faculty from departments of General Medicine and Endocrinology would be speaking on topics related to overview of endocrine disorders with psychiatry, psychiatric manifestations of thyroid disorder. We'll also have a case-based discussion on endocrine disorders masquerading as psychiatric disorders. On day 2, we have eminent faculty from the departments of General Medicine and Psychiatry speaking on topics like psychiatric aspects of diabetes mellitus, management of psychiatric disorders comorbid with diabetes mellitus, and metabolic syndrome in psychiatry. We also have postgraduate quiz based on the theme of the CME, just like all the years. On day 1 at 12:10 p.m., we have the quiz prelims, details of which has been mailed to all the registered delegates, and we'll be explaining it again shortly. The main quiz will be held tomorrow with 5 selected participants at 9 o'clock. This year, for the first time, we also have award poster and award paper sessions with 8 students presenting in each session. We also have free posters displayed on a Google Drive, link of which has been shared by mail to all the registered delegates. So we thank all the students for sending their abstracts in huge numbers, and it was indeed an arduous task for our scientific committee to choose only 16 abstracts for the awards. We hope that the CM is an enriching academic experience for all of you. I thank you again for registering and attending the online National Psychiatry Update 2020. Thank you. Over to Dr. Rashmi now.
Thank you, ma'am. Now I will be telling about certain instructions to the participants. So delegates who have not registered for the CME so far may register using the Google form displayed on the screen. The Google form for quiz prelims is also available on the screening link. For those who are interested in taking part in the quiz prelims today at 12:10 p.m., the form will be activated only at 12:10 p.m. by the quiz master. Also, please note that the quiz is only for postgraduate students. All the free posters are available for viewing and may be accessed today and tomorrow using the link shared to all the registered delegates by mail. And also, please fill the feedback forms shared with you through the email you received yesterday. And also, please log in on both the days to get the e-certificates. Now, let us now begin with our first session. I request Dr. Sudha Vidyasagar, Professor in Department of Medicine, Kasturba Medical College, Manipal, to begin the academic session with her presentation on overview of interface of endocrinology disorders with psychiatry. So Dr. Sudha Vidyasagar, she is a professor and HOU in the Department of Medicine, KMC Manipal. She has completed MBBS from Stanley Medical College, Chennai, Madras University, DCH also from the same college, completed MD in General Medicine from Kasturba Medical College, Manipal. She was awarded as Best Outgoing Student from KMC in MD General Medicine. She has a teaching experience of over 34 years, and also she has got Good Teacher Award in Kasturba Medical College, Manipal for 7 times and won TMAPI Gold Medal Award for outstanding research for her paper. The session will be starting at 9:20 a.m.
Yeah,
Do you want the video?
those words, nothing else. I won't have any words there. If the image comes there, I won't have any words. The words will come.
You're comfortable, no?
Yeah, I'm
You can
okay.
adjust the video moving the laptop. If you're comfortable in this position.
Yeah, I'm
This should be
okay.
fine, no?
Yeah.
Will be given, any problem.
Yeah. Should I start now? What is it? Yeah. I'll just make this fan a little less. I don't want so much fan. One more less. You know. Start. Good morning to all of you. I'm honored to be part of this conference, which is dealing with endocrine disorders and psychiatry. As a physician, I have been seeing many patients who have had problems which are endocrine, who present with psychiatric problems, and the other way around. So it's my job today to take you through an overview of the interface of endocrine disorders with psychiatry. We will go through this topic answering these 4 questions. What is the interface between endocrine disorders and psychiatry? What is the common clinical interface that we as physicians face? Why is this interface existing? And what is the clinical implication? Now, the interest in psychoneuroendocrinology began in 1975. If you look at the number of articles that came out, you will find that a lot of work in this area came in the 80s, which was the golden age of psychoneuroendocrinology, where this interface was talked about. But if you see the number of papers that came out over years, this chart gives up to 2010. You can see an arrow there where most of the papers came out on the hypothalamo-pituitary adrenal axis, which is the stress axis that we know of. And this is the most well-documented interface between endocrine conditions and psychiatry, because as we know, the stress response triggers the HPA axis on one side and also the sympathetic system on the other side, making way for a lot of adrenaline and a lot of stress response. What is the importance of this interface? It is because a person who has a problem, like a psychiatric problem due to an endocrine cause, may fall between 2 stools, may be unrecognized at either department. A physician may fail to recognize the endocrine problem and send him to psychiatry, or a psychiatrist may fail to recognize that the psychiatric illness is because of an endocrine problem. So this is why this interface is important, and I'm glad the psychiatry department is doing a conference on this. So this calls for an interdisciplinary approach, and both departments have to coordinate because there is a significant overlap in the presentation and in the management of these conditions. Now let's deal with some of the common clinical interface that we see as physicians. Hypothyroidism is one thing that we all see a lot in the medicine department. And we know that untreated hypothyroidism is significantly associated with depression. We all are familiar with the term myxedema madness, which is how it was described earlier on. for the cognitive defects that these patients had. And hyperthyroidism, on the other hand, is very well known to have an association with anxiety disorders. Moving on to the cortisol, which, like we said, is the most studied hormone in endocrine and psychiatric conditions. Major depression, 50 to 60% of Cushing syndrome may have a major depression, and they also may experience generalized anxiety, mania, hypomania, and steroid withdrawal will cause just the opposite. Uh, Coming to Addison's, sometimes it is difficult to recognize because Addison's may present only with psychiatric symptoms. And if we do not think of Addison's at all, it may be treated as a psychiatric disorder. And that's why they say in the field of psychiatry, Addison's disease can often be overlooked when only the psychiatric features are present. So it needs an astute clinician to recognize that there is a basically endocrine problem. Pheochromocytoma is something that is a rare disease, but it can confuse us as physicians because psychiatric conditions, symptoms may be there of anxiety. I remember having a 20-year-old student who came labeled as anxiety, and because the hypertension is intermittent and may not be there at the time of examination, so it's often missed. Hyperparathyroidism also presents with depression, and this depression is cured by parathyroidectomy. And imagine the amount of money you would spend on depression. That's the dollars given there. So many dollars can be spent on antidepressant medication alone if the underlying parathyroidism is not understood. Similarly, in hypoparathyroidism also, depression is known, and the psychiatric symptoms will not go away until the calcium levels are corrected. The androgens, as we know, can give rise to an excess of androgens can give rise to aggression, anger, and acting out because of the testosterone, DHEA, etc. There's not one endocrine disease where the psychiatric component doesn't exist. You can see in this article about primary aldosteronism, which can present with anxiety, depression, and impaired quality of life. So if you look at the whole gamut of the interface between endocrine conditions and psychiatry, as we listed, we can see the depression that's present in hypercortisolism and the anxiety, the type 1 and type 2 diabetes, the hyperthyroidism, the hypothyroidism, the pheochromocytoma, the hyperparathyroidism, the hypoparathyroidism, and the androgens. And of course, we'll go on to the female hormones later. Now, one of the conditions that we often deal with as physicians is type 1 diabetes. And I see a lot of patients who are young, adolescent, who are already going through the stress of a chronic disease because they began it in childhood. Add to it the rebellion of adolescents because they don't want to take insulin, they do not want to follow a diet, and they feel the effect of peer pressure on them. This leads to mood swings. The mood swings of adolescents are exaggerated by the presence of a type 1 diabetes, plus the fear of going into hypos. Hypoglycemia is common because when you're trying to control diabetes strictly, this happens. And the pain of blood tests and insulin. None of this is easy on anybody at any stage of life. It is particularly difficult for an adolescent because they are not mature enough to handle that kind of stress. And I have a lot of my patients who are worried whether they will get married or not, who will marry them knowing that they're a type 1 diabetic, which again puts stress and drives the diabetes out of control. And the work pressure. I have people who are working in the software industry, which puts a lot of strain on them. And with their type 1 diabetes on the side, this stress makes both difficult for them. So there is a lot of problems that we face when we are dealing with type 1 diabetics. Not only that, we think it's only diabetes that is going to cause a psychiatric problem, but you can see in this article, which is from 2020, there is a relationship between anxiety, depressive disorder, and bone mineral density. So according to the available data, the conclusion says that anxiety, depression, and BMI increase as BMD decreases. So when the bone mineral density decreases in diabetic foot, all these things increase. And so you need to tackle the psychological aspect of these patients also. So not just the diabetes, but the complications of diabetes also have a psychiatric angle to them. And of course, we know the interface between medicines that are given for diabetes and medicines which are given for psychiatric. Some of the psychiatric medicines do cause diabetes, that I will not go into the detail here. There is a lot of work being done. This is again from this month, 2020, November, emotional regulation and diabetic distress in adults with type 1 and type 2 diabetes. And there is a strong relationship. And we know that when we decrease the distress, even the A1C, the glycated hemoglobin, which we use as our gold standard for control in diabetes, that also improves. So unless we tackle both the aspects, we will not be delivering comprehensive care to our patients. Now, having said what is the problem and what is the clinical interface, we will go on to ask ourselves, why does it all happen? The why of it all. How do endocrine disorders cause psychiatric problems? So, where's the link between these two? We know there are neurotransmitters like 5-HT, noradrenaline, and dopamine, and they go through the HPA axis also, and all of them modify the mood. So there is a huge link between endocrine hormones and the mood and the psychiatric manifestations. There is a shared etiopathogenesis. For example, insulin resistance is a pathogenic mechanism between both diabetes and depression. And we know that it has a biological basis based on the insulin resistance in the brain through the insulin receptor in the brain. And on the other hand, you have the Janus kinase, the TNF alpha. All these are playing their part out in the brain, which are impacting on hippocampal neurogenesis, synaptic plasticity, the HPA axis, and the reward system. So there is a common link between type 2 diabetes and depression. A lot of work has been done on the research on stress and behavior, which actually take a different angle altogether, not just the hormonal, but the genetic. So the endocrine alterations in psychiatric patients could go through the genetic polymorphisms. For example, in this article, it was shown that the levels of cortisol, ACTH, and dexamethasone in major depression might be influenced by genetic polymorphisms in this gene, this FKBP5 binding protein, which interacts with the glucocorticoid receptor. So it makes it a little more complicated. It's not just endocrine hormones and psychiatry, it is the genes acting on the endocrine secretions which are causing psychiatric disorders. So the link becomes more complicated here. There are so many things that we don't know about the brain. One of the less recognized facts is that the brain is the most fertile of all endocrine organs, and it produces neuropeptide hormones within and beyond the boundaries of the endocrine hypothalamus. Most of us think it's only the hypothalamus, but much beyond. And that is why there is no simple answer to the question whether endocrine activity is directly related to the pathophysiology of a psychiatric illness, or it acts as a vulnerability factor, or it's a compensatory mechanism. All three are possible. And there is a huge area, a gray area in this field, which requires a lot more research coming in. One of the most fascinating interfaces is in the pathophysiology of eating disorders. For example, the neuroendocrinology of anorexia nervosa and bulimia nervosa has been variously researched and described. We know that there are profound endocrine disturbances in anorexia, and these could be adaptive, reactive, or etiologic, like we said in the previous slides. And we know that the chronic starvation is characterized by increased secretion of cortisol and growth hormone and suppressed levels of leptin. That's why they are so thin, sex hormones, and T3. So all these endocrine disturbances do occur, and probably the most important thing is the high levels of cortisol, indicating and ACTH, indicating that it's not the problem with ACTH, it is the CRH hypersecretion which is there in anorexia nervosa, and all of them have a psychological effect. Now, not only do endocrine disorders act independently on psychiatry, sometimes they act together, which is what we see when we see patients with diabetes with eating disorders. And you find that the common denominators for developing eating disorders in type 1 and type 2 diabetes are increased body weight, body dissatisfaction, female gender, a history of dieting, and a history of depression. So, a lot more goes into the combination of two endocrine disorders and their psychiatric manifestations. And we know that type 1 diabetes has a lot issue with psychomotor agitation, sleep difficulty, and endocrine disorders. Now, does gender play a role in this endocrine link? We all know that we all categorize women as being emotional, but probably we're at the mercy of our hormones. And this good review from Lancet talks about why are women so vulnerable to anxiety, trauma-related and stress-related disorders, and what is the potential role of sex hormones. So we know that there is a lot of link between sex hormones and psychiatric manifestations in polycystic ovarian disease, in premenstrual tension, postpartum depression, PTSD, post-traumatic stress disorder, and postmenopausal mood swings. Now, a lot of work has come out on psychiatric disorders in women with polycystic ovarian syndrome. Anxiety and depression is well known. And we know that not only anxiety, not only depression, personality disorders, social phobia, obsessive compulsive disorder, and ADHD and eating disorders all are possible. And that's why we find it quite difficult to manage these adolescents when they come to us with, to the gynecologist and to us as physicians. And a lot of other conditions like schizophrenia and other psychotic disorders are also more in women with PCOS than in general population. We know that menopause is a stressful phase in the life of a woman, and there is an increased risk of major depressive disorder in women who are undergoing menopause. There's a 2 to 4-fold increased risk. There is a good risk for post-traumatic stress disorder, especially when there are periods of low estradiol, like premenstrual phase, postpartum, perimenopausal, and postmenopausal. All of them can lead to impairments in the natural extension of emotional responses in the aftermath of trauma. And it is during these phases that women tend to go into mental and behavioral disengagement, alcohol, drugs, or denial. So the hormonal link for PTSD is well established. There are sex differences in many other disorders. For example, schizophrenia, bipolar disorder, post-traumatic stress disorder. The question asked is, are gonadal hormones the link between all this? And we can see here that progesterone and estradiol, both of them have effects on the mood, and allopregnanolone is another hormone that is recognized to have a lot of impact on the mood. What is the link now? The link is that serotonin and allopregnanolone are endogenous anxiolytics, and estradiol stimulates both of them. And estradiol is a good thing to have because it automatically brings about less of anxiety. And so it is through these links that the female sex hormones may be working. And it is known that there is an impact of sex hormones in schizophrenia also. Women with schizophrenia have symptom fluctuation related to their menstrual cycle, and periods of low estradiol, like we have told, lead to increased rate of hospitalizations in people with schizophrenia. And there are improvements in pregnancy during schizophrenia, all of which may have an estrogen basis. Now, this is where I think we all have to pause, and as interdisciplinary roles, as a psychiatrist, as a physician, as an endocrinologist, we have to think what are the clinical implications. There's so much theory told about. We know that there is a lot of link in this interface, and we deal with these kind of patients daily. But what is the clinical implication of all what we have heard so far? One of the personal experiences that I would probably never forget is the way I had a 60-year-old patient with uncontrolled sugars. And she was usually controlled earlier on. And I was surprised to see a 300, 400 sugar in that lady. And in a busy OPD, the first reaction is, how come your sugar is uncontrolled? What did you do? I mean, it's a little, kind of a school teacher response to that. And I did say that, have you gone off diet or have you stopped your medication, which are the two common things that we deal with. And then she sat quiet for a minute, and then she told me that she lost her son-in-law in a railway accident 15 days ago, and the daughter and the children had come to her house. So that's when I felt that I completely missed the point. I never understood the stress she was going through. And after that, I learned to ask all my patients about stress when their diabetes is out of control, and not the usual things of not dieting or not taking the drugs. And I've emphasized to all my postgraduates that whenever they write a diabetic case sheet, they should mention whether the patient is having stress or their sleep is not all right. Because a fragmented sleep is another risk factor for diabetes, and one which drives diabetes completely out of control. So if we do not understand the patient as a whole, and we are just looking at the endocrine part of it, the diabetes part of it, we will probably do more harm than good, because we'll completely miss the point and we will not treat the patient as a whole. And control of this anxiety in this patient actually brought down her sugars much better. And that's when I realized that this is something that we should all do in our clinical practice. Like we said, it's well known that diabetes and depression is common, and physicians must be aware of the psychiatric symptoms associated with diabetes. And if the psychiatric issue is not understood, the diabetes will never come under control, and the financial cost to society and the healthcare system is catastrophic. This we all know from personal experience, which is actually being dinned into us day after day. But it's just that we are reluctant to cross over to another specialty and think about it. And that's what is probably the block, the mental block that we all face as physicians. So the misdiagnosis. I had a 35-year-old housewife who was brought to me by her husband saying that she doesn't work in the house and she's very lazy. This is what he told me, that she's very lazy and doesn't want to do anything. One look at her face and I knew she was hypothyroid. Her face was puffed up and she was really looking very tired. And that's what she told me. Doctor, it's not that I'm lazy, I'm just tired. At the end of the day, I can't do, and I wasn't like this. And detecting that hypothyroidism as a cause of her depression and correcting it probably saved the marriage. So we know that we can misdiagnose and miss the diagnosis if we don't look for it. We have had patients with steroid withdrawal, patients who come to us who have taken steroids for either asthma or rheumatoid or something else, and then or some Ayurvedic drugs which contain steroids, and then they stop it. When they stop it, they come to us with severe weakness. They cannot do their routine work and they are feeling low. They don't feel like doing anything. And I have seen people on antidepressants for steroid withdrawal. If you go into the history and ask them, then we know that the steroid withdrawal is probably the cause of depression. And if we treat the steroid withdrawal by the small dose of uh, prednisolone that we give, most of our patients do extremely well. So unless we have the recognition that there could be an underlying endocrine problem to the psychiatric manifestation, we would miss all this. Similarly, with pheochromocytoma, like I told the 20-year-old student who was brought to me saying anxiety, not writing the exam, always feeling tremulous, on and off. And so this on and off was taken as hysterical behavior until somebody detected a hypertension during that time. So this interface is important because we as physicians may miss the psychiatric aspect. And the psychiatrist must understand that the psychiatric manifestation could have an endocrine aspect. A lot of work is being done on the link at the biological level. We know that there's a lot of work being done on cortisol and major depressive disorder. And from the bench to bedside, a lot of information is coming. And this is a study which again came out in 2020 about cortisol and major depressive disorders. And they say that major depressive disorders do influence cortisol levels, but there's still the interface is not worked out very well. And we don't know whether intervening at this interface would make a difference to the patient, because there is no proper cutoffs for the levels at which we could diagnose. And we say that probably the response of the HPA axis may be different in patients with major depressive disorders. Some drugs which are used for diabetes can actually ameliorate depression. This is again information which came in recently on type 2 diabetes. where metformin was found to ameliorate depressive behavior when compared to baseline, and similar results were known for liraglutide, which is what we call as a GLP-1 analog, which is also used in diabetes. So sometimes the treatment for one endocrine disorder may actually bring down the depression in the other side. Not only that, not only the diabetes, but the complications of diabetes can also be influenced by depression. This is a study which talked about, again came out in 2020, Diabetes Care. Depression is associated with progression of diabetic nephropathy in type 1 diabetes. So not only the diabetes is increased, but the depression causes increase in the progression of diabetic nephropathy. So if it is not understood, we could be losing a lot of kidney in the bargain, and the patient may actually become more and more renal failure. Now, probably as physicians, endocrinologists, and as psychiatrists, we were always focused on the HPA axis. Everybody was talking about the HPA axis, but there are so many hormones that are beyond the HPA axis, which are actually influencing mood and psychiatric manifestations. Now, that is called a simplified diagram. But if you can look at this diagram, you'll see how many hormones are involved. Estrogen, ghrelin, vasopressin, neuropeptide Y, melatonin, leptin, all of them, pregnenolone, prostaglandins, all of them are there. So, and look at the interactions between them, it is so complex. Some of them inhibit some others, some of them influence some others. So, what is the implication for therapy at the hormonal level? Estradiol has been used successfully as an adjunct for SSRI in depression. Again, this is an old paper. I don't know the current status of this, but maybe this pharmacotherapy may help to avoid the fluctuations in sex hormones, and this may be worthy of investigation. So many hormones have been tried. Allopregnanolone has been tried as an anxiolytic. I have not put up the studies because we have a whole conference coming up and many people will be talking on this. This is just the curtain raiser to this whole interface. The SCRMs have been tried for anxiety. Oxytocin has been tried as an anxiolytic as a target for therapy. AVP as an anxiogenic. Neuropeptide Y as an anxiolytic and an antidepressant. Prolactin, leptin, ghrelin, melatonin, and prostaglandins. All of them have been tried. So maybe supplementing these hormones may make a change in the manifestations of these psychiatric disorders. What would be the future directions of this interface? One would be the timing of drugs in women, because women know that we know that in women during the menstrual cycle, there's a huge fluctuation of hormones, and we know that there are periods when the estrogens are less, and these are the periods where women are more vulnerable. And so maybe changing the timing of the drugs to suit the cycles of women may be one area where psychiatry will move on to interlink with physicians and endocrinologists. Understanding mechanisms will make a huge difference to the way we look at any disease. And so understanding the hormonal link of psychiatric disorders is very important, and I think it is the future. Next is genetic mapping of psychiatric disorders through endocrinology. So the genes influencing the endocrines and the endocrines influencing the psychiatry may be the next move forward. So look at this picture. It's a question of perspective, whether you see the wine glass or you see the two faces. That depends on which department you come from. And I want to congratulate the psychiatry department for going across specialties. I think this is what is missing in today's medicine, that we are divided into specialties, but patient is one. Patient has all the systems in one place, but we are trying to divide him into pieces and look at each piece separately. And it's nice that the psychiatric department has come up with this theme for an endocrine interface for the psychiatric disorders. And I think this is the future. People who can understand another department are probably going to be the winners in future. Thank you very much. I'll just mute. Yeah. Stop share now. Stop. Mute you. The first question that's been asked is menopause and psychiatric complications. As we all know that in menopause, there are many women come to us as physicians with mood swings, hot flushes, and feeling, suddenly very anxious. And then the other side, that they feel that they can't do much. So these are both anxiety and depression can occur in menopause, and they may oscillate between both. It's not that one person has only anxiety or only depression, but because of the mood swings that they have, they're often misunderstood. They tend to react very much to small things, what they would not take seriously in the non-menopausal time. Uh, they would take much more seriously during menopause, and it's only the perimenopausal time, so it's actually 6 months before and about a year up to a year later. After this, most people settle. Most of them who come to us as physicians do not require much treatment at all. They require more reassurance, and probably they do well with the placebo. Because if you tell them that no, this will settle and you will be all right in 1 year, most people don't like that. So we generally put some supplements, and the gynecologist also put some supplements to say that this will work on your mood. But otherwise, there is no major, I have not seen a major breakdown in people during menopause. But yes, we have to understand that it could be related to the menopausal time. The psychiatric manifestations could be related to the menopausal time. Okay, the next question is how to differentiate between hypothyroidism and depression. We have a lot of clinical manifestations, like when we see a patient with hypothyroid, of course they are depressed. Like what I told you, we have seen a lot of women, especially women, because hypothyroidism is common in women, even in men. They do come with mental slowing. They're not able. I had a bank clerk who told me that she could not calculate as fast as she could earlier on, and also that they feel depressed and don't feel like working, etc. But we have clinical features like the face. I mean, most of us, it's like a pattern recognition on Google. Once you see a patient with hypothyroid, the face, you can make out the subtle changes, that you get a little bagginess around the eyes, and a little swollen face. And then you ask them about their weight. They would have gained weight. There is some amount of bradycardia, some amount of constipation that they have. And we go for the ankle jerk. The typical thing that we look out for is a hung up ankle jerk, which we make out. So, as physicians, we have other tools to aid us to make a diagnosis of hypothyroidism. But hypothyroidism, unless you suspect, you will not ask for the TSH. That's the danger. There are two diseases in medicine that we say that you must have a sharp eye for. One is hypothyroidism, one is Parkinson's. Unless you think of it, you will not look for it. So that is why depression, yes, depression also patient will look very slowed and quiet and things like that, but it would not have the other manifestations like constipation, like weight gain, like cold intolerance, like bradycardia, those things. Okay. So that's how we differentiate between depression and hypothyroidism. The next question is, since diabetes mellitus is related with depression, does anti-diabetic medication bring some improvement in mood, or is it related to in cause and not the treatment? Like I showed you in the last two slides, there are one or two studies which talked about metformin bringing down depression, similarly with liraglutide. But it is not just that. The depression in diabetes comes because of many factors, because you're living with a chronic disease, and this chronic disease is altering your lifestyle. Like you can't eat what somebody else cannot eat. You have to be always careful about what you eat, about your weight, about your exercise, which all of which are not very nice on the mind. In type 1, it is much more difficult because they are young and they are insulin dependent for life, and that is enough stress for a young person, and to think of a life ahead dependent on insulin. So it's not everybody who can take that stress, and people do go into depression. But antidiabetic medication causing improvement in depression, I found only 2 studies, one on metformin, one on liraglutide. The reassurance that you can give your patient and tell them that it's not so bad as they think is probably one of the best things that you can do to allay their fears and say that it's not too bad. When we used to have meeting for our type 1 diabetic patients, we used to always put a photograph of Wasim Akram and tell that, see, he's a cricketer, he's playing so well. And I used to make the small boys in the type 1 group bow to me. Those are the things that would, perk them up. And, you show them actresses who are type 1 diabetes who are doing very well. So role models like that can help them. But as such, antidiabetic medication, no, except for few. There's some more questions on this, no? Chat. Okay. Okay. One question is on premenstrual disorders and anxiety and temper problems. Yes, like we saw the link between the female hormones, the cycle of hormones in the female menstrual cycle, and their relationship to post-traumatic stress disorder and anxiety is well known. And that is why we said that the low, wherever there is low estradiol, remember estradiol is a natural anxiolytic. Okay, it's a natural anxiolytic because it works up the levels of serotonin and allopregnanolone. So you don't have enough estradiol, those periods of your menstrual cycle, you are going to get more anxious, and post-traumatic stress disorder is also more. And that is the link. That is the link between the sex hormones and the anxiety and temper problems. And if you point out the link to the patient, I think the patient understands. Most patients are intelligent enough to understand. And first of all, they understand that they're not out of control. I mean, it's scary for somebody to think that I am not in control of myself. But if you say that, no, no, don't worry, it's just the hormone, and you should recognize it and you should just cool yourself down. Many people do extremely well. Once you point out what is the problem to them, and they understand that there's a reason they are behaving like that, they are able to forgive themselves and others. So I think that explanation is what makes the difference. The next thing is, what all psychiatric disorders can be manifested in diabetes mellitus? The commonest psychiatric disorder is depression, because it's not only depression because of the disease, social, emotional, and circumstantial, but also a disease in the brain, like what we said about the insulin receptors in the brain, which the shared receptors between depression and diabetes in the brain. So there's an endocrine link, there's a biological molecular link at the level of the brain and circumstantial. So depression is the most important psychiatric disorder that is manifested in diabetes. Of course, a lot of anxiety about the future because of type 1 diabetes, especially. They don't know where they are going. They don't know whether they'll find partners in life. They don't know whether they can hold a job well. And they don't know whether they will, get into hypoglycemia in the middle of a crowd and feel embarrassed. Those anxieties to remain. So some of the patients actually have what we call as binge eating to prevent hypoglycemia. So they do that also. So both are common. And of late, a lot of psychiatric disorders have been known to increase the complications of diabetes, like what I mentioned about nephropathy and even bone mineral disorder. So these are bigger and bigger links that are being discovered. The next question is, are we supposed to taper and stop steroids or continue same dose with this steroid withdrawal? Now, the HPA axis actually gets suppressed once you give the steroid for more than about 2 weeks. So we have a lot of patients who are coming to our OPDs with steroid withdrawal because they have taken for 6 months, 1 year, like that. And then somebody would have told them, no, no, steroid is a bad drug, no, you don't take. Or they would have got admitted in a hospital for some other illness and somebody would have stopped the steroid. Once that happens and they come to us, we recognize when we see them that they are feeling very low, tired, weak, and myalgia, things like that. And we do the cortisol. The cortisol is very low. Then what we have to do is we have to put a supplemental dose of cortisol. We give this replacement dose of 7.5 milligrams of prednisolone, and then we continue it for some time, because the HPA axis can take about 1 year to recover. It's not that they will recover very fast. So the tapering of the steroid always has to be done very slowly, and we play it by year. Like we give 7.5 initially, then we give for 2 months, and we come down to 5. Wait there and see whether the patient is better or not. They're not better, we continue on 5 for a long time. I've had patients for whom I have withdrawn over 2 years also. So it takes a long time for the patient to recover, because when you try to taper down, they get back their symptoms and they're the best judge of what symptoms are. That's it. That's it. Any more questions? No. Thank you all for a very patient hearing. Thank you. Oh, yeah, no. Honoring. I- Will it take a long time or you won't? All right, okay. I'll read you.
Thank
Yes.
you, ma'am, for your valuable inputs on the topic. Now I request Dr. PSVN Sharma to present a memento to Dr. Sudha Vidyaswamy.
It's okay. Fine. Thank you, ma'am.
Thank you.
Excellent. Thank you.
Thank you, everyone. Next section will be begin at 10:15 a.m.
I now invite Dr. Vasudeva Acharya, Professor, Department of Medicine, Kasturba Medical College, Manipal, to present his valuable opinion on psychiatric manifestations of thyroid disorders. Dr. Acharya completed his MBBS from Government Medical College, Bellary, Gulbarga University, and MD from Mysore Medical College, DNB, General Medicine, from the National Board of Examinations. He has several publications to his credit and has authored chapters in several books. He has also been a reviewer of Indian Journal of Respiratory Medicine and APIK Journal of Internal Medicine, and a postgraduate examiner at various universities and National Board of Examinations. Over to you, sir.
Good morning to all of you. It's my pleasure to be a part of this psychiatry CME, particularly the endocrinology and psychiatry interface. I thank Dr. Sameer, the HOD of psychiatry, Dr. Sharma, the senior professor, Dr. Sonia, and other team members for inviting me to this meeting. It's always good to have this kind of interdisciplinary conferences so that we can have a mutual exchange of our knowledge. So when the topic was given to me, this is what actually came to my mind without looking at any literature. So severe thyroid dysfunction may mimic any psychiatric symptom profile, which I have seen a lot of patients. Some words like myxedema, madness, base dose psychosis, this suddenly flashed in my mind when I got this topic. Mild thyroid disease also have irritability, depressed mood. Again, it's all my experience kind of thing. Subclinical hypothyroidism, which is actually a very interesting topic in our field. There are many people think that these people need to be treated, provided there is some other reasons. And one of the reasons actually we are thinking is depression. So somebody with depression, subclinical hypothyroidism, should they be treated with the thyroxine? And of course, when you see somebody with an abnormal biochemical thyroid value, like TSH high, low, or T34 low, high, is there a genuine thyroid disease? Why this question is because there are a lot of critical illness, psychiatric illness, psychiatry drugs, which can have some interaction with the T3, T4, TSH. This was in my mind. So this will be my flow of thoughts in this next 40 minutes or so. So physiology of thyroid hormones, homeostasis, and effects on the brain. This actually I'm a little bit concentrating on the last part of that. Common thyroid disorders, hypothyroidism, hyperthyroidism, causes, features, treatment. It is actually my topic, so I don't have to read anything about it. The next components are more difficult for me. Neuropsychiatric manifestations of hypothyroidism, neuropsychiatric manifestations of hyperthyroidism. And I will touch upon two important issues there. Actually, one is called thyroid autoimmunity and the psychiatric manifestation. I'll put a little bit details of these issues. And of course, quality of life, social issues with the thyroid disorder. Of course, you people are expert in this, but still I'll comment few things on that. And lastly, I comment a few slides on lithium and thyroid. When actually the topic was given to me, it was looking very easy for me. So thyroid disorder, I'm an expert, there is no issues with that. But I thought I'll read the textbook of endocrinology. This is the Williams is the standard textbook of endocrinology. I looked into the thyroid disease and psychiatric manifestation. I was surprised to see there are only 4 sentences. That means everything else I'm talking later is actually I made a kind of relatively intense literature search. So what the Williams textbook gives is what probably we know commonly, that patient with the neuropsychiatric disease may have any kind of TFT abnormalities. People with the bipolar disorder have a slightly elevated TSH, mild reduction in T4. Severe depression can have elevated T4. Acute psychosis can have anything. So reasons are unclear. And last line is important. We need to differentiate from the primary thyroid problem. This is what I got from the textbook of endocrinology. So a little bit of history of this thyroid and psychiatric manifestations. Long back in 1825, Ms. Parry actually increased the incident, reported there is increased incidence of nervous affectation. This is the word used in that publication in thyroid disorders. 1873, the words like myxedema and psychosis words were described. And in 1949, the famous phrase that is myxedema madness was coined by Dr. Asher. So this, I think I've already told you kind of, this is a basic knowledge what we have. Thyroid disorders affect emotion and cognition. Excess or deficiency of thyroxine cause mood problems. Depression can be accompanied by a subtle thyroid dysfunction. This is very important, as I've been telling you. Such patients should be identified and if necessary to be treated. Overt thyroid disease is rare. Even I think this is kind of a summary which I'm going to give at the end of my slide also, end of my presentation also. And only 1 to 4% of the affected disorders have a overt hypothyroidism, but subclinical was quite common. And the last part, I think many of you would have used this also, use thyroxine as an adjunct treatment for a depression, which also I'll touch upon a little bit. Again here, the first line, the mental symptoms often accompany all medical disease. This statement is very important because I have one psychiatrist resident with me in my team now. I think I've told her to see all my patients because they have some issues. So it's worth being seen by a psychiatric people if they have time, almost all medical illnesses. So merging rate of depression and hypothyroidism is almost 56%. These are a little older publication, this 56%. I don't think it's actually true in nowadays because there is an early diagnosis of thyroid disorders. And the last line, that's quite important, the causality, the mental disorders and the thyroid disorders. Is there a causality in between these two? Basically, all these actually model studies are based on the biochemical. You have a TSH value and look at some, you go follow some psychiatric guidelines to make a diagnosis of something. It's actually, they are not based totally on a psychosocial medical model. This is actually, I felt it's the most controversial issue when you look into the prevalence of thyroid dysfunction in psychiatric diseases or psychiatric illnesses. So I saw the different literature. It varies from maybe 1% to maybe 50, 60%. I just looked into one or two, I think, specific authors' publication. So this is from an Indian publication. That's why I actually decided to show you. Here, Mr. Radhakrishnan, he has found around 30% of the people admitted with the schizophrenic disorders had abnormal thyroid dysfunction. So almost 25% had hypothyroidism. Of course, many of these are actually subclinical. They are not overt hypothyroidism, but did have an abnormal TSH value. And when you looked into the mood disorders, almost 23% has an abnormal thyroid function. And most of them are again hypo, that means probably elevated TSH. And also I looked into one more from Germany, which actually they looked into the different your coding, which I am not very familiar with these things. So ICD-10 code with all these disorders, and around 1,134 patients they looked in. And what is the percentage of people with the thyroid disease, non-specifically altered TSH or a T3, T4? There is no huge difference. Of course, there is some increase in the mood disorders. Otherwise, there are not much of a difference. And they conclude that newly admitted psychiatric patient with a genuine thyroid disease, there was no notable association of thyroid disease and major psychiatric diagnostic groups according to ICD-10, particularly depression. So that what is this mean by a major and how much is it significant? No notable. These words are important. So I will say that milder disease, some amount of association is always there. So go back to the basic physiology. Next few slides, actually, I'll talk about the physiology and the pathogenesis of these disorders. You know that it is a hypothalamus which secretes thyrotropin releasing hormone, TSH which is secreted by anti-repituitary, and the thyroid glands. You have a positive effect here, more TRH, more TSH, more T3, T4. And T3, T4 acts all throughout the body and which has a negative feedback on TSH and TRH. So if you look into the synthesis of thyroid hormone, what happens inside the thyroid gland? This is the thyroid follicle. You probably remember all this writing histology diagram of the thyroid follicle. So TSH has a strong influence on that. You need iodine for that. So iodine with tyrosine, which forms the thyroglobulin, which is finally converted into T3 and T4, which by diiodothyronase it becomes T4. That means 4 molecules. With 3 molecules, 1 molecule iodine added to this thyroglobulin becomes monoiodothyronase, otherwise T3. So T3 and T4, which are the peripheral hormones. In that, T3 is actually the greatest metabolic activity. Though 90% of the secreted hormone is T4 from the thyroid gland, T3 has a major activity, and I'll go to the next slide, which tells about how T3 is formed in the peripheries also. This is about what happens in the cellular level inside the thyroid gland. So we have a TSH here, and you have sodium iodine symporter, which transports the iodine. So we need iodine, we need a TSH here. So it is transported, and don't bother about all these things. So you have actually thyroglobulin here. So what's called organification of thyroglobulin with iodine. You have a monoiodothyronine, diiodothyronine. Then depending on the couple combination, it becomes T3 or T4. So both again come to the cell pinocytosis, then through the lysosomes, they exocytosis and reach the blood. So this is at the cellular level. If somebody asks you what is the function of thyroid hormones or the thyroid hormone metabolism, you can tell anything. Actually, T3, T4 works on each and every cell of the body. So most important things are actually skeleton and growth, bone mineralization, skeletal muscle development, then liver and heart function, CNS, that's what actually mentioned here, CNS and the behavior also. Immune system also has some effect, and finally the basal metabolic rate. So thyroid hormone increase the basal metabolic rate. So this is the physiology of the thyroid hormones. Little more into the effect of thyroid hormones and the brain, which is actually we are interested here. That's why I put this T3, T4, RT3 and D1, D2. D1, D2, this remembers me the psychiatry wards in our hospital. I think it's been changed nowadays, but still I can't forget this D3. Just now talking to the HOD here. So the T4 is the is considered T4. I told you 90% of the thyroid hormone is T4, which is secreted from the thyroid gland, which is actually a prohormone. It doesn't have an active effect. Some effect is there, but it's kind of a prohormone. T3 is the active and which is responsible for most of the metabolic effect. As I told you, only 20% of the T3 is produced in the thyroid gland, and remaining T3 is synthesized or released from the T4. So that is done by different enzymes. That's why this D1, D2, D3 come. So remainder of the removal of iodine, one of the iodine molecule is removed from T4 by this D1. That is nothing but type 1 deiodinase. The name itself says deiodinase. So it takes off the iodine in the circulation. This is important. So D1 is predominantly in the circulation. Same D2, that is type 2 deiodinase, D2, which is in the brain. So we are interested in D1 and D2, particularly D2, because this has an action in the brain. So if D2 is not there, you can imagine, though there is a T3 in circulation, you may not have enough T3 in the brain. So that's a problem with the D2, which I'll talk probably a little later about some diseases. Type 3 is actually has a opposite action, which forms T4 into reverse T3. The reverse T3 is an inactive form. So once this T4 is converted to reverse T3, actually it doesn't work. So in the brain, D2 is predominantly in glial cells, which actually has transport T3 and also formation of T3, whereas D3 in the neuron, which actually becomes an inactive form. Then there are another two important proteins we should know, maybe three. One is actually these thyroid hormones cross the blood-brain barrier via big transporters. They are called transthyretin or TTRs. If there are some problems with TTR, they won't reach the brain itself. Then another two proteins. One is actually what is called OATP1C1, organic anion transport protein 1C1. This actually helps in transfer of T4 into the glial cells. So T4, remember it, T4. And the second one, which is called monocarboxylate transporter 8, MCT8, which transports both T4 and T3, but predominantly T3. Why I'm stressing these two is because there are nowadays we are diagnosing a lot of diseases with the thyroid problems, with the neuropsychiatric diseases and manifestations, having some genetic problems with these proteins. So there are some specific diseases have been diagnosed with problem with these proteins. So MCT4 and OATP1C1. T3 in the brain is produced from the brain, that is from the T4, which has come through this hormone, and it can be produced by, as I told you, D2 iodinase, and also transported to the brain by MCT. MCT transport T3, whereas T4 transported by this, but produced by again D2 enzyme. So these are the few things we should remember when you talk about the genetic issues here. So thyroid hormone receptors are widely distributed in the brain, which regulate the cognition and mood. So in the specific areas of the brain, which I was telling you, so temporal and spatial regulation of this deiodinase enzyme, particularly D2. As I told you, D2 is the one which converts D4 to D3 in the brain. D1 is actually nowhere related because D1 is in the circulation. D2 we are particularly interested, and also the transporter system and the expression of thyroid hormone receptors. Combination of these three will cause multiple problems in the brain, though thyroid gland is normal. That's what I'm going to stress on these things. So, for example, there is a mutation in this MCT8 gene which actually transport T3. So, what happens? You will not find enough T3 inside the brain, but in the body, otherwise you have enough T3. So, this may end up what is called an isolated neuronal hypothyroidism. Though these are very rare, I'm not saying these are common diseases, but you have isolated problem in the brain, hypothyroidism, because of this MCT gene problems. So, polymorphism, the D1 gene, as I told you, D1 is a deiodinase in the circulation, which have no effect on TSH because they have nothing to do with the TSH, because T4 and T3 will be transported by the other enzyme. So it will not cause any problems. Sorry. Yeah, there is no effect on the TSH because D1 has nothing to do with. So polymorphism in D2, D3 gene cause alteration in the T3 levels in the brain without changes in serum concentration, because serum concentration are directly linked with D1, because deiodinase works in D1 affects in the works in the peripheral circulation. So there are multiple publications on this, actually this genotype and genetic disorders and the thyroid function abnormalities and depression or bipolar disorders. So one of those actually they looked into the deiodinase 1 genotype and thyroid function to lifetime history of major depression in different kind of population. And it's a complicated slide, don't worry about it. But they found actually confirmed the prior reports of this particular gene is associated with the FT4 levels, increased FT4 level. We show that genotype is also associated with the major depression. So we can look into this further research can go on these particular enzyme issues. This is a very interesting name I found when I looked into literature search. I found at least 15 publications in this name, Robertas Bonifacius. That's why I thought his review is quite important. It may be a little old, 2010 is published. Even after that, there are many publications in his name. I think he's an expert in thyroid and psychiatric disorders. So he was telling about increased TSH positivity, like high TSH is associated with the risk of depression in mainly in women. That's what he found. And in fact, negatively associated mood in men. So it's the problem with TSH, hypothyroidism, depression is more in women. That's what he felt. And he actually put a lot of controversies. I'll discuss later. And he said most psychiatric patients do not have a overt thyroidism. It is common. Even we also agree with this. And if present, it is actually is a risk factor for the mental disorder than a causal. That's what he thinks. It's a risk factor, not a causal. Then I think these are all I'll discuss later. They also told that depression, this is actually well accepted issue. Depression, which decreases serotonin in the brain, whenever they decrease serotonin, there will be increased thyrotropic releasing hormone. So increased TSH, increased FT4. That's why this is the explanation he gave for a increased FT4 in patient with depression. And there is also some blunted reaction to TRHO. In a depressed patient, if you give a thyroid hormone releasing hormone, TSH response is not as good as normal. That's also actually he thought. Now I think next 5 to 7 minutes I'll discuss predominantly medical issues. I think we should know about this. So classification of the thyroid disorders. This is pure medical issue. Taken from a textbook of medicine. So hormone excess, otherwise indirectly call it a thyrotoxicosis, Graves' disease, multinodular goiter, adenoma, subacute. These are the 4 common causes. Secondary are rare. Secondary means problem with the pituitary. They are very rare, but you may find that TSH secreting tumors. Hormone deficiency, otherwise hypothyroidism. Most common is Hashimoto's or autoimmune thyroiditis, atrophic hypothyroidism, then post surgery, post radiation, a lot of other things. There's an important entity called hormone resistance, which is not been well studied. So thyroid hormone can have like insulin resistance. Thyroid hormone also can have a resistance to its functioning. It can be a thyroid gland, peripheral tissues, brain, everywhere. It's a big topic by itself. Another disease called euthyroid goiter or endemic goiter, which used to be very common around maybe 3-4 decades ago, particularly iodine deficiency. Now, because we have a fortified salt, which is available always, so it's not common nowadays. But still, you find a lot of people with a goiter without any thyroid dysfunction. Then, of course, non-functioning tumors, benign, malignant, all kind of tumors will be there. So, how do you interpret this thyroid function test? I just put the most important ones here. So, TSH, T4, and T3. I have not specifically put for a free T3, free T4. That will complicate the issue. Don't bother about those things. If you find a undetectable TSH, which is very low TSH, raise T3, raise T4, simple. Diagnosis simple. It's a primary thyrotoxicosis. That means thyroid is functioning more. Undetectable THH with normal T4, only T3 raise. There is some entity called T3 thyrotoxicosis, predominantly T3 secreting tumors. Not tumors, but lesions. undetectable TSH, but normal T3, normal T4. This is called subclinical thyrotoxicosis. Not a very common entity, but it is there. We find sometimes. Normal TSH with low T3, low T4, secondary hypothyroidism. That means TSH secretion itself is affected, but you may have some TSH there. That's why actually you can see that put as a normal TSH. Some amount of TSH will be there, but response is very poor. That's why you don't have a high TSH. This should have been a high TSH otherwise when you have a low T3, T4. It's also not a common disease. So this is the most important issue I'm discussing. TSH between 5 and 20. This 20 is a little arbitrary value. In our hospital, actually, we take 10. So 5 to 10 as a subclinical, and I think more than 10, we take it as a disease actually, overt hypothyroidism, but most of the standard textbook gives 5 to 20. TSH high, not very high, but you have a normal T3, T4. This is called subclinical hypothyroidism. This is probably the most common kind of thyroid dysfunction we find in our hospital. So more than 10, 20 TSH, T3, T4 low, very simple, primary hypothyroidism, Hashimoto's or whatever it is. And this very high TSH with T3, T4 normal, sometimes we find this is usually due to artifact or rarely, as I told you, thyroid hormone resistance. So few sentences about thyrotoxicosis and hypothyroidism. So common cause of thyrotoxicosis, I think the first three are the most common. Graves' disease is a very, what you call a celebrity disease. So it's called, described by Basedow. There are Basedow psychosis you would have heard, otherwise called Basedow's disease also in the past. So it's an autoimmune disease of the thyroid gland, which has a diffuse goiter, and there is a skin and ophthalmology involvement also. Multinodal goiter is more common in the older age. Solitary adenoma can happen at any age. Thyroiditis transiently can have a thyrotoxicosis. Basically, thyroiditis is a decreased function, but there may be problem with the release of hormones, so they may have a transient thyrotoxicosis. Iodide induced, previously used a lot of iodide for a treatment of thyrotoxicosis. Nowadays, we don't use that much. And extrathyroidal tissues like factitious, tumor ovary, or a taste secreting tumor, these are all rare. First three and at the most four. These four contribute for almost 98 to 99% of the thyrotoxicosis what we see. These are the typical features of thyrotoxicosis. What I highlighted is neuropsychiatric manifestations. So weight loss despite normal or increased appetite is a typical syndrome of thyrotoxicosis. Also, we get the same thing in uncontrolled diabetes. Also, remember, so there will also be weight loss and increased appetite. So heat intolerance, sweating, palpitations, irritability, emotional lability, anxiety, apathy, multiple other psychiatric manifestations. Palmar arrhythmia, tachycardia is very common. You can kind of what you call atrial fibrillation arrhythmia, one of the common arrhythmia you find in thyrotoxicosis. Lot of eye signs you may get, so don't bother about that. I simply have put a lid reaction and lid lag, but there are around 10 named eye signs are there in thyrotoxicosis. Untreated thyrotoxicosis may cause osteoporosis, and also amenorrhea is also relatively common in thyrotoxicosis. Once you find the low TSH, high T3, T4, and clinical features of thyrotoxicosis, you should differentiate between at least 3 or 4 common types which I told you. So Graves' disease, adenoma, multinodular goiter, and thyroiditis. The test done to differentiate this is radionuclide scan, which I show you the picture here. So radionuclide scan, this is done in the nuclear medicine department. Either you can use technetium or iodine. In our hospital, actually, we use technetium. So if the gland takes technetium, entire gland take uniformly increased intake is seen. This simple is Graves' disease. Graves' disease is a uniform increased intake. This is the normal thyroid gland. Some amount of increase will be there. I should have put a picture of salivary gland also. So when you take this technetium 99, salivary gland also takes technetium, which is seen in the same kind of picture. Whereas Graves, this will be dark, salivary glands will be very thin. This is thyroiditis. That means decreased uptake. There is inflammation. There is no uptake of iodine or a technetium, so it's decreased. This is normal except a small area here which is decreased. This is called cold nodule. Actually, it's an alarming sign. If you find a cold nodule, it is likely to be a malignancy. If you find a hot nodule, this is typical what I call a adenoma, single tumor, single lesion which is secreting thyroid hormone. This is multinodal. You can see multiple. There are 4 or 5 hot spots what you call. So it's secreting the thyroid hormone. This is multinodular goiter. So multinodular goiter, thyroiditis, Graves' disease. So treatment of thyrotoxicosis, there are 3 choices. You have anti-thyroid drugs, otherwise called medical management of thyroid disease. You have carbimazole or propylthiouracil. It can be used in most of the people. There are some issues with the pregnancy. We can use propylthiouracil in early pregnancy. Otherwise, any of these drugs can be used. Second choice is radioactive ablation. In present sense, most of the people actually, the treatment of choice is actually radioactive ablation. The only problem with radioactive ablation is most of them will go for hypothyroidism later, 6 months or 1 year later. They need to be on a thyroxine supplementation for lifelong. Some people don't agree with this. So you undergo some procedure, again take medicine. So they don't agree. So that's the problem. Otherwise, almost all, except during pregnancy or a planned pregnancy, we go for radioactive ablation. Traditionally, actually, this was done only for older people, but nowadays they do it for younger people also. Surgery is not a preferred choice nowadays. Again, it's a olden days surgery was a preferred choice. Now we do for only a large goiters for a cosmetic regions or a compressive symptoms are there or a person cannot take drugs, you go for that. Temporarily, we can manage a patient with propranolol, which reduces the symptoms. So this is the treatment of thyrotoxicosis. I will move on to hypothyroidism. So classical symptoms, weight gain, cold intolerance, fatigue, all these are typical symptoms. Carpal tunnel syndrome, bradycardia, hypertension may be there. But depression is the more common in hypothyroidism. There may be psychosis, what is called as myxedema madness. So causes of hypothyroidism, again, 2-3 most common. Most common obviously is Hashimoto's thyroiditis or autoimmune. You find a very high amount of thyroid antibodies there in these patients. Iatrogenic, that is following a radioactive ablation, which I told you, which is commonly done nowadays for many people with thyrotoxicosis, following surgery or sometimes drugs like amiodarone or lithium. Thyroiditis also, most of these actually end up in Hashimoto's later, but there are some other forms of thyroiditis like dequarans, riddles, they may also cause hypothyroidism. Iodine deficiency causing hypothyroidism is not very common nowadays in at least in our country, because we have most of the places you find a fortified salt or iodine added salt. It's more common in mountain regions. They have a bigger goiter actually. Congenital infiltrative diseases like amyloidosis, secondary like pituitary problems, these are all rare causes of hypothyroidism. Treatment of hypothyroidism is simple actually, levothyroxine, otherwise called LT4, levothyroxine or T4, that's what available easily in the market, LT4 or something. You titrate the dose to achieve a normal TSH, that's what you do. The TSH is 50, whatever it is, usually you start with a dose of around 25 or 50, then keep on increasing to achieve a normal TSH. So treatment of hypothyroidism is very simple, anybody can treat hypothyroidism. You need a higher dose in pregnancy because fetal growth, TSH alteration, multiple things are there. Are different guidelines for treating hypothyroidism in pregnancy. In simple, you need a higher dose. Use a lower dose in people, older people, particularly the cardiac disease, because it's a cardiac stimulant, it may induce some arrhythmia and all. So, little careful in the older people. As you know, there is a strong overlap between the hypothyroidism symptoms and neuropsychiatric manifestations. So these are the overlap symptoms, hypothyroidism symptoms and mood. You look at everywhere kind of yes is there, except maybe weight loss, which is not seen in hypothyroidism. People with hypothyroidism gain weight, whereas mood disorders, weight loss, weight gain, both possible. And insomnia is not a common feature of hypothyroidism. Otherwise, fatigue, constipation, appetite loss, decreased pleasure, libido, decreased interest, all are common with hypothyroidism and mood disorders. Again, almost same thing I put here. Shared symptoms will be between these two are depressed mood, fatigue, sexual drive reduced, and trouble concentrating. Whereas the person is likely to have a depression if he has insomnia, inability to sleep. These are classical, I think, the depression symptoms. You people are better with these thoughts of death and committing suicide, planning to commit suicide, etc. Whereas hypothyroidism likely to have a constipation, cold intolerance, muscle cramps, hoarseness, dry skin, which are not features of actually depression. There are a rarer presentation of thyroid disease and neuropsychiatric manifestations. So once in a while, they may present with melancholic depressions. Around 5 to 15% of the severe hypothyroid patients have some form of psychosis. So it's not rare actually. Capgras syndrome, I think you must have heard. There are many case reports of this Capgras syndrome with thyroid dysfunction, like your close relative or something imposed by somebody else. I think there are multiple other manifestations which are not good at those things. So you may have hallucinations, loose associations, paranoia have been reported. There is a nice article, which is a very old article, but it gives very nice presentations of these things. Psychosis may precede physical symptoms by a month. This is the one thing you should remember. So I think this is one of the reasons actually people with psychosis or a depression worth checking on TSH value. So I'm telling you, there is some classical publication on this myxedema madness with the Capgras syndrome, with the catonic features and responding well to thyroxine along with the olanzapine. And another case report also, risperidone used here actually for a management of myxedema madness. So what is the effect of levothyroxine? LT4 is levothyroxine 4. That's what I continue to use this LT4 and LT3 and now onwards. So treatment of hypothyroidism. I'm not talking about thyroid effect actually. I'm talking about a neuropsychiatric effect here. Effect on a neuropsychiatric manifestation. So LT4 treatment to achieve normal TSH range. That is my job. Actually, I will achieve a normal TSH by giving a levothyroxine at a different dose. Definitely, it improves neuropsychiatric symptoms. There is no doubt in that. But there will be a definite inconsistent pattern. You cannot expect everyone to improve normally, and complete resolution is unlikely. The psychiatric or the psychosis or depression may not be, complete resolution may not be there. And some people even thought of giving a higher dose to keep a TSH in a lower side. For example, 0.5 to 5 is also normal TSH. So I am happy with the 4 TSH, but some people try to keep TSH around 1, give a higher dose, but it is found actually not superior. Then actually the concept of what you call levothyroxine 4 with LT3 also. This LT3 is not easily available. Thyroxine T3 is not easily available in the market. What we use is actually T4. But there are attempts of using this. The concept came actually in 1891 when they introduced the thyroid hormone therapy. So what is given is actually animal thyroid extract. Here we cannot differentiate between T3 T4. Animal thyroid extract will have both T3 and T4, right? So it has been tried in the past. There is no doubt in that. But variability of T3 and T4 in a given tissue actually led to the replacement of what you call a natural combination. You call it as a natural combination probably. Animal thyroid extract, what all the thyroid gland what secretes. But it's actually the variability of this that led to the simpler T4 monotherapy. So nowadays, actually, we treat with T4. In before 1980s, actually the T4 dose was, the thyroxine dose was related to clinical symptoms. Ended up in obviously higher dose. So now we use by the TSH values. So there is a significant reduction of thyroid reduction. Maybe in 70s and all, average person would have received 125, 130 thyroxine. Nowadays, most of people manage with 50, 75. So even with the TSH normal range, few do have psychiatric symptoms, which I told you, it may not be very clear. This was I was telling you before also, there is some genetic polymorphism and combination therapy. That's what, again, thanks goes to Munveshis. He put a lot of articles, I told you. He added LT3 to LT4 and showed significant improvement in the neuropsychiatric symptoms. So the reason behind that he told is probably a same thing, that D2, dehydrogenase 2, which is present in the brain, or the proteins, the OATCP1, which transmits actually T4 to the brain, it may affect, it may be useful in such patients. He had not detected those things, but he proved it. But many other ascids failed to use this concept as such. But if the patient has subset of people with a D2 gene polymorphism, D2 means the conversion of dehydrogenase T4 to T3 happening in the brain. People cannot convert T4 to T3 in the brain, may have a positive response to T3 because you can give directly T3, which goes inside the brain. Whereas in a OAPCP1 polymorphism, which actually transport predominantly T4. So even if you give T3 here, no use, because it's the issue with the transport of T4. So no use. So at present, generally the combination is not used and T3 is not easily available also. So next few slides I talk on neuropsychiatric manifestation of subclinical hypothyroidism. This I told you is a very common entity. You find elevated TSH, but normal T3, T4 and no symptoms. What to do for these patients? So prevalence varies with the upper level of normal TSH. Different labs, different places give upper level of normal TSH. We often use at 10, but an international standard is used at 20. So what happens to this SCH if you don't do anything? Around 4.3% will convert to overt disease by 1 year, and 2.6 if they are antibody negative. If they are TPO antibody positive, good number. 5% will convert to overt disease. So is it worth treating? It's an entity. In fact, in medical field, anybody with the subclinical hypothyroidism also has a TPO antibody. Actually, we treat them. But at the same time, around half of the subclinical hypothyroidism had normal TSH by 4 years. Don't do anything, nothing will happen. So TSH may become normal, particularly if the antibody is negative. So antibody negative, no clear consensus. Antibody positive, may treat. One of the studies showed 63% subclinical had depressive symptom. I think it's actually high, I would say, but it's too high, 63%, but it's been published in 2010 or something. But large cross-section studies fail to show a good link with the depression. And even it is present, it is more common in the young adult and a middle-aged adult compared to older people. So treatment of subclinical hypothyroidism with levothyroxine as far as depression is concerned, it's a mixed result and no clear consensus at this point of time. And also there is a meta-analysis which published very recently, 2018, they published here. They found that overall subclinical hypothyroidism is not related to depression. Younger patient may be useful, some association found, but no benefit of T4 treatment on depression in patient with subclinical hypothyroidism. And maybe you have fixed the TSH titer for a particular age, then you can study further. That's what the recommendation this article gives. This is the most important entity. Somebody who is euthyroid depressed, TSH normal, T3 normal, T4 normal. Will you give a thyroxine trial? In long ago, the Bior et al. He used a supratherapeutic dose, 375 macrogram of thyroxine he used for 51 months, and he found more than 80% improved. He used in all diseases, all psychiatric diseases, schizophrenia, MDD, that is major depression, bipolar disorder, less hospitalization, 80% improved. Difficult to believe as far as medical person is concerned, because people won't tolerate this high dose for 51 months, almost 4 years or something. They won't tolerate. But anyway, it's a published article in that. But I looked into some other interesting points here also. So around 30 to 40% fail to respond to antidepressant. I think all of you know, in a primary depression, around 30% people, 1/3 will fail to use respond for a single antidepressant therapy. So you try some adjuvant therapy. Can we try LT3 like thyroxine or LT3 as an adjuvant therapy with the antidepressants? Remember, this is for a euthyroid normal person but depressed. There are two entities, what is called accelerating antidepressant response and augmenting the antidepressant response. There are multiple publications on these issues. Accelerating means you start drug with an antidepressant, whatever it is, SSRI or a TCAs. Along with that, use levothyroxine, LT3 or LT4. In fact, many people said T3 is better. Start with the drug. Whereas augmentation, you already use some drug antidepressant, no response, as said 1/3 of what you see, add in a thyroxine. So this is called augmentation, particularly for TCS. Overall, actually, it said not much useful, but there are many plus or minus articles. So certain polymorphism, as I told you, D1 polymorphism, LT3 may be useful, they said, particularly when using SSRI, use a T3 hormone, the people with the D1 polymorphism may be useful. Now we move on to thyrotoxicosis and neuropsychiatric manifestations. I think I already told you thyrotoxicosis in TSH less than 0.01 and increased T3/T4 symptoms. It varies from anxiety to depression. Anxiety is more common, obviously. So some reported a higher number again. Anxiety 60%, depression 31 to 69%. But I put a star mark here. These are a little older publications. I think this is from around 98 or 99 somewhere I found. Higher numbers probably due to a delayed diagnosis, I would see. Nowadays we diagnose thyrotoxicosis early, probably due to delayed. That's what my concept. Classical symptoms are anxiety, dysphoria, emotional lability, intellectual dysfunction, restless. Anything can happen. Anxiety side actually, including anger and mania also. Depression also is reported. Rarely delusions also reported. Specifically, some people looked into Graves' disease. I told you Graves' disease is an autoimmune disease, one of the common cause of thyrotoxicosis, causing psychiatric symptoms. I don't know if you can see this or not. Actually, this is a little interesting to see. In Mayo Clinic in 1920 to 1931, almost a century ago, people with thyrotoxicosis, they looked into psychiatric manifestations. Huge number had toxic psychosis, 42%, 26% delirium, and around 20% bipolar disorder. Here, this is from the Ito Hospital in 1975 to 1979, again around 50 years ago, 40 to 50 years ago. They started seeing more and more anxiety disorders, more and more depression, and less delusions and less psychosis. Again, I told you, I assume these reasons are due to early diagnosis, and this is due to late diagnosis of thyrotoxicosis. This is a century ago. What happens with the treatment of thyrotoxicosis? You are given a radioactive iodine or antithyroid drugs. What happens? Neuropsychiatric symptoms did not resolve in many patients, about 50% in fact, which was more common in the people with Graves' disease, particularly with the ophthalmopathy, eye involvement. So there are enough residual cognitive deficits, and there is some benefit propranolol. Propranolol, I told you, is used in treatment of thyrotoxicosis initial part to control the symptoms. And some people continued this propranolol even after achieving a normal thyroid function. They showed some benefit with propranolol with the neuropsychiatric features. This is the relationship between overt hyperthyroidism and mental disorders. So many authors, most of them, a reasonable number, except this first one had only 33 patients, otherwise 160, 500, 2,600 people with the control. In fact, most of them found there is a good relation between the anxiety, depression, anxiety with the improved with treatment, more in Graves. In fact, bipolar disorder also more common. This was found by Hugh. More hyperthyroidism and depression also found by this group. So they have found a significant amount of relationship between the Graves' disease and particularly hyperthyroidism and neuropsychiatric manifestation. And there is an entity called finding a role of emotional stress in the onset of Graves' disease. The presentation of Graves' disease is a role of emotional stress. And many people found good, out of I think 10 or 11 studies, almost 6 or 7 people said there is some relationship with this. So there is something to do with the Graves' disease and the emotional stress. Subclinical hyperthyroidism is not a very important entity. I told you in the beginning itself, it's not very common. So what you mean by this is low TSH, like hyperthyroidism, but normal T34. So they may have some amount of nervousness and irritability. Definitely is less apparent than the obvious Graves' diseases. So I think this kind of diseases is better actually refer patient to psychiatrist rather than medically managing them. Better evaluate and treat as a mood problem rather than a separate disorders. Whether to treat this subclinical hyperthyroidism is not very clear. Treat in the sense I'm talking about anti-thyroid drugs. You may try in older people where there is an increased risk of atrial fibrillation or osteoporosis. You can try small dose, but should be careful. And there is no data on the reversal of mental symptoms in this group. This is an interesting entity I thought I'll touch upon. Thyroid autoimmunity and psychiatry. So I'm not talking about hypo, everything here. People having an antibody. There are multiple antibodies which are tested for thyroid gland. Most common one is called TPO, thyroid peroxidase antibody. There are TSH receptor antibodies. There are many other antibodies tested. TPO is a commonly done, actually, which is very commonly found in people with the Hashimoto's thyroiditis. But many people with Graves' disease also have a TPO antibody. So is there a link between autoimmunity, depression, and bipolar disorder with or without a overt thyroid dysfunction? That is actually the entity here. There are multiple good publications on this. This is actually looking at the Hashimoto's thyroiditis. People with Hashimoto's thyroiditis, that means they will have an anti-TPO antibody high. And is there a link of depression? Most of the people thought there is higher prevalence of depression. So this Gayanias, Alchin, and this study also everybody tell there is a significant link between the anti-TPO antibody and depression, irrespective of they are on treatment or they are euthyroid. See, this is purely euthyroid, no treatment. This group euthyroid, some of them received T4. This both, it had people with treatment, people without treatment. All of them had some link with the depression and anti-TPO antibody. If you look at the general population also, they found not much actually relation with the depression and TPO antibody. No association with TPO antibody, the depression. Here also, most of the studies had not much of link there. Another group of studies, actually, they looked into what is called a postpartum depression. It's actually a very important, I think, entity as far as psychiatry is concerned. They looked into the link between thyroid antibody and the postpartum depression. So all these three groups have found significant amount of link with the depression. People who had a TPO antibody, except maybe the last one. Last one did not have much, but these 2-3 had a significant link between the autoimmunity and the depression. This is about bipolar disorder. This is actually, there are 4 or 5 studies. All said there is it's a controversial result. That's why I don't put a smaller part. I'll put in next slide as a summary. Yeah, I have put a summary of that autoantibody and your psychiatric disorders here. So thyroid autoimmunity is associated with the major depressive disorders and bipolar disorders. Maybe more common, more linked with the depression. High TPO antibody in Hashimoto thyroiditis patients. More depression has been proved by many people actually, irrespective of thyroid. This is more important, irrespective of thyroid function test. So, is it worth checking for a thyroid antibody in all major depression? It is left to you. So, there is definitely increased incidence. Probably I will check if the family has a thyroid disease. Person may not have family because this anti-TPO antibody runs in families. If there is a strong family history of a thyroid disease, person has a depression, probably not responding well to your therapy, check antibody. What to do after that? Again, I don't know. Whether to treat them with a thyroxine, accelerate or augment, which I was telling you, probably we can try those things. Or at least you check TFT frequently in such patient, maybe once in 6 months or once in a year, if necessary, treat. TPO antibody positivity during pregnancy is been proved probably to have a more postpartum depression. As far as bipolar disorder is concerned, I told you, which is not very clear association. Some authors found there is association, some people did not. But more interesting is there a link for the same genetic disorder like thyroid autoantibody and bipolar disorders? Can we link? Like we have an autoantibody here. I don't think we have any antibody approved. I'm not sure anything has been tried in bipolar disorder. Is it from the same disease, same genetic disturbance? That probably needs to be studied. Next to 3-4 slides, I put on social issues, which I'm not an expert in this. So I just looked into the literature and I'm putting don't ask me any questions on this. So this is not my field, but I looked into some issues there, quality of health and work related issues. So this particular study, which is published in 2013, so thyroid hormone status and health related quality of life It's a big study actually. And they found that this population study, health related quality of life scores of subject with depressed TSH value or markedly elevated, like either hypothyroidism or hyperthyroidism, were generally not significantly lower than subject with the normal or mildly elevated TSH. There is no big difference in the quality of life. Again, another study which looked into thyroid dysfunction, also autoimmunity, and the quality of life and mental health, particularly in children and adolescents. This also said not much. So in contrast to finding in the adults, especially in hypothyroidism, there was no significant impairment of quality of life or mental health in children and adolescents in the generic pediatric population affected by the thyroid disease. So there is no big difference. Another publication actually also looked into the quality of life, particularly working life. So impact of thyroid disease on a working pattern or a working life of the patient, which is a review actually very recently published in May 2020. And they found hypothyroid and hyperthyroid patients actually have taken more sick leave. If you ask me, the hypothyroid, unless they are like myxedema madness or a myxedema coma, they don't need to take a leave. It's a milder disease. It's one of the milder diseases what we see in a medical field. They don't have to take a leave, but they found actually it has affected the the working life. So they have taken a more sick leave, particularly depending on the severity. And another issue probably may be true is what I also see is hyperthyroid impairing working ability, particularly if the Graves disease involves the eye. It has a very bad eye symptoms and they respond very poorly to therapy also. TSH responds very well, but ophthalmopathy and eye symptoms, diplopia and all, they respond very poorly. This is probably understandable, but this part I'm not very sure whether it's really true or not. Of course, people with the thyroid, which I have not touched upon, the thyroid cancer issue I have not touched upon. So obviously thyroid cancer survivors remain unemployed, 1/3 of the people. This actually, I think next, I think 2 or 3 slides I put on drug therapy and actually the drugs used by psychiatrists and the thyroid dysfunction or any association. So this one publication talks about the thyroid function in patients with a bipolar disorder and impact of quetiapine therapy. And what it says is actually around 28 patients with a psychiatric disorder, they did not find any significant, no significant difference in the thyroid profile initially. But when they are treated with the quetiapine, so that's what they say. Nonetheless, quetiapine treatment may disturb the thyroid system and needs a close monitoring. I think somebody is on a probably higher dose of quetiapine. Probably we should look at, I don't know, like there must be some recommendation from your psychiatry textbooks and all. So they should be on a thyroid monitoring. You know, this is not a quetiapine is a very commonly used nowadays drug nowadays. So there must be some other recommendations on that. Lithium, the age-old drug, which is kind of a drug which even now it's been used. I think all of you must be using this drug very commonly, and a very strong link with the thyroid abnormalities. I thought I should touch upon this drug. I have only 2-3 slides on this. So spectrum of lithium disorders and the current perspective. So thyroid actually, the lithium affects thyroid function in multiple ways, not just on particular enzyme or something. At a cellular level of hormone synthesis itself, that means affecting the thyroid gland itself, and also it affects the thyroid release also. Also, it reduces the peripheral conversion of T4 to T3. So in multiple ways it affects. So predominantly it causes hypothyroidism because all this decreased synthesis, decreased release, and decreased conversion into T3. So hypothyroidism and goiter. So this goiter was seen around 3 to 12% by palpation, and if you do an ultrasound, around 50% you found goiter in a people taking lithium for a long time. So they are the most frequent abnormalities. Hyperthyroidism is very rare, and the increase in the propensity to thyroid autoimmunity has also been observed. So many people on lithium, they tried checking TP antibody, which has become sometimes positive later. So again, the prevalence, as I told you, I am little hesitant to put all this prevalence of neuropsychiatric manifestation in thyroid disease because it varies from 0, 1, 2% to 60, 70%. Here also, this person says around 5 to 52%. So average duration is around 18 months. I think you use this for a longer time in many patients. So this hypothyroidism followed by lithium is more common if the person is on a longer duration of treatment, more common in females, age above 50 years, family history is there, positive antibodies. I am stressing this, at least this group of people, I think you should monitor them. So we should do a frequent, I think you must be doing on almost all patients, definitely this group we should do. So once in 3 to 6 months, probably TFT and maybe ultrasound neck also to do look for the problems. So finally, I'll end here talking about my summary. So there's a long recognized link between the thyroid and depression. There is no doubt in that. So depression is more common in hypothyroidism, anxiety, bar depression in hyperthyroidism. This is a worrying thing. Causal relationship is not been established yet. That means if you treat the cause, patient will become better. We don't know. Most patients with depression have a normal TFT. This also you should know. Don't jump and see, I want to do TFT for everybody and I want to see the thyroid problems. No, we will not find. Possible role of thyroid autoimmunity is an interesting thing in the pathogenesis of depression and bipolar disorder, particularly depression. Screening the patient with depression for thyroid disease is reasonable. So I won't see like somebody said depression, you do a TSH. I don't find any objection to that. So using thyroxine as an adjunct, I think I leave it to you. The whatever are called as augmentation or acceleration of antidepressant therapy with the thyroxine. In internal medicine, actually, we don't actually seriously look at into this aspect, except if the patient is a hypothyroid or at least subclinical hypothyroidism. Normal euthyroid patient, we don't recommend, but I think psychiatric probably we should try in particular patient and it needs to be investigated further. And more probably genetic and neuroimaging field studies are required, particularly that D1, D2 enzyme related polymorphisms. So finally, shall I refer all my thyroid patient to your team? I don't know, or will you refer all your depression patient to me? You decide on this. Thank you so much for patient hearing. If you have any questions, I'll just check that. It's okay. So there are a few questions I can see here from Dr. Nisha H. Hypothyroidism in pregnancy and psychiatric complications. There is nothing very odd about that psychiatric. Only one difference in pregnancy, I think I've told you, the treatment of hypothyroidism. The indications are actually like your threshold is low. So you treat even a borderline TSH also. Anything above actually 2.5, some people say even 2 TSH, you treat them. And you adjust the dose frequently. Second thing is psychiatric complication in pregnancy. Of course, it adds on. So pregnancy itself is actually has lots of complications, particularly postpartum. Definitely there are, it increases with the people with hypothyroidism. And one more entity, I think, which I've told you in between, people having TPO antibody positive. Even if they're euthyroid, if they have a thyroid autoimmunity, there is a definite increased chance of postpartum depression. Next question I can see from Joshua Andrade. Is there only depression comorbid with thyroid or other psychiatric manifestation? I think this I've already addressed. There are multiple. Definitely answer is multiple more than depression. Even in hypothyroidism also, which is actually depression more common, they also have psychosis, whereas hyperthyroidism, anything can happen. Dr. Bandari is asking something on, is there a need to treat subclinical hypothyroidism if mood disorder is under control and there is an incident, this is an incidental finding. Yes, this is an important question. Actually, in internal medicine, we have some 4 or 5 indications to treat subclinical hypothyroidism, like people who have infertility, people who are pregnant, people who have very high lipid level, people who have TPO antibody positive, and depression. This one, I just say it's a depression. So I don't know actually how mild, moderate, severe depression. To answer your question, subclinical hyperthyroidism, mood disorder is under control. Probably I will not treat unless this patient has any one of other things, like is pregnant or is infertility or a very high lipid level or an antibody positive. Otherwise, I will not treat. Now, Dr. Samir is asking about for hyperthyroidism, when to choose carbimazole or PTU, which is what is the starting dose, target dose, and what is monitor. So presently, in general, the drug of choice is carbimazole or methimazole. Both are available actually. PTU's advantages are 2 things. One is actually it acts fast. So actually, I don't see any reason to act fast, but if you really want to act fast, you can start PTU. Maybe few days it acts faster than carbimazole. Second thing is early part of the pregnancy, first trimester of pregnancy, we prefer PTU. But if you look at the literature of last 4 or 5 years, the endocrinologist actually, Dr. Sana may be answering this question later. Actually, they say even carbimazole is good enough. There is no need to change at present. But in general, obstetricians are apprehensive about carbimazole. So I will go for PTU in the early part of pregnancy. And if at all, you are starting at want a faster action. The carbimazole dose, it comes in 10 milligram, 5 milligram tablet. You can use 10 milligram 3 times a day to 20 milligram 3 times a day. start at the lower dose for older people and look at the two important side effects are on liver and the counts. You have to check the TLC, that total leukocyte count around 10 days and 1 month later. Whereas PTU dose comes in 50 milligram. So you can start 50 milligram 2 times or 3 times a day and increase up to maximum up to even 300 milligram it is used. Dr. Shah is asking about, is it advisable to ask for a free T3 T4 on most people can be diagnosed by simple T3 T4? Your answer is a little tricky question to tell. So I will not ask for a free T3 T4 in all patients. That is first answer. I can manage with T3 T4. But if you are, for example, if the person is kind of, for example, you are a psychiatric patient, he is depressed, and you have a TSH value which is kind of a borderline, not very kind of a low or very high, borderline subclinical kind of thing, then I'll ask for a free T3 T4, which will actually dictate the things. Then, of course, some specific situations, for example, pregnant woman, I will ask for free T3 T4 because it guides you, because you have to treat them fast, manage them fast, next few days is important. So such people actually ask for free T3 T4. Otherwise, it's not a must. So unless it's a borderline people. But other way of looking at this is, if you look at the cost, if you do in our hospital T3, T4, TSH, which is almost equivalent to TSH and FT4. So you do only FT4 and TSH. That is your choice. You can do that. Give a little more information. I don't deny it, but because of just cost issue, I don't want to do everybody free T3 T4. Again, Shah is asking one more question. For treatment of rare genetic disorder, LT3 is available. LT3 actually, I'm not sure, definitely not available locally. I remember using an injection of levothyroxine, in fact, getting it from Mumbai around 10 years ago. Person come with a critical hypothyroid with the complications. He is not able to absorb the food because he had a what I call a paralytic ileus. So it is available, but not in this market. You have to buy it. I think tablets are not available as far as I know. And Manisha is asking about mostly we come across thyroid dysfunction as incidental finding in patient with depression. Yes, I agree with that. Among them, as I told in the beginning itself, thyroid dysfunction is not so common in manifestation in the as a mood disorders. Among them, when and to whom T2 antibody test to be done? Is there a role of treatment with the steroids for autoimmune thyroid disorders? Okay, so you are asking me whether to do a T2 antibody test in a people with the thyroid dysfunction. Correct. So this is a good question to be asked. As I told you, there are so many. In my slides, I showed you the importance of T2 antibody. If you ask me, I will do most of the patient with thyroid dysfunction, irrespective of their depression or not. I will do TPO antibody. This gives you an idea. Multiple reasons it has an advantage. Somebody has a subclinical hypothyroidism and TPO antibody positive. I will treat them with thyroxine. As I told you, that's one of the indications to treat, irrespective of depression or no depression. Second thing is, which will probably tell about the future. So if somebody has euthyroid, like T3 T4 normal, but he has depression, but TPO antibody positive, this patient likely to develop probably hypothyroidism, slightly higher chance of developing hypothyroidism in future. So you may have to check TSH more frequently. And if the family history is there, definitely I'll check. So this specific question, if somebody is depression, thyroid function is normal, will you check the TPO? It's a difficult question to answer. But if you look at my presentation and the link between I showed between thyroid antibody and the neuropsychiatric manifestation, I feel there is nothing wrong in checking because it's not a very costly test. I think our lab is cost around some 200, 300 rupees, not a very expensive test. But what to do after that, I think keep in your mind, if there's a family history, if they're pregnant, treat them with a small dose of thyroxine. Otherwise, wait, maybe more frequent checking of TSH. And the last part you're asking is role of steroid. Because it's an autoimmune disorder, shall we try steroids? So as far as I know, as such, TPO antibody positive and a thyroid disease, we are not giving steroids. Steroids in thyroid disease used in only one condition, that is called a thyrotoxic crisis. That is not for an antibody purpose. That is for actually all the steroid in the body is utilized by the thyroid hormone excess. And when you are treating it, they will have a what I call a Addisonian crisis. To overcome that, we give a steroid, not for a autoimmune actually disease. But remember this autoimmune disease is not actually only thyroid. Somebody having autoimmune thyroid disease is likely to have many other autoimmune dysfunction. So in such cases, there may be indication. Somebody has an SLE with the TPO antibody positive, you may give steroid. But as such, just because TPO antibody positive, you will not give steroids. I think I answered almost all the questions. Thank you so much.
Thank you, sir, for your valuable insights on the topic of psychiatric manifestations of thyroid disorders. As a token of appreciation, I now request Dr. Anil Kumar, Associate Professor, Department of Psychiatry, to present a memento to Dr. Vasudeva Acharya.
Yeah, you will welcome. You want to keep a video? Close or video? Yeah, very expensive. Yeah, everything. Yeah, okay. Thanks. Thank you.
I now invite Dr. Sahana Shetty, Associate Professor and Head, Department of Endocrinology, Kasturba Medical College, Manipal, for a case-based discussion on endocrine disorders masquerading as psychiatry disorders. Dr. Sahana has been a recipient of several prestigious awards. She has published widely as well. Some of the awards are a silver medal for research for her work on vertebral fracture assessment by dual energy X-ray absorptiometry, along with the BMD in the evaluation for postmenopausal osteoporosis at the ISBMR annual conference and endo update held at New Delhi in 2018, and a gold medal for research on bone turnover markers at 10th annual meeting of Indian Society for Bone and Mineral Research, Mumbai. Over to
Good morning, everybody. Yeah. Yes. A very good morning to all of you. At the outset, I would like to thank Dr. Sameer, Dr. Sonia, and the organizing team for having me here. Today, I'm going to talk on endocrine disorders masquerading as psychiatric disorders, where I'm taking you through a series of cases to show a practical aspects of how do you diagnose or kind of suspect these cases when they present with psychiatric manifestations. So when we all have heard of terminology called neuropsychiatric endocrinology. So this suggests that there's a close link between this, the neuropsychiatry and the endocrine systems. We know that the central nervous system and endocrine systems are both designed for intercellular communications, and most importantly, they have crosstalk between them. Now, if you consider central nervous system kind of a electrical circuit, endocrine system is more like an Wi-Fi, which acts on several different. In addition to that, electrolytes and calcium can help lead to the diagnosis in many of these cases. So, moving away from hyperglycemia, let's move to our second case. So, this is a 63-year-old lady. So, this lady had history of irrelevant talk, confusion, switching, tremors early in the morning. So the patient's children complain that every day, most of the days in the morning, when they try to wake her up, she's confused. There's an irrelevant talk. She does not recognize the relatives and had an abnormal behavior. And these episodes used to last only in the morning times and used to improve in the later part of the day. She was evaluated at local place. Most of her investigations at that point of time was normal. So she was diagnosed to have conversion disorder. I do not really understand the psychiatric terminologies, you would know better. And then she started on antipsychotics. And some of these episodes, she also kind of had an acute weakness. So the local doctors had also thought of a transient ischemic attack, and she was started on antihypertensives and antiplatelets and also on statins. So this was the medication she was on. So one fine day she came with acute alteration in mental status and a paucity of movement in the left half of body. So the initial presentation looked like a cerebrovascular accident with a left hemiparesis. So if you look just on this at a glance, you feel that you have a lady who had been having episodes of recurrent TIA and now has presented as CVA and also has some psychiatric manifestations early in the morning. Now these symptoms were going on for the last 6 months. But in the emergency, what they found is that in the initial assessment, her RBS was GRBS, it's a glucometer RBS, was 29 milligram per deciliter. Of course, they were surprised and they did send a lab value, but then she was immediately started on 50 ml, 50% dextrose. So not only was there improvement in the sensorium, her sensorium was completely normalized, but also the paucity or the left-sided weakness also improved with dextrose, suggesting that all her acute presentation was secondary to severe hypoglycemia. So when we have hypoglycemia, you can have two types of manifestations. One is the autonomic manifestations, where you have tremors, sweating, anxiety, kind of feeling hunger. These are autonomic symptoms. And then when it is more severe, you can have neuroglucopenic symptoms, which is kind of obtundation, going into drowsiness, seizures, and even you can also have acute neurological deficit, which is reversible with treatment. So this particular patient actually had symptoms of hypoglycemia. It was predominantly in the morning because of the fasting which happens overnight. So daytime she probably used to eat and would not have this prominent symptoms, but then the overnight fasting would lead to these symptoms in the morning and then most of the times when she used to go to hospital previously, probably she would have been normal at that point of time. Hence her investigations did not reveal this. So the main reason I put up this is to know that there's an entity called hypoglycemia which can occur in a non-diabetic individual due to several reasons. You will only diagnose it if you check the RBS or a glucometer RBS at that particular time when the patient has symptoms. So this patient was further evaluated to look at what is the cause for hypoglycemia. Her systemic assessment with renal function, liver function, thyroid, cortisol levels were normal. So we subjected her to a supervised fast, that is we kept her fasting and checked her RBS. And then when she went into hypoglycemia, the insulin C-peptide levels were measured, which were non-suppressed, suggesting that there is hyperinsulinic hypoglycemia. So she had increased insulin production from the body, and on imaging, she had a pancreatic mass confirmed by endoscopic ultrasound. So the diagnosis was insulinoma. So she underwent excision of the insulinoma, after which this resolution of her symptoms. So it's important, although these diagnoses are rare, it is important to be aware of this entity so that you diagnose it appropriately. So when you have these sporadic symptoms, intermittent symptoms, it's important that you check the particular values at that particular time. So yes, like I said, it's important to send these samples during that particular episode. Now moving away from hyper and hyperglycemia, let's go on to the case 3. So this is a 63-year-old lady who presented with history of insomnia, loss of interest in her routine activities, complaining of fatigability throughout the day, decreased appetite, and weight loss in 6 months. So at a single glance, it looks, I don't know if you can label it as a mood disorder or depression, but she had some symptoms suggestive of a decrease in her day-to-day activities and loss of interest and weight loss. Now, this patient on examinations, if you see, she had a BMI of 17 kg per meter square, however, did not have pallor icterus, cyanosis of clubbing. She had mild tachycardia with pulse rate of 110 per minute and fine tremors. Now, once we say fine tremors, these are not the ones which you can easily pick up, like in a Parkinson's or an essential tremors. You can only pick up if you examine the patient with the outstretched hand and probably keep a paper and see if it's moving. So this is something you have to really examine to identify. There's no goiter and no neurological deficit. So investigations, of course, it was a case of thyrotoxicosis. Now I put up, this is called as apathetic thyrotoxicosis. In a classical thyrotoxicosis, you would have patients presenting with autonomic symptoms where they complain of palpitations, sweating, they would have increased tremulousness, very obvious tremulousness, increased frequency of passing stools. But then in elderly patients, you have an entity called apathetic thyrotoxicosis where they may not exhibit autonomic symptoms and they may only come with kind of decreased sleep, loss of interest, and predominantly decreased appetite and weight loss. So this entity is something we should know in elderly so that we investigate accordingly. So in general, when we talk about thyrotoxicosis or hyperthyroidism, we know they can have a variety of neuropsychiatric symptoms like irritability, rapid speech, anger, emotional ability, nervousness, anxiety, panic-like episodes, insomnia, which are altogether summarized as hyperactivity and an anxiety state. And these symptoms can be mistakenly diagnosed as some kind of primary anxiety disorders. So thus, hypothyroidism must be excluded for patients presenting with anxiety symptoms. Of course, in like the case I presented, they can also present with symptoms similar to depression, which is known as apathetic thyrotoxicosis, and this is commonly seen in elderly. The extreme form of this would be a thyroid storm, where in addition to the exaggerated thyrotoxic symptoms, they can have systemic manifestations with respect to cardiovascular, GI, and central nervous systems. So in this extreme form, they may present severely agitated, delirious, psychosis, seizures, and coma. So, doing a thyroid function test with the background of these clinical presentations, you can diagnose this thyroid storm. It's very important to diagnose because if not diagnosed appropriately and treated, it can turn out to be fatal. Coming to the case 4. Now, so this is a 30-year-old lady who is diagnosed with a bipolar disorder. So she has a primary psychiatric disorder. So she was initially evaluated and had a normal thyroid function test, electrolytes, calcium, and glucose profile. So lithium is, I know, is one of the therapy you offer for bipolar disorder. So she was started on that, and initially she had a good response to it. Subsequently, at follow-up at 1 year down the line, she had predominant depressive symptoms. So other than doing a psychiatric assessment, checking at compliance, and doing a modification of therapy, do you have to do any endocrinological assessment in these patients? Because the initial investigations were all normal. Now, for this, the answer is that you not only have to look for another disease which a patient can have, you also have to look for the medication associated problems. Like this patient is on lithium therapy, so you know if lithium can cause any endocrinopathies. So there are several endocrinopathies which are described to be induced by lithium. Most common what we see is the lithium-induced thyroid dysfunctions. So lithium can induce both hypothyroidism and hyperthyroidism. So somebody presenting with predominant depression symptoms, you might definitely screen for hypothyroidism, and this can develop at any point of time once you start therapy. And the other thing, which is not so common, but we can still see and we must be aware of, is the PTH-dependent primary hyperparathyroidism, which can be induced with lithium because lithium kind of acts on the calcium-sensing receptors and alters the threshold. So some rarely patients can also present with hypercalcemia secondary to the hyperparathyroidism induced by lithium. And then again, nephrogenic diabetes insipidus has also been described with lithium therapy, where patients present with polyuria and nocturia. Of course, in a psychiatric patients, primary polydipsia must also be considered. But then you need to keep in mind that lithium can also induce nephrogenic diabetes insipidus, and then appropriately evaluate or refer. And then, of course, diabetes and obesity has also been linked. So the basic investigations you need to do is a thyroid profile. In addition to that, doing the electrolytes, sodium and calcium, would help in screening some of these disorders. In nephrogenic DUI, we would do a overnight water deprivation test. So when we talk about hypothyroidism, this is a common topic. I'm sure all of you are aware of it. So we know that it mimics symptoms of depression. In hypothyroidism, we know there's a generalized slowing with both mental and physical activities, easy fatigability, and reduced concentration ability. So the difference in both somatic and mental energy reduction. So there's close mimic between hypothyroidism and depression. So a clinical clue. So if there's a history of hypothyroidism or any thyroid disorders in the past, patients has undergone radioactive iodine therapy, radiation to the neck, or if you notice any thyroidectomy scar, that would be a very important clinical clue. But many of them may have Hashimoto's thyroiditis and may have none of this history. Physical examinations, of course, you would see a dry, rough skin, hoarse voice, some goiter may or may not be present, macroglossy. These are somebody with a prominent symptoms, and in children, sometimes the findings will be very subtle. The severe form of hypothyroidism, is called as myxedema madness, where patients can become obtunded, stuporous, and in the later and the severe stages may also present with confusion and coma. The patients presenting with myxedema madness has decreased drastically in the recent times because of the commonly thyroid function tests are done in most patients when they in any hospital visit. So patient presenting with myxedema madness is very rare, but this is an entity again we must remember, because again if you do not diagnose and treat, it is going to be fatal. Now, one entity I want to mention with respect to thyroid is the Hashimoto's encephalopathy, which is not that common, but many a times it may not be diagnosed appropriately. So I'm just mentioning about it. Now, it's got diagnosis of exclusion. So patients with this present with encephalopathic symptoms and can have neuropsychiatric manifestations, seizures, associated positive thyroid antibody, and most importantly, they respond to steroid therapy. Now, it is debated whether it is really associated with Hashimoto's thyroiditis or it's just a common coincidence that there are two different autoimmune diseases coexisting. But what is most persistent is that these patients have anti-TPO positivity. They can have, they may be euthyroid, subclinical hypothyroidism, and overt hypothyroidism. But most importantly, they show good response to corticosteroids. So this entity is, the correct terminology should be a corticosteroid responsive encephalopathy associated with autoimmune thyroiditis. Now, these patients present with fluctuating encephalopathy, cognitive impairment, behavioral changes, can have seizures and other involuntary movement, ataxia, and other neurological manifestations. Now, the diagnosis is, it's a diagnosis of exclusion. So you can have acute or subacute encephalopathy with fluctuating courses. You have to rule out other systemic autoimmune diseases with positive anti-TPO antibody in response to corticosteroid therapy. There is no specific diagnostic test which helps us in kind of confirming this diagnosis. So it's a diagnosis of exclusion. Imaging again may not help. You might have a non-specific changes, some white matter abnormalities and T2 cortical abnormalities. Even the functional scans, you might just see a hypoperfusion in the frontal and temporal lobe. So this is an entity which is not yet completely defined. We don't have a specific test, but it's something we must keep in our mind. So when you talk about neuropsychiatric manifestations, hypo, hyper, and Hashimoto's encephalopathy is what should come into our mind. Now moving into the next system. So, so this is our next case. Now this is something which we must keep in mind and kind of always keep in our mind in patients with refractory depression. So we have this 42-year-old lady who's diagnosed with depression for the last 5 to 6 years and has been on multiple medications, and she was labeled as refractory to treatment. Now, she also had other comorbidities. She was diabetes for 5 years, and again, she was not responding to oral drugs. She was also on insulin therapy plus the oral drugs. She was also hypertensive on antihypertensives, and she also complained on menstrual irregularities for the last 5 to 6 years and was amenorrheic for the last 1 year. So if you see and you think of your common cases, of course, she looks, you have a 42-year-old lady with depression, and she has comorbidities which could be age related. And then of course, she's 42, so she must have menstrual irregularities. So overall, if you do not thoroughly examine, it looks like a common case. But then if you examine her thoroughly, look at her face, she has this rounding of the face, call it moon face, where you're not able to see the ears from behind. She has hirsutism, that is abnormal hair growth in a male dependent area or androgen dependent areas. And then she had hyperpigmentations. To identify these hyperpigmentations, we usually ask for serial photographs. So most of our patients now have mobile phone and would have their old photographs. So we kind of go through their photographs from the past and see what is the transformation in their appearance. So if you find a significant change in terms of hyperpigmentation, hirsutism, rounding of face, so that is that's very, very important clinically. So this patient also had a striae on the abdomen. On evaluations, again, when we suspect, of course, now by this clinical descriptions, we would have already realized that she looks Cushingoid. So she's a case of Cushing's. Now, what is most important is that if you just do a cortisol like we did in this patient, if you see her 8-m cortisol, it is in the normal range. So just by doing a random cortisol, you cannot exclude or include, or you not diagnose or exclude a case of Cushing's. So if you're suspecting, it's very important that you do a screening test or refer appropriately. So you have different screening tests like 24-hour urinary samples, dexamethasone suppression test, ACTA. So it's quite complex. So it's important to at least identify that this patient probably is having hypercortisolemia and needs evaluations, because this is very, very important, because untreated hypercortisolemia, the mortality is quite high. Patients can succumb to infections or cardiovascular or vascular events, in addition to the other comorbidities they have. So if this patient then, this particular patient then underwent imaging, and there was a right-sided pituitary microadenoma, and so this was a case of Cushing's disease. So after surgery, she had significant improvement in her appearance, psychiatric symptoms, there's improvement in hypertension and diabetes, almost normalization of these parameters. So it's very, very important to diagnose. Otherwise, we'll be treating the comorbidities, but the underlying disease will continue to be there. This is another similar case of 50-year-old postmenopausal lady, again on depression, treatment for depressive symptoms for the last 1 year. She also has diabetes and osteoarthritis for the knee. And for the osteoarthritis, she's been on some native medications. So she had come to me for the treatment of type 2 diabetes. Now, one look at her, you can see that she's okay. You have an elderly lady with comorbidities. But if you actually again look carefully in the clinical examination, she also has a rounding of face, a moon face, what you call. And if you see the scapular area or the nape of the neck, there's fullness, and she has fine hairs on her face. So this is the only clinical finding she had. So this is also a Cushingoid appearance. So if you do a random cortisol, it is suppressed with the suppressed ACTH. So that suggests that she's on an exogenous. So this is a case of exogenous Cushing. So she's taking steroids. Mostly the native medication what she's taking contains steroid. So this is a case of exogenous Cushing with HP axis suppression, which can present, in addition to diabetes, can also present with psychiatric manifestations like depressive symptoms. So again, exogenous Cushing's or exogenous steroid use is very, very common. Either they might be taking it through prescribed medications, over-the-counter medications, or in any of the indigenous or native medications. So this entity is quite common, what I see in the OPD, and must be kept in mind. So moving on to a next case. So now I move, I think so far it's been mostly females. So now I move to a fairly young man, a 28-year-old gentleman who presented with intermittent headache associated with feeling of impending doom, anxiety, sweating, and palpitations. So more of like a panic attack. He had recently lost his job six months ago, and was attributing most of his symptoms to that loss and not been able to find an appropriate job. So in his routine examination, he had a normal pulse rate of 98 and a slightly abnormal blood pressure, slightly elevated blood pressure. He was evaluated elsewhere. His thyroid functions were normal. His ECG and echo was normal. And because he had this intermittent headache, an MRI brain was also done, which was normal. He was then started on attenderal again elsewhere, after which there's worsening of symptoms in terms of more frequent and severe symptoms. So to have this impending doom and anxiety episodes along with sweating and palpitations, which was occurring more frequently after starting the treatment with atenolol. So is it just panic attacks, or is there an organic pathology? So the clinical clue to suspect organic cause, you have a man who have an individual. First of all, is a man, so panic attacks. Not sure how frequent it is in men, but what I know is most frequently seen in women. But then other other clues would be that you have a patient who has an young onset hypertension. Of course, you have to confirm with BP checking on multiple other two or more times. And then he also has this triad of palpitation, headache, and sweating. Then there's worsening of his symptoms, addition of beta blocker. So there's a phenomenon called vasomotor reversal of Dale. So patients who have excess catecholamine, when you add beta blocker, there's worsening of his symptoms. So he had all these classical symptoms, which was suggestive of an underlying catecholamine excess state. So we asked for a 24-hour metanephrines and normetanephrines, which was elevated. And then on imaging, you can see above the kidney, just pointed in the arrow. So this is a left adrenal mass, which was a left adrenal pheochromocytoma. So it's important to rule out pheochromocytoma in patients presenting with episodes of profuse intermittent episodes of sweating, palpitations. Sometimes they may just present like an anxiety-like of episodes, and it's lasts only for seconds. So and then the blood pressure may also be elevated only during those episodes. So it is only if you have a high index of clinical suspicion and you screen appropriately, then you're likely to diagnose this case. So many of the times we see that the diagnosis is delayed by at least 1 or 2 years after the onset of symptoms in these patients. So it's important to know this, the triad of these symptoms or these presentations to suspect the possibility of pheochromocytoma in patients with such presentation. So that's the reason I put up this case. So moving on to our next case, So 50-year-old lady with complaints of lethargy, fatigability, again excessive sleepiness, loss of interest in day-to-day activity, again most of the times remaining to herself, complaining, looking fatigued, decreased appetite for the last 2 years. She was also evaluated and was on antidepressants. Now, so again, she presented to emergency with nausea, vomiting, drowsiness, and then seizures and loss of conscious following an episode of fever and an acute upper respiratory lower respiratory tract infections. So the family also gave history of admissions previously with hyponatremia. So this was the patient we had seen. So if you examine her, she's a dry skin and some puffiness of the face. So in the initial investigations, which is sent for emergency, you only see a low sodium. The thyroid functions, TSH was normal, her renal functions were normal, but she had severe hyponatremia. But then when we see severe hyponatremia, and then because of this loss of consciousness, a CT brain was done, which was also normal. Subsequently, we've seen this patients, we asked for other thyroid profile in view of this recurrent hyponatremia, and you can see that free T4 is very low, low cortisol, and also the other pituitary hormones were low. And then retrospectively, and then when we asked history of the when she was better after correction of sodium, she gave history of failure of lactation for her third child, and also she had not resumed her periods after her last childbirth. So that again was suggestive of hypogonadism and also absence of prolactin after delivery. So this is a case of pan-hypopituitarism and imaging. If you can see that the cella is empty, so it's a case of empty cella as a sequelae of Sheehan syndrome. So these patients again may not immediate, sometimes present immediately. They may have a slow course, and they may later, and then mostly they may present like chronic fatigue, loss of interest, and then only when there is any acute illness, they may present with severe presentations. So this is going on to our next spectrum of case. This is a common case. So a 38-year-old lady presents with intermittent episodes of panic attacks. So she presents with symptoms of sweating, intermittent episodes of sweating and palpitations. She also complains of excessive irritability, restlessness, and disturbed sleep since the last 6 to 7 months. On examination, she had a normal blood pressure. A thyroid function test is normal. Her ECG and echocardiograms were normal. Of course, looking into after hearing the previous case of the men who presented with similar episodes of sweating and palpitations, you would rule out a pheochromocytoma in this case. But before going on to that, the additional history we got was that she was having irregular cycles since the last 1 year, and the last menstrual period was 6 months ago. So in view of this history, we got an FSH done, which was clearly elevated and was in the menopausal range. So generally, when somebody at 45 or 50 years presents with these symptoms, they are easily diagnosed as vasomotor symptoms or postmenopausal symptoms. But then some of the patients can have a premature menopause, which is called as premature ovarian insufficiency. And initially, it presents kind of oligomenorrhea, and then there is a cessation of menses, like in this patient. And then again, because it was a premature thing, her menopausal symptoms could also be severe. So this was premature menopause because of the autoimmune ovarian failure, premature ovarian failure, and had vasomotor and neuropsychiatric symptoms. So these symptoms can be quite severe and disabling, and it's important. So again, why is it important to identify? It is not only just to relieve her symptoms. This patient has an early menopause. So if you do not treat them with hormone replacement therapy, then they are more likely to have accelerated bone loss, prone for osteoporosis and fractures at an early age. Again, with respect to cardiovascular health, with the overall well-being can be affected. Of course, the sexual health can be affected. So it's important to diagnose this premature menopause and then treat accordingly. And most of these patients who have this vasomotor symptoms with premature menopause, just by replacing the hormones, giving them a combination of estrogen and progesterone, relieves most of the symptoms. You do not really have to give additional symptoms for their vasomotor symptoms. So the most important thing is to diagnose these patients with premature ovarian failure. Okay, so going on to our next case. This is a 40-year-old gentleman married with a 12-year-old son who had presented with complaints of erectile dysfunction since the last 2 years. His comorbidities is also diabetes and also an oral glucose lowering agent. So considering the history of diabetes, he was thought of erectile dysfunction as a complications of diabetes and other comorbidities. So he was treated with tadalafil and also was counseled once or twice, but there was no significant improvement. So, okay, it's coming in a reverse order. So the investigations here, if you see, this patient had a significantly low testosterone and an elevated prolactin. On imaging, he had a macroprolactinoma. So this was a case of macroprolactinoma and secondary hypogonadism. Again, in men, the symptoms of prolactinoma may not be very obvious like in women, because women come with oligomenorrhea, amenorrhea, and galactorrhea. So most of the times they're diagnosed early. But men with macroprolactinoma are often diagnosed late because the manifestations may be initially just loss of libido and then erectile dysfunction. So many of these patients, men with macroprolactinoma, prolactinoma, are diagnosed often late. So it is very, very important to do a testosterone and a prolactin in every man presenting with erectile dysfunction so that you do not miss these cases. Now, again, when you diagnose these cases, we know that cases with prolactinoma you can manage medically. Whatever is the size of the tumor, they will respond very beautifully to cabergoline. Like this patient, he was just on cabergoline therapy and then subsequently titrated and is tumor free 2 years down the line. They do not need surgery also. And then if it is a microprolactinoma, just by treating the hyperprolactinemia and then kind of tumor resolutions, they'll have complete normalization of their testosterone levels and the symptoms may improve. However, if it is a macroprolactinoma and the gonadotropes are destroyed, we might have to start them on testosterone therapy. So the erectile dysfunction improves with the testosterone therapy. The main idea of putting this case here is to emphasize the fact that it is very, very important to check for prolactin and testosterone in patients with erectile dysfunctions. And also, other than prolactinoma, the most common cause of an elevated prolactin in clinical practice, what you see is the drug induced, and the commonest drug we see is the prokinetic. So commonly it is co-prescribed along with the PPI. So we see different proton pump inhibitors, that's antacids, and combination with this prokinetics like domperidone, levosulfuride. These are commonly prescribed medications, and patients also take it over the counter, and this can elevate prolactin to several folds. So we have seen patients presenting with prolactin elevated by say 10 times than the normal value, and also having this hypogonadal symptoms with this constant use of these prokinetics. Hence, it's important to have a good drug history and check for prolactin in patients presenting with erectile dysfunction. Okay, so this is my last case. So I put up all together. So this is a 34-year-old gentleman with a history of generalized clonic seizures on anti-epileptics since the last 3 years. Now, he presented with depressed mood, decreased interest in most activities, loss of appetite with 20% weight change, insomnia, fatigue, loss of concentration, and also previous thoughts of death without suicidal ideation in the last 3 months, which I think will fit into your criteria. I'm not sure the exact criteria, but suggestive of a depression. Now, the additional thing, when he was asked for specifically if he had any other additional problem, he did complain of symptoms of paresthesias involving his toes and sometimes cramping in his leg. Now, the another important history, which if again asked specifically, the patient reported was that he had undergone a subtotal thyroidectomy for thyroid nodules 5 years ago and was on thyroxine replacement. Now, on overall general physical assessment, he had no sensory and motor deficit and no significant abnormalities. But in history, with the background history of a thyroidectomy, we always check for latent signs of tetany or hypocalcemia. So his Chopsticks and Trocher signs were positive. And then I think this patient we diagnosed retrospectively in view of his symptoms and seizures. He underwent a CT. He had undergone an imaging, and in the CT brain, you can see calcifications, significant calcifications in the basal ganglia. So basal ganglia calcification is seen in patients with hypoparathyroidism. So further investigations, you can see calcium of significantly lower calcium of 5.4, elevated phosphorus, and a low PTH. So this was a case of hypoparathyroidism. Even his seizure disorder was secondary to the low calcium, and all his psychiatric manifestations was a part of hypoparathyroidism. And then you might be surprised to see that this patient, the symptoms was for 3 years and the diagnosis was missed. It happens quite often. And then again, most of the times these patients have hypocalcemic symptoms immediately after surgery, but some of them recover after 1 or 2 weeks after surgery, and they may not be on supplements. But subsequently down the line, because of the fibrosis and the vascular compromise, they can develop hypoparathyroidism in the later part of time. So it's always important to screen for hypocalcemia when patients present with these symptoms such as depression and seizure disorders, to look for hypoparathyroidism. So surgical hypoparathyroidism, and then you can also have autoimmune hypoparathyroidism. So, but just by doing a calcium, these disorders can be diagnosed. And radiologically, you can see calcifications in basal ganglia. That's again another pointer. So when we talk about parathyroid gland related neuropsychiatric manifestations, both hypo and hypercalcemia, that is hypoparathyroidism and hyperparathyroidism, can have several neuropsychiatric manifestations. So patients with hypoparathyroidism can have mental lethargy, which is called as a brain fog, sleep disturbances, anxiety, depression, and rarely psychosis. Hypoparathyroidism, we know that it presents like a bone, moan, and groan. So these patients can have depression, irritability, lack of initiatives, lack of spontaneity, delirious, psychosis, catatonia, lethargy, and with severe hypocalcemia, they can also present with, they can also become comatose. So all we have to do to diagnose is to just check a serum calcium with an albumin and a phosphorus. So if you have an elevated corrected calcium, only then you do a PTH. So it's simple to diagnose, but suspecting is most important. So I took you through some of these cases involving different endocrine system, where we spoke initially about hypoglycemia, hypoglycemia, thyroid disorders, apathetic thyrotoxicosis, lithium-induced endocrinopathies, and then insulinoma. And then we also spoke about pheochromocytoma presenting with panic-like attacks, premature menopause, ovarian insufficiency related symptoms, and then hypogonadism, again, hyperprolactinemia related erectile dysfunction. So you can have different psychiatric manifestations. I've only presented some of them. So when you talk about assessment, it is very, very important to take a detailed history. Look for comorbidities. Many of the patients will have other comorbidities. Try to link and see if it is related to the disease, whether you can put all the symptomatology under a single diagnosis. Sometimes it could also be a secondary to the therapies the patient is receiving. So look for it. Take a detailed medication history, take a family history, and then pay attention to his clinical examinations. Most of them will have some altered vital signs like tachycardia. You think of thyrotoxicosis, a dry skin, bradycardia. You think of hypothyroidism. So and then elevated blood pressure in young with panic symptoms. You think of pheochromocytoma. So keeping a check on the vital sign and kind of correlating is important. General physical examination is very, very important. Overall appearance of the patients can give a clue to the endocrine diagnosis. So, most of these endocrinopathies can have some psychiatric manifestations like a present. They can have different mood disorders, depression being the most common. Again, in some of these patients with diabetes, you can have eating disorders and then etc. Commonly you get psychiatric manifestations in endocrinopathies. So I would like to conclude that endocrinopathies must be considered in the differential diagnosis of neuropsychiatric manifestations. Now, identifying them is important because most of the endocrinopathies are completely reversible if you identify and diagnosing. So the difficult part is identifying and diagnosing that this particular patient is probably having his endocrinopathies. Commonly, we do thyroid function tests, so thyroid disorders are not missed so often, but the rest of the endocrinopathies may be missed if we do not put together the signs and symptoms and consider. So once you recognize that they have a very dramatic recovery, the outcomes are going to be very good. On the contrary, if you miss the diagnosis, not only going to have poor response in terms of the psychiatric problem they're coming, but also in terms of the other systemic manifestations they can have and the disease-related morbidity and mortality. So sometimes some of the basic investigations like glucose, sodium, potassium, calcium, TSH, T4, and cortisol is all that is needed for us to kind of suspect that the patient is having an endocrine disorder. So thank you. I would be happy to take up questions. I'll just chat. So there's some questions. 15. Okay. So I have a question from Dr. Sheba. So the question is, long-term use of lithium for stabilization of mental symptoms with TFT abnormalities. Would you recommend stopping it or any other monitoring? So yeah, thyroid dysfunctions, lithium, like I said, is quite common. But then I mean, as far as my understanding of the psychiatric disorder goes, I think lithium is a very important modality of treatment for these patients. And on the contrary, it is very easy to treat hypothyroidism. You just have to do a thyroxine replacement. So if the patient needs lithium therapy, we would not advise them to discontinue that. We just would consider treating the underlying thyroid dysfunctions. However, if you're able to switch out to another therapy, then that is okay. But otherwise, it's not mandatory to stop or change the line of treatment you're following. And would you recommend any other monitoring? Yeah, like I said, there are certain endocrinopathies which are associated with lithium, but monitoring as such may not be required. Of course, you would do a metabolic monitoring in terms of the diabetes lipid profile. Calcium can be done specifically if you have symptoms such as hypoparathyroidism, severe bony pains, proximal muscle weakness, somebody coming with renal calculi. Of course, we would look for hypoparathyroidism, but that could predominantly be symptom based. Even nephrogenic DI is not common, it's very, very rare. So only those patients who have symptoms of nocturia, polyuria, we would screen for this. These abnormalities. Otherwise, the routine monitoring would only include a thyroid function, sugars, and lipid profile. Of course, the weight monitoring. So, yes, the next question is, mostly we come across the thyroid dysfunction as incidental finding in patients with depression. Among them, when and for whom TPO antibody test should be done? Also, is there a role of treatment with steroid for autoimmune thyroid disorders? Okay, so there are 3 questions here. Okay, so yeah, so for patients, if you have a subclinical hypothyroid state, now it's difficult to say if the disease, thyroid dysfunction, is causing the symptom. But then in patients with significant depression or on therapy and even borderline thyroid dysfunctions or subclinical, we do consider therapy because there are enough clinical literature showing that supplementing with thyroid does help them in terms of their depressive symptoms. And then antibody testing. So suppose if you have a patient who has a kind of hypothyroidism which is proven beyond doubt, then we do not do TPO antibody. But in patients with subclinical stages, we can do antibody and then kind of look at the underlying diagnosis. So those with significantly elevated antibody, the chances of them converting from a subclinical to overt hypothyroidism is high. So in that way, it would be helpful. But otherwise, somebody who has kind of a severe hypothyroidism proven on therapy, there's not much role of a TPO antibody. And the role of treatment with steroids for autoimmune thyroid disorders is, I think, the third part of the question. So yeah, so theoretically, if you look, it is an autoimmune disease, so steroids may help. But then if you look at the risk versus benefit ratio, giving thyroxine would be much simpler and easier than giving steroids. So we do not give steroids for treatment of autoimmune thyroid disorders. So, okay, so the next question is, for treatment of rare genetic disorder, is LT3 available in market? LT3 is actually available, but it is not available in most of the places. In some of the places it is available, but there is a preparation of oral LT3 which is available, and we have used a patient when there is emergencies in perioperative preparations and all, but it is not commonly available in most places. So another question is it advisable to ask for free T3, free T4, or most people can be diagnosed by simple T3 and T4? Okay, so yeah, out of this, first of all, T3 is not required for diagnosis of thyroid disorders, especially hypothyroidism. TSH for primary hypothyroidism, if you're suspecting the abnormalities in the thyroid gland, TSH is enough in most of the cases. But if you're suspecting a central hypothyroidism, in that cases, the TSH may be normal, but only their central hormones, the thyroid hormones, will be low. So in those cases, you would require a free T4. So if you want to ask me what is this test you want to do, so kind of rule out the thyroid disorders in your patient. So you have to do a TSH and a free T4. So only these 2 tests is enough. If you think, suppose you do not have a free T4, then you can do a total T4. Now again, T3 definitely is not needed. if you can either do a total T4 or a free T4. Now, free T4 would be preferred in certain situations where patient has other diseases and you suspect that the albumins, the binding, see, total is, it's a thyroxine which is bound to the albumin and other thyroxine, albumin and other binding proteins, whereas free T4 is the free hormone which is available, right? So if you have some underlying conditions which are which may influence this binding protein, then free T4 is more accurate. So if you have a good lab which can give you free T4 reports, then just ask for TSH and free T4. That is all which is required and will cover most of the thyroid disorders. If it is not available, ask for a TSH and a total T4. Should I continue or? Okay. Is it 16?
Thank you, ma'am, for that practical and enlightening session. I now request Dr. Samir.
Okay. I think they want me to answer one more question. Etiology of, okay. Okay, so there's a question by asking etiology of premature ovarian failure. Yeah, so premature ovarian failure, there's several reasons for premature ovarian failure, but the commonest cause would be an autoimmune ovarian failure, just like Hashimoto's thyroiditis, and you have this thyroid dysfunction. Similarly, there can be something called autoimmune euphoritis. So these patients can have a premature menopause. So commonly we see that is the cause, but in addition to this, we can also have other causes like Mosaic-Turner syndrome, can also initially have regular cycles, and some of them can even conceive and later have a premature menopause. And then you have some rare genetic disorders which can also have a premature menopause. But common etiology would be the premature, that is autoimmune euphoritis or autoimmune ovarian failure. Sometimes patients have this, they can have underlying pituitary disorders which could cause oligomenorrhea and amenorrhea. This is also something we must consider. So doing an FSH alone helps us to know whether it is really an ovarian problem or a pituitary problem, but just do an FSH and see what is the condition. If FSH is clearly elevated, then that suggests early menopause and you have to treat accordingly. So yeah, and this again, I would like to thank the organizers for inviting me. Thank you.
Thank you, ma'am, for the practical and enlightening session. I now request Dr. Samir Kumar Praharaj, Professor and Head of the Department of Psychiatry, to present a memento to Dr. Sahana Shetty as a token of gratitude.
Thank you. Okay.
Next, we'll be moving on to the postgraduate quiz screening round. The quiz will be conducted by Dr. Rajesh Krishna Bandari, Assistant Professor, Department of Psychiatry, Kasturba Medical College, Manipal, and Mrs. Anaga Deshmukh, Assistant Professor, Department of Clinical Psychology, Manipal College of Health Professionals. The quiz will begin at 12:10 p.m.
Good afternoon, everybody. Now we have the quiz prelims. Please note that it's only for postgraduate students. We'll be starting the quiz at around 12:10 as per schedule. Instructions will be given again by Dr. Rajesh Krishna Mandari and Mrs. Anaga Deshmukh at 12:10 p.m. Thank you.
Good afternoon, all PGs. So very welcome to the PG quiz prelims. So this quiz has been a tradition of the psychiatry update CMEs from our department right from the beginning. So this mainly to encourage the students to start reading about the particular theme, also get familiarized with the theme, some trivia about it, etc. So we have two rounds in this whole quiz scenario. One is the prelims part, and the second one is the finals. So some of you, those who have gone through the quiz instructions, so you might, some of you might find it a little tricky as to how to respond in such short time, how to navigate between the windows, etc. So I'm going to give an initial instruction which is going to help you as to to respond to these quiz prelims. So from the quiz prelims, 5 toppers will be selected. Basically based on the highest mark scoring, and in case there is a tie, the person who has submitted, so there's a submit button at the end of the prelims. So once you submit, whoever is submitted earlier will get the priority or gets the topper position. So I'll begin with the instructions for you about the prelims. So the Google form is not yet activated for you, so don't panic about it. So it will be activated shortly once you listen through these instructions. Yeah, so fill in the initial details, including email ID, name, course, college details, and mobile number, because we'll be contacting you over phone and sending the email link for tomorrow's, those who are the toppers. There are 25 questions, 20 with 1 marks each, and 5 questions with 2 marks each. No negative marking. So if somebody wants to take a guess, you can, But remember, you will also have to be ready for the final quiz. Each questions will be displayed for only 15 seconds, so you have to be very quick. This is in order to prevent any foul play, so that somebody should not go for Google search and try to get answers. So this is the reason for it. So we have tested it and found that 15 seconds is something which is most appropriate to ensure that the choices are made quickly. The answers are to be ticked as A, B, C, or D. So there are no options. The choices are not actually displayed on the Google form. You have only option A, B, C, or D. So you will have to look at the video screen, the live video, and on the other side, you'll have to keep ticking the answer. So it means you'll have to switch between Google form window and the Zoom player or the webinar link to play this quiz. So like mentioned earlier, in case of a tie, the person who submitted the form earlier will be considered for the final round. So trying to give some explanations on how to go about this. So this is your digital platform. So you would have logged into this and you are viewing the screen now. So there is a section called this quiz prelims on the right hand side. And you can click open link in new window. Don't open link in new tab, but new window. This is important because it becomes easy to toggle between the two screens. That is one of the option for you. So if you open the quiz prelims, this is how you will see. So right now it is not yet accepting the responses, so you'll get only this particular message. So if you are using the Alt and Tab button, you can use this. So you will see both screens and you can keep toggling between it and view it as full screens. The alternative method is, so you look at this section and look here, there's a restore button, a restore down. So this will help you smaller the size of the window. So then you can use this arrow button that you will get and shorten it and make it half the screen. Similarly, once you open the quiz prelims form, you can use the same restore down or make it smaller and make it use the arrow and shorten it and place it such that on one side of the screen you can see the webinar live, and the other half of it you can see the Google form. So you can quickly look at the questions and answers on choices on this particular left hand side, and the right hand side you can quickly do the scoring. So I hope you are ready. I'll give you a minute time to just keep these screenshots, everything ready. Okay. Mute. Yeah, hopefully you have kept the screens ready in this format. So I understand that there may be a little lag time between when I'm speaking and when you are actually able to hear. So don't worry. We have ensured that there is a live display of what is actually being viewed by others at this point of time. and the forms, etc., will be closed only after the live video stops. Okay. So you are now ready to begin. Be honest, stay alert, and be quick in responding. The Google form is now being activated. So once it is activated, you can press the refresh button for the form. So that time you can start seeing the entry details. So you can begin entering the details of email, name, course, that is whether you are a DPM or a MD psychiatry course, or if you are from other specialty, you can specify so. The college details, including the place where your college is, and of course your mobile number, because we will be contacting you directly to give further information on if at all you are selected to the finals. There is also a disclaimer which says the possible limitations of having these kind of quiz sessions on an online platform. So we have tried our best to ensure that the possibility of cheating is kept at a minimal or possibly nil because of the very short time frame. So we request you all to choose that I agree after you read through that and then move to the general section. So you'll get roughly 3 minutes to fill the initial details and be ready before the actual quiz starts. So the Google form is now activated. So you can start filling the details of the first page, read through the disclaimer and be ready. Once the questions start, the quiz master will not be reading any of the questions, but just pointing out that there is a change that by just saying next. Once you have entered the details and you have pressed I agree, you will go to a page called general section. So this basically tells instructions about the number of questions that are there and time you get. So you can read those 3 instructions and wait on the first question page. I'll be reading the general instructions again here before actually beginning with the first question. So you can be ready by that time. So I'll be giving the instructions now. So the general section, there are 20 questions here. Each correct answer gets 1 mark. No negative marks. 15 seconds to read and select the answer. Press the next button once you select the answer in the Google form. The question on the webinar window will change automatically. So ready, we'll start. First question. Second question. Third question. Question 4. Question 5. Question 6. Question 7. Question 8. Question 9. Question 10. Question 11. Question 12. Question 13. Question 14. Question 15. Question 16. Question 17. Question 18. Question 19. Question 20. So now the achiever section begins. 5 questions in this section. Each question carries 2 marks. Again, time per question is 15 seconds only. So be ready. Start. Question 21. Question 22. Question 23. Question 24. Question 25. So the end of the quiz, you have only 15 seconds left to submit the response, after which the response will get closed. We'll be closing the response now, so you may no longer be able to submit. We will review the questions again in about a couple of minutes for knowing the answers. So please be online. We'll join in about 2 or 3 minutes. There you can be. Yeah. Yeah, thank you for waiting. So we'll just go to the answer section. So this question 1 in TRH stimulation test, TRH infusion test. So the answer is B, exaggerated. This question 2, Rotterdam criteria is used in the diagnosis of PCOS or the polycystic ovarian syndrome. Question 3, so which out of these antipsychotics has relatively the least risk of raising prolactin? So the answer is B, acinapin here. Higher levels of which of the following hormones is likely to promote sleep? So this is a straightforward one. Answer is melatonin. Look, cortisol, thyroid, everything is lowest at the night. And adrenaline, you know, will only stimulate. Question 5. It's estimated that dash percentage of patients treated with lithium develop hypothyroidism and up to dash percent may develop a goiter. The answer is 20% and 50%. 20% develop hypo and 50% goiter. Question 6, reboxetine beta histidine combination has been tried as treatment for antipsychotic induced. The answer is A, weight gain. Features of metabolic syndrome includes all except, so abdominal obesity is one of the marker, low HDL levels, insulin resistance. So the answer is low vitamin D levels. We know that vitamin D levels may be lower, but it is not one of the actual features for the metabolic syndrome. Question 8, suggested mechanism of antipsychotic induced weight gain are all except, so all of them are there except that the A, 5-HT2C, it is antagonism, not agonism, which is responsible. So Ferriman-Galway scoring system is used in the assessment of, so answer is B, hirsutism. So thyroid hormones are present in different concentration in the body. What is the ratio of T4 to T3 in the brain? So, so basically T3, T4 ratio is generally higher than that of serum levels. Whereas in the serum, it is T3 is lower and T4 is higher. Question 11, common early psychiatric manifestations of Cushing syndrome are hypersensitivity to stimuli and emotional lability. So this is the answer. In which of the following endocrine conditions is anxiety symptoms relatively less likely to occur? So technically all of them can present with anxiety symptoms. Most often thyrotoxicosis, hypoglycemic and pheochromocytoma invariably have anxiety ones. Hypothyroidism more of depression. A diagnosis of adrenocortical insufficiency is made primarily on the basis of plasma cortisol measures during the DASH test. So the answer is ACTH stimulation test. Which of the following drugs is known to cause hypothyroidism? So we are all familiar with lithium. Technically, amiodarone, methimazole, all of them can lead to hypothyroidism. Which medication in doses of 2.5 to 5 milligram twice a day or thrice a day is effective treatment for hyperprolactinemia? So answer is A, bromocriptine. Okay, so you may begin at lower doses but reach higher doses later on. Question 16. Among the following antidepressant, which of them has the least risk of causing sexual dysfunction? So answer is bupropion. Question 17, a micronutrient essential in the conversion of thyroxine to threonine or T3, T4 to T3 is selenium. Metformin treatment has been found to increase the risk of DASH deficiency. So answer is vitamin B12 deficiency. Women on which mood stabilizer developed polycystic ovarian syndrome in up to 10.5% during treatment. So the answer is valproate. So in NCEP ATP3 criteria, a definition according to them, one of the criteria for metabolic syndrome is waist circumference over 40 inches for men or 35 inches for women. So this is the answer. So in the achievers section, they are a little tougher and not easy to get as information. Which of the following tests is most useful in confirming menopause in a lady who has missed her cycles for a year? So it's the FSH levels. Even though we know that estrogen, progesterone levels are lower, so the actual confirmation is through the FSH levels. Question 22, social communication deficits associated with autism is linked to which hormones? So the answer is oxytocin and vasopressin. In the study trial, thyroid supplements was added at which level and as what agent? So the answer here is level 3 as an augment to antidepressant. So it was an augment strategy and at level 3. So along with one side was the lithium. QRIS 3 is a tool upgraded to also include DASH factors to assess DASH risk. So answer here is mental illness factors to assess cardiovascular risk. So in this, even the antipsychotic usage is added. As per the Meteor study, which disorder was more common among those prescribed first generation antipsychotics as compared to those getting second generation antipsychotics? So the answer is hypertension, whereas the others were more common with second generation. So that's it. We have been able to get 5 finalists. Okay, the 5 finalists are Dr. Ankit Dangi from AFMC Pune, Dr. Vaibhavi PS from SSIMS and RC Davangere, Dr. Swapnil G. Nigam from KMC Manipal, Dr. Sri Chaitanya Voroganti from Chettinad Hospital and Research Institute, and Dr. Yashwant MH from Case Hegde Medical Academy, Mangalore. So you 5 have reached the top score in this session, and you will be getting a separate email and a call to confirm your participation. So yeah, so there was one actually tie with one person. So the fastest one has been selected as the topper as compared to the other one. So I think we may be, this quiz prelim session is over now, and we wait for the organizers to announce about the afternoon session and which is basically the poster and the award paper sessions. Over to the organizers.
The next session will be award paper session, which will start at 2 o'clock. So I request all the students who are taking part in the award paper session to log in by 1:45 p.m. So we'll meet at 1:45 p.m. Thank you.
पापा ने PhD क्यों बनाई, तो पापा का सिलेक्शन हुआ है 8 में।
not live.
If I'm stuck, I will call you. What I have to do now? Vishwa, what I have to do now?
Dr. Galgali?
Yes. Hello.
Hello, sir. Welcome, sir.
Yeah.
We are just waiting for all the students also to join.
Okay.
So you can just give a few instructions and then we can start at sharp 2 o'clock, sir. The first presenter
Okay.
can start at 2.
Okay.
So,
Am I audible clearly?
yes, sir.
You're able to see me on the screen?
No, sir. You'll have to switch on your video, sir.
Okay, 1 minute. I will try.
Thank you, sir. Yes, sir.
Yeah.
We can see the video. Thank you, sir.
Thank you.
We'll just wait for Dr. Hema Tharoor also to join. I'll just call her and come.
Okay.
Good afternoon, everyone. Today we'll be moving on to the next segment of the day, which is the much awaited poster and paper presentation. We will begin first with the paper presentation and then followed by the posters. There are a total of 8 paper and 8 poster presentations, and the award for both of these will be declared at the valedictory program tomorrow. The judges for the current paper presentation are Dr. R.B. Gargari, who has retired as the head of department and professor of psychiatry at St. John's Hospital Medical College in Bengaluru, and who has also been an alumnus of KMC. We also have with us Dr. Hema Tharoor, senior consultant psychiatrist at SCARF, Chennai. Thank you, ma'am and sir, for joining us. So we will begin with the first presentation, which is Dr. Kalai Selvi. You may upload your PPT.
Okay. Are you able to see my PPT now?
Yes, it's visible. No. Yes, now.
Okay, I'm starting now, ma'am. Good afternoon. My topic is cross-sectional study on decision-making capacity for advanced directive and nominated representative in patients with schizophrenia. Decision-making capacity is to settle on contemplated and educated choices in identifying with self-care, monetary, and legitimate issues. Every person, including a person with mental illness, shall be considered to have capacity to make decisions. A meta-analysis done by E.D. Studman showed that about half of schizophrenia patients were capable to make decisions. A few studies showed that schizophrenia patients didn't perform adequately in contrast to general population and patients with other mental illness on choices in regards to their treatment. A study conducted in CMC Vellore assessing comprehension and recall of key information in psychiatric patients and their caregivers using information sheets clinically and also using a tool for assessing capacity, no one fulfilled the stringent competence criteria. Hence, the study focuses on assessing capacity by using two means, which is a tool and clinically. The objectives are to assess the decision-making capacity for advanced directive and nominated representative of patients of schizophrenia clinically using Indian Psychiatric Society's guidance document and also using a tool which is MacArthur Competence Assessment Tool for Clinical Research and to assess the factors affecting decision-making capacity. The study design is a cross-sectional study and the study was conducted over 6 months period and it included 96 patients and it was conducted in Department of Psychiatry, Chettinad Hospital and Research Institute. It included all patients aged between 18 to 59 years with a diagnosis of schizophrenia according to ICD-10 diagnostic criteria. It included both inpatients and outpatients who were cooperative and who didn't have any acute symptoms. We excluded patients with other psychiatric conditions, mental retardation, neurological disorders, nicotine dependence, and benzodiazepine use. MacArthur Competence Assessment Tool for Clinical Research is a semi-structured tool which has a scoring criteria. 4-component abilities of decisional capacity are there, which are understanding, appreciation, reasoning, and choice. Many other studies done in other parts of the world have used that if a person scores 20 or more than 20 in understanding scale, they are said to be competent. Indian Psychiatric Society's guidance document is a semi-structured assessment format which has 3 components, namely understanding, appreciation, and choice. Here in the study, a person who scores more than or equal to 20 in understanding scale and MCAT-CR and is also found to have capacity clinically will be considered to have decision-making capacity. The patients were recruited after obtaining informed written consent from them and their caregiver. Then the socio-demographic data and clinical parameters were assessed using semi-structured pro forma. Then the symptom severity was assessed using positive and negative symptom scale. Then their cognitive functions, namely working memory, processing speed, and visual motor integration skills were assessed using Wechsler Adult Intelligence Digit Span Test, Digit Symbol Substitution Test, and Bender Gestalt Test. Details about their illness, treatment options available, concept of advanced directive and nominated representative was explained. Then their decision-making capacity was assessed using MCAT-CR, which took around 15 minutes, and clinically using IPS guidance document, which took around 30 to 45 minutes by 2 independent psychiatrists. Then the results were calculated using appropriate statistical methods. Clinically, 43.8% had capacity, and using MCAT-CR, 61.4% had capacity. All patients who were found to have capacity by clinical assessment using IPS guidance document were found to have capacity in MECAT-CR, whereas few patients who qualified to have capacity in MECAT-CR lacked capacity clinically. This table presents a comparison of socio-demographic variables among groups with and without capacity. Here, the occupation and residence varied significantly among the groups. Here, more the number of unemployed patients and more patients who lived in rural areas lacked capacity. This table presents a comparison of clinical characteristics among the groups. Here, patients with more duration of illness and those who had more positive, negative, and total PANSS score lacked capacity, and those who had more cognitive decline lacked capacity. This table presents the factors affecting decision-making capacity. Here, the Bonferroni p-corrected value was obtained because it had multiple parameters. It was found that male gender, unemployment, and cognitive decline were found to affect capacity. This study suggested that lack of decision capacity to make advance directive and nominated representative is common, yet in no way inevitable among psychiatric patients. And when compared with other study which showed 51% of schizophrenia patients had decision-making capacity to participate in research and 31% of them had capacity for treatment. This difference could be due to the fact that decision-making capacity is task-specific. And in our study, MECAT-CR assessment was less stringent, whereas clinical assessment using IPS guidance document was up to intermediate level. A study conducted in India on assessment of capacity by both clinical means and using MECAT-CR reported that among 3 patients, 2 of them had capacity clinically, whereas no one had capacity in MECAT-CR assessment. This could be due to the fact that they have kept the criteria that if a patient scores more than 75% in all the 4 domains, then only they have capacity. Moving on to the factors affecting decision-making capacity, when compared to other studies, in our studies, male gender, unemployment, and cognitive decline were the factors affecting capacity. It was different that male gender was affecting capacity compared to other studies. It might be due to the fact that our study had more number of males and among them more had symptom severity was more when compared to females. We have few limitations like the results are not generalizable as it was conducted in tertiary healthcare center which had no patients without any formal education, and this study is not doesn't consider a control group. Then the MECAT-CR tool which was used is not validated in India, and there could also be possibility of selection bias due to the convenient sampling technique which was used. And to conclude, the study shows that person with schizophrenia also has decision-making capacity to make advance directive and choose nominated representative. And in India, as per Mental Health Care Act 2017, psychiatrists can routinely include assessment of decision-making capacity using MECAT-CR understanding component as a screening tool, which can be followed by clinical assessment. And these are my references. Thank you.
Thank you. Now I request the judges to take over for the discussion.
Dr. Hema, you can start.
Okay. Kalai Selvi, thank you. I thought the speed was a little fast. But otherwise it's a nice study. Only thing was, I was wondering, this 80 into 59 and all, I mean, was there any tool to also look at in terms of, did you look at cognitive and at 59, 60 and all? I think why such a wide age group?
Age group, ma'am, like I didn't include the pediatric age group and
I meant the 60, nearly at 60 years you had taken people, so that's why I'm asking.
Up to 59
so was
considered.
Your MACAT, does it include anything for on the 4 domains? Is there anything for looks at cognition also, or just understanding the
just
tool?
Understanding, ma'am. No, cognition was not there, ma'am. Only the understanding ability, how they comprehend.
Okay. My only point here is, see, there's a very significant paper even published from SCARF where we looked at psychiatric advanced statement, and in fact the findings are totally
Kumar
opposite.
sir had done.
Dr. Ramesh and group, we did it, and In fact, 112 patients and the 93 who completed, in fact, the people with longer duration were clearly able to write a PA statement. There was the people from rural were able to say where they wanted to get admitted, and in fact, we looked at the feasibility of a psychiatric advance statement. Um, in fact, it's a significant paper even quoted in the new Mental Health Act. So I was a little surprised that it was not mentioned in your review and it didn't come up in your discussion and when you have quoted the articles. So since you have recommended in your conclusion about using the NACAD tool, I was just wondering how this paper was missed. That's all I'm asking.
I've included that study which was done by Kumar et al. Sir, which said that among 123 patient psychosis patient, 96 of them had capacity to make an advance directive. The difference might have been both. I have looked for advance directive and nominated representative. Might be the difference could have arisen because of both the components which I
I'm
looked.
saying maybe it would have, just for the audience also, that it's a very significant work done which highlights that, and the findings are totally in contrast. So that's why I'm asking to explain. See, when your population is pretty similar, where you have said longer duration could not, but here in our findings, we felt that people with longer duration and severity were able to, independent of the illness, were able to make advanced statements, a psychiatric advanced statement. So the findings are in total contrast. So it will be worth looking why the difference exists, I'm saying.
Okay,
So is it also, see, sometimes in studies like this, it matters what tools you take. See, ours was a feasibility study and people were just asked to write. They could write. But the moment you bring in a structured tool in to measure, and then when you do the regression and the analysis and then you interpret data, the findings are different, is what I'm saying. So maybe it's worthwhile looking into when people, examine the findings like that, because population pretty similar from Chennai and Vellore. I can't think of any other, but I think in terms of, we just ask them all to write a statement about what they would like to do as far as advanced treatment is concerned. And vis-a-vis, when you do a tool to measure understanding and all the 4 domains you said to assess decision making, and then and then when you correlate with their severity, maybe your findings are different as well. So it would be nice if you look back and see if the same group, since you're there,
Yes, ma'am.
they all could probably, so in a study like this, if you could incorporate, if you didn't do a tool to assess like this, if you say 4 domains and you make a structured assessment vis-a-vis, you can do it parallelly. Ask them to write down what they would like as an advanced directive and see the findings. Is my comment as well.
Okay. Thank you.
Since this is a competitive kind of a presentation, only questions, then any appreciation I will do, or I will give any suggestions. My one question on this presentation is, suppose I am a clinician, I am treating patients. What is your advice based on the implication or findings of your study? And suppose I'm a magistrate, what is your advice? Because this is something to do with advanced directive and it has both clinical application as well as legality.
Yes, sir. Legal thing is totally separate, sir. That will be, the assessment will be done, which they do is different, and they use a different term known as competence. We don't use such term as competence, and we do say just whether the patient has decision making capacity or not based upon our interview with the patient clinically.
A disagreement between the competency you decide and the competency they decide.
Yes, sir. It might differ based on the task, one thing, and also the person who do assess, and for the reason they assess, sir. It might differ, sir.
Okay, that's all. Thank you.
Thank you, sir.
Okay. Thank you for your presentation. Just a quick instruction. We'll have a presentation of 7 minutes, followed by a discussion time for 2 minutes, so that we can have an equal and fair chance for everybody.
And we'll finish by 3:30 p.m. So 7 minutes for presentation and 2 minutes for questions. So next
presenter, we have Dr. Rashmi. Rashmi, please upload your slide.
Yes, ma'am, I have uploaded.
Your time starts now.
Yeah, my topic is on understanding pattern of theory of mind acquisition in Indian preschoolers, a cross-sectional study. Co-authors are Shripati M. Bhatt, Avinash Kamath, and Nita Thomas. So coming to the definition of theory of mind, it is the ability to represent, conceptualize, and reason about others' mental states. And the components of theory of mind used in my study are diverse desire, diverse belief, knowledge access, false belief, and hidden emotion. Theory of mind abilities develop as the children grow, especially in the early childhood. And there is also a distinct order in which theory of mind skills are developed. And also there are various factors influencing the theory of mind. There are age, gender, number of siblings, number of adults, family size, and socioeconomic status, culture, as well as language. Now coming to the previous researchers done on theory of mind, in USA and Australia, it has shows that diverse desire was acquired first, later comes the belief, then comes the knowledge access, then later false belief and hidden emotion. Whereas research done on China and Turkey shows that diverse desire comes first, then knowledge access comes, then diverse belief, false belief, and hidden emotion. So we are doing this study to see the pattern of acquisition in Indian preschoolers. So the main aim is the study of pattern of acquisition of theory of mind in Indian preschoolers. Study design is a cross-sectional, community-based study conducted in Anganwadis and preschools in Udupi and Shimoga taluks. Participants are 118 children aged 3 to 6 years, selected using stratified cluster sampling. Study period is 14 months. Inclusion criteria are children aged between 3 to 6 years were recruited from preschool and Anganwadi, and their parents were able to read and write Kannada or English. And children with known history of significant sensory or neurocognitive impairment were excluded, and ethical consideration like written informed consent from the parents were taken. Coming to methodology, in a semi-structured performer, I looked for socioeconomic status, number of siblings, and family size. And the scales, I administered Wellman and Liu theory of mind scale, which is translated and adapted to Kannada by myself. And statistical analysis like descriptive statistics, chi-square test, and Gutman analysis was done. So these are the tasks I made children to do, and from that I came to know the theory of mind acquisition in each of them. Coming to the results, so in 36 to 48 months age group, there are 36% students, and 49 to 60 month age group, there are 20% students, and 61 to 72 months, there are 43%, and both female and male children equal in number. And the children from rural background were more, and the children from nuclear family were more compared to joint family, and children who have one sibling were more compared to 2 or 3 siblings. And place of interview, preschool was majoritarily interviewed. Coming to the representation of the graph of theory of mind acquisition across the different age categories. So here this graph represents that the proportion of children who are able to acquire maximum of theory of mind is more in older age groups, whereas the initial tasks like diverse desire, diverse belief, and knowledge access were acquired in the initial age categories. Coming to the chi-square test, which has been done to see the significance between the age groups as well as the theory of mind domains. And there was a significant difference between the different age categories among the category A, category B, and category C age groups. And the effect size of age on diverse desire was 0.33, and effect size of age on diverse belief was 0.246. Effect size of age on knowledge access was 0.574. And effect size of age on executive false belief is 0.64, and the effect size of age on content false belief is 0.70, and effect size of age on hidden emotion was 0.468. So Gutman's scaleogram analysis was used to see the Wellman and Liu theory of scale understanding. So Gutman scaleogram arranges the items in increasing order of difficulty in such a way that if a person can answer an item, if he or she will be able to answer all the items before which are easier than the index item. So here the Gutman scaleogram analysis for the current study yielded a coefficient of reproducibility of 0.95 and index of consistency of 0.61, which indicates a significant scalability. And the order of acquisition in Indian preschoolers showed that diverse desire was acquired earlier compared to belief, then comes the knowledge access, then explicit false belief, later content false belief, and hidden emotion was acquired. Coming to the first table, that is the number of participants who passed the item. So maximum number of children were able to answer the diverse desire task compared to the hidden emotion task. And the second table represents the participant not conforming to the scaleogram order. That is, they were able to answer the second question, but not able to answer the first question. So that number has been displayed in the table 2. Now coming to the discussion. So there are different patterns of theory of mind acquisition is seen in studies from Western individualistic countries like USA, Australia, and studies from collectivistic countries like China and Turkey. So this has led to the universality without uniformity hypothesis in the theory of mind development. And also children's theory of mind understanding reflect a mix of universality emerging in a cultural specific ones. And also reasons for the lack of uniformity in the pattern of theory of mind development may be due to different socioeconomic cultures and language background of the children. So current study results show the role of age highlights the predominant development of the theory of mind, and also acquisition order was similar to the studies from USA, Australia, but different from China and Turkey findings. So the possible reasons for the current study may be understanding cognitive representation mental states such as belief and knowledge was maybe harder than the understanding non-cognitive states such as desires. So therefore the children were able to answer the diverse desire task more earlier. And also children actively learned ideas and values in the context of socialization practices between the families and communities. So the early adult and child conversation influences the theory of mind understanding in the children. And also culture specific functionality might have led to a need of developing understanding of theory of mind ability than the other factors. And also the changing family structures in Indian homes and more bilingual households might have led to the pattern of acquisition of theory of mind as well. So coming to the conclusion and future direction. So the universal pattern of theory of mind acquisition is there, and also uniformity with the Western studies have been seen. So the current study has used the age appropriate theory of mind tasks which are adapted to Kannada. The main limitation include a small sample size and single order of presenting of theory of mind tasks was seen. The future study should explore more regarding the longitudinal development of theory of mind. And also future study should focus on the role of language. There may be one possible hypothesis for different between across cultures linguistic differences. For example, emphasis of verbs and nouns are different between Indo-European and Sino-Tibetan language and Mongolian languages. So current study was taken predominantly from Kannada language, which is a Dravidian language, which is also influenced by the Sanskrit. These are my references.
Thank you, Dr. Rashmi.
Alternatively, I will ask and then now and then Dr. Hema. And see, this is, you said language and cultural aspects do influence, but at the same time, you said there is a universality.
Universality and the age group. Yes.
Universality in the age group.
Okay. Yeah, age and theory of mind is universal, but the
well,
uniformity is different among the different cultures.
Second question is 3 to 4 years group is different, then 5 to 6 years group is different in your findings. Since this is a dynamic, it keeps changing every year. So how to, what is your suggestion for people who do research in this field?
So yeah, that's what age is the main criteria which is involved in the theory of mind. So
do you suggest that it should be a narrow range like 3 to 4?
No, it should not be a narrow range. It should be a broad range actually. Some children might acquire the diverse desire easiest as
one more question, last question. Since there is a recent educational policy, the national education policy is there. Suppose I am a teacher and you are presenting this to a group of teachers. So what is the message I should take home?
So yeah, the understanding ability of the different children will be different. So we cannot think every children can learn the similar aspect and make them.
That as a teacher, I already know that. That as a teacher, I already know that. Any specific research finding which I should take as a message and it should change my practice as a teacher?
Okay, according to our research, we found that the children with more family members and siblings, as well as the interaction with the school members had good development of theory of mind. So maybe I can give that message.
Okay, that's fine.
Thank you, sir.
Rashmi, this whole concept and language acquisition, after doing the study, what have you learned would be the most important implication with the concept and the language acquisition?
Yes, ma'am. I felt that in children who had more bilingual languages, they acquired the better theory of mind understanding when compared to the children with one single language ability.
So you would differ from this advice where teachers say in many places, speak only English, don't confuse the child with two languages.
Yes, ma'am. Obviously.
That's the when you send, most parents ask you that. That's why I'm asking this
Yes,
question.
ma'am. In my studies, I found out that children who knows Kannada as well as English had a better results.
So you would, yeah, so you would differ, right? So you would tell all teachers to change. Okay.
Thank you, ma'am. Next up, we have Dr. Ashok. Dr. Ashok, I request you to upload your PPT.
Can you see my screen?
Yes.
Shall I go ahead, ma'am?
You may start now.
Yeah. So I'm Dr. Ashok Jamigungla, a junior resident from the Department of Psychiatry, Kasturba Medical College. Today I'm presenting a sub-analysis of a larger study. So we're presenting only the part which is related to anhedonia during protracted alcohol withdrawal states and its relationship with abstinence, which is a 6-month follow-up study. So the word anhedonia was introduced in psychiatry by Ribot, who defined it as the inability to experience pleasure. So the prevalence of anhedonia in general population is less than 5%. It is a core feature of depression and one of the most important negative symptoms seen in schizophrenia. Yet it is also very frequently seen during acute and chronic alcohol withdrawal according to recent studies. So the physiological withdrawal symptoms in anhedonia show different time course, with the hypoactivity of the dopaminergic system responsible for anhedonia emerging later and lasting longer. So anhedonia positively correlated with drug cravings and increased the likelihood of relapse in earlier studies, and so it is thought to be a key obstacle to recovery from substance dependence. However, there is a lacuna in this area due to lack of longitudinal studies, and our study attempts to fill that gap. So we included patients between the age of 18 to 60 years with a diagnosis of alcohol dependence syndrome in withdrawal. We have taken informed consent. The patients that were excluded from the study were those with comorbid major psychiatric disorders, other substance dependence except tobacco, and those who had a history of epilepsy. It was done over a period of 16 months. And at baseline, we recruited 116 patients. We collected their social demographic and clinical data. We screened them for other major psychiatric disorders with modified mini-screen. We assessed the severity of withdrawal using CYAR scale and assessed the severity of dependence using SAD-Q, and anhedonia was measured using SHAP-C. Again, we followed up these patients at 1 month, 3 months, and 6 months, during which we administered SHAP-C to measure anhedonia. Those patients that lapsed or relapsed were excluded from further assessments. So while there are many scales to measure anhedonia, all of them were in English and we had none in Kannada. Since we wanted a clinician-rated version, we used SHAT-C, which is a modified version of the Snaith-Hamilton Pleasure Scale. It is a 14-item clinician-rated scale which measures anhedonia in the domains of social interaction, food and drink, sensory experience, achievement, and pastimes. It takes 10 minutes. It is the questions are based on 4-point Likert scales and scores range from 0 to 14, with 3 or more meaning anhedonia. It has good internal consistency and split half reliability and correlated positively with SHAPS. And the patients, the mean age was 42 years and all of them were male, 99%. 3/4 of them were married and 95% were employed, living in nuclear families, mostly in middle and lower socioeconomic status from rural areas. So the average mean age of dependence on alcohol was 31 years and the quantity frequency index was 109 standard drinks per week. So we measured them at a average days of 5.2 days from their last drink, and half of them had previous history of withdrawal, with quarter of them receiving de-addiction treatment previously. 80% had previous tobacco use. And when we assessed, quarter of them had delirium during withdrawal, and the mean CYR score at the time of assessment was 3.7. Equal number of patients were present in mild and moderate groups, and there were quarter of them were in the severe dependence group. So 18% of the patients had anhedonia during baseline. When we compared the groups with and without anhedonia, there was significant difference in quantity frequency index at 116 standard drinks per week in the patients with anhedonia. So at baseline, 80% of them had anhedonia. At 1 month and 3 months, about half the patients had anhedonia, and at 6 months, only 1/5 of them had anhedonia. So we ran chi-square test to compare the relationship between anhedonia and abstinence status at 1 month and at 3 months. We did not find any significant relationship between both these. And then we ran Kaplan-Meier survival analysis to check the relationship between anhedonia and time to first drink. So when we compared anhedonia at baseline and time to first drink, we found that the patients with anhedonia had significantly longer median time to first drink at 20 days compared to those without anhedonia who had 14 days. So we also ran the same comparison at anhedonia at 1 month and lapse or relapse at 3 months, but we did not find any statistically significant difference, but the numbers were quite low here. So anhedonia has been initially conceptualized to have physical and social subtypes, but recent studies show that there are 3 subtypes with deficiencies in reward liking, wanting, and learning, with implication of opioids and dopamines. So when we compared our study with another cross-sectional study by Martinet et al., we saw that anhedonia was prevalent in almost half the patients at 1 month, but it continued to be present in half the patients at 3 months in our study. Their study showed that it was present only in 16%. And Maran et al. In 1998, when they did this study, they did not find change in SAS or PAS or FCPS scales over a 6-month period. So they concluded that anhedonia does not predict relapse. Generally et al. In their study, they did not find significant correlation between duration of abstinence and also the scores of SAPS. So we did not find significant relationship between anhedonia and abstinence, but we found that people with anhedonia took significantly longer median time to first drink. So it may be hypothesized that motivational anhedonia may be at play here, leading to longer time to first drink, but we have not assessed the subtypes. So overall, anhedonia appear to be protective for relapse, but we need to study the subtypes to understand this concept better. So I conclude saying that anhedonia is frequent during acute withdrawal and is seen in about half the patients at the end of 3 months, while at the end of 6 months, it is seen in only 1/5 of the patients. So this reduction of anhedonia over time shows that it's probably a state marker of alcoholism rather than a trait. And patients with anhedonia during acute withdrawal had significantly longer time to first drink. So management of anhedonia may play a critical role in relapse prevention. So the limitations of a study is that the sample size and follow-up rates have been limited due to the ongoing COVID-19 pandemic, and the abstinence status has been recorded based on self-reports. However, future studies can use biochemical tests like CDT, GGT, and MCV to confirm the abstinence status because it could be influenced by anhedonia. And we could not assess the subtypes of anhedonia, so using newer instruments like temporal experience pleasure scale, which actually measures the subtypes, it may have different implications in clinical management. And our results must be interpreted with caution because we are not controlled for tobacco use. So future studies can control for tobacco as it may affect the hedonic capacity independent of alcohol. And future studies can also look into the neurobiological correlates of anhedonia using imaging studies like fMRI. So these are my references.
Thank you, Dr. Ashok. I request the judges to take over.
Prema.
Ashok, quick 2 questions. So, is this anhedonia, so do you recommend we treat with an antidepressant or an anti-craving agent?
So we found that since dopamine and opioids are mostly implicated in the mechanism of anhedonia, we can see whether it can be treated by antipsychotics or opioid blockers like naltrexone. Like it could, if it worsens this anhedonia, because in our study we found that it was protective for relapse, delaying the time to first drink.
The second question is the so-called anhedonia and craving. Is there a plan to correlate, or is there anything? Because I didn't see.
As my previous studies have looked into it, they found a positive correlation between anhedonia and craving, but in our study we did not assess craving, ma'am.
Why?
I mean, it was part of a larger study called protracted alcohol withdrawal syndrome, in which we looked at different symptom domains. So we did not have craving in our study. This is a sub-analysis, ma'am.
Okay, thanks.
Thank you.
Ashok, this concept is very old, 1896 anhedonia, and it must have metamorphosed now, and it is applied in various conditions. And now that you say that it is there even in substance use disorders, originally, clinically, we feel that anhedonia is more familiar in depression because qualitatively, patient says that I used to like it, but I have lost interest. Whereas in alcohol, how do you, generally they like the substance or alcohol and they want to, they lose interest in many things. It gets narrowed down in dependence. then it has to open up and then create interest in many other things. So how do you qualitatively understand this concept of anhedonia across 3 disorders? Schizophrenia, anhedonia, how it is different, then depression, anhedonia, how it is different, substance use disorders, and anhedonia.
In depression, it is predominantly thought it is consummatory anhedonia that is at play, while in schizophrenia, they found that it is anticipatory anhedonia. So they can experience a pleasure right now in schizophrenia, but anticipating future events and pleasure from them is impaired. While in depression, experiencing pleasure in the current moment is impaired. But in in substance use, they have not seen specifically like that, because overall in a meta-analysis, there were only 3 to 4 studies looking at anhedonia in substance use. So that is why we need to look at what is at play here, whether it is motivational anhedonia or consummatory anhedonia. So at 1 month when we did the analysis, we found that this quantitative frequency index was higher in the people with anhedonia. So possibly they were not deriving pleasure when they were consuming alcohol, so they had to drink higher amount of alcohol. So that's one thing we thought.
So what is the role of benzodiazepines versus psychotropics and their relationship with anhedonia? Since now we are comparing in substance use disorders where benzodiazepines are predominantly.
So if we give antipsychotics, it will actually reduce the dopamine further and it will worsen the anhedonia. So in our study, since we found that anhedonia seemed to be protective for relapse or lapse, we thought that it may help in treating substance dependence. But benzodiazepines in the other way, they might reduce the anxiety and in turn may improve anhedonia, while antipsychotics worsen it.
Okay, thank you.
Yes.
Thank you. Next up, we have Dr. Rohit Ranjan. Dr. Rohit, I request you to share your slides.
Hello.
Yeah.
A very warm good afternoon to respected judges. My study is about study of neuropsychological deficits and related functional impairment in bipolar disorder patients in remission. Able to change the slide. Which one? Coming to introduction, bipolar disorder is a serious mental illness. The condition often involves sudden episode of illness separated by remission. The symptomatic phase involves mania or depression, and the research shows that the people with bipolar disorder face some cognitive challenges. An increasing number of studies have detected cognitive impairment in patients with bipolar disorder, not only during acute phase but also during remission. It includes difficulties in working memory, which is a type of short-term memory that allows us to store information for a short time while carrying out a mental task. It helps with learning and is important for concentration. Short-term memory problems affect daily functioning. They can be subtle and they can affect a person's ability to take in new information, and that is needed to complete complex tasks. They may also make social interactions more difficult. While bipolar disorder is widely understood in terms of mania and depression, its effect on thought may have more impact on daily life and especially working life. Poor memory and difficulty concentrating can make it hard for a person with bipolar disorder to work. These problems can persist between bipolar episodes. The impact of bipolar illness on cognition can be influenced on age of onset, pharmacological treatments, individual response, familial risk factors, and clinical features. Recent neurocognitive investigations during the remission phase of bipolar affective disorder have shown a persistent cognitive deficits in 32% of patients. There is a limited evidence in the Indian literature in this area. Hence, identifying and addressing neurocognitive dysfunction would improve treatment outcome and overall well-being. Cognitive deficit will lead to a social and occupational disturbances and demand overwork, leading to stress and relapse. So recognition of this at earlier stage will lead to functional recovery. The combination of pharmacotherapy, psychoeducation, and cognitive rehabilitation will be required to manage further BPAD episodes. Coming to the aim of my study, to study the pattern of neurocognitive deficit and their functional impact on BPAD patients in remission on maintaining dose. The objective of the study are to study whether patients with bipolar affective disorder in remission have cognitive or neuropsychological deficits, and to study the pattern of cognitive impairment in patients in remission on maintaining dose. The study design was a cross-sectional observational study, and the source of data were BPD patients in remission on maintaining dose were collected from the psychiatry department at MVJ Medical College and Research Hospital, Hoskote, and were taken for the study and after taking the informed consent. And the study was conducted for the period of 2 years, from November 2018 to August 2020. And thus, the total of 50 bipolar affective disorder patients in remission on maintenance dose were taken up for this study, and the age group was between 18 years to 60 years. And coming to methodology, the study participants were 50 patients who met the ICD criteria for BPAD in remission, and the participants were recruited by purposive sampling method, that is non-probability sampling, and the diagnosis of participants with BPAD were determined using mini international neuropsychiatric interview. And the participants with BD bipolar disorder were included in the study if they had low residual depressive symptoms, that is HAM-D score less than 7 and YMRS score less than 7, and they do not have any episodes of major depression or hypomania or mania in the 6 months preceding the study, and were on a stable dose of medication. And then the functioning assessment short test was used to measure their functioning, and it is basically designed for assessment of functioning in the BPAD patients. And the Addenbrook's cognitive examination and PGI memory scale was used specifically for the assessment of neurocognitive impairment, and the brief coping scale questionnaire were used to measure effective and ineffective way to cope with the stressful life event, and the Rosenberg self-esteem scale was used to assess self-esteem. And coming to the inclusion criteria, the patient previously diagnosed as having the BPAD, and the age group of 18 to 60 years were included for the study, and the both sexes were included for the study, and those individuals who are currently in remission with the scores less than 7 in HAM-A and HAM-D and YMRS. And the patients with history of mental retardation, epilepsy, head injury with loss of consciousness, and cerebrovascular diseases, neurodegenerative disorders, substance abuse, and systemic illness with known cerebral consequences were not included in the study. And the patient with a history of active psychosis in past 3 months were not included in the study, and children and adolescents were not taken in the study, and the patient with other significant medical and psychiatric comorbidity were excluded from the study, and the individual with current and active episodes of BPAD was excluded from the study. And coming to the result, in the functioning assessment short test, the cutoff of more than 11 is subject with bipolar disorder as a measure of disability. And based on the cutoff, it was found that 28% patients were found to have poor functioning, and 32% were found to have average functioning, and 40% of individuals were found to have better functioning. And out of 50 bipolar affective disorder patients in the study, 46% of patients were found to have neuropsychological deficits in one or more cognitive domains. And according to Addenbrook cognitive examination, it was found that 22% of patients had difficulties with attention, and 12% patients had difficulties in language, and 8% of patients had problem with visual spatial ability, and 6% has problem with memory, and 6% patient has problem with the language. And this was a graph for PGI memory scale, in which it was found that 10% of individuals were found to have difficulties with remote memory, 8% of individuals were found to have difficulties in recent memory, and 6% of individuals were found to have difficulties in mental balance. And for attention and concentration, 22% of individuals had issues, and with short-term memory was deranged in 8% of individuals, and working memory was impaired in 28% of individuals, and simple learning was impaired in 16% of individuals, and new learning ability were impaired in 16% of individuals, and visual spatial memory was impaired in 4% of individuals, and recognition was impaired in 4% of individuals. And this is the clinical variables of the sample based on the functioning, and it was found that a significant correlation was found with the number of hospitalization and duration of hospital stay, and significant correlation was also found in HAM-D, YMRS, and FAST scores. And coming to the discussion, in the present article, we performed a cross-sectional observational study to determine the pattern of neurocognitive deficit and their functional impact on BPAD patients in remission. This study emphasized that patients who had longer hospital stay are more prone to have poor functioning. This could be because such patients might have had more severe symptoms or were difficult to stabilize on treatment, or due to severe cognitive deficits, as also seen in previous studies. An association of illness severity with cognition impairment in bipolar disorder patient could be due to allostatic overload described by Kapinski et al., where greater stress can lead to more severe neurological damage and cognitive
Thank
decline.
you, Dr. Roy. It's time. You may have to stop now.
Yes, ma'am.
Your time is up. You may stop now.
Oh, yes, ma'am.
I request the judges to
just make a last one sentence.
Anything?
In this study, it could be possible that the patient who had longer hospital stay might have experienced more stressful mood episode or greater acute allostatic load. And Tohen et al. Also found the association between functional recovery and shorter hospitalization. Hence, we can understand that in our sample also poor functioning is associated with longer hospital stay. Coming to conclusion, it suggests that there is a significant degree of morbidity and dysfunction associated with
one sentence conclusion.
Moreover, the psychosocial factors included higher stress, moderate social support, and self-esteem, and greater use of problem-focused coping strategies. Poor functioning patients had a history of longer hospital stay and had greater score in depression,
Too
mania,
long
and
a
stress.
sentence. I think the sentence, I should have defined that sentence. Sentence not more than 10 words. Okay, time is over. And so what is the key definition of remission you have used in your study?
Depending upon the HAM-D and HAM-A score, sir. HAM-D and Weimar score. If the score is
that has a time item is there, last 1 week, last 1 month, last 6 months.
Yeah, in the last 6 months, sir. Like on the patient who are they don't have any episodes of mania or depression in the last 6 months.
YMRS and Hamilton's depression, do they assess for last 6 months?
Like for the for the sample which we have collected, sir, like for the past 6 months, if the patient don't have any symptoms.
You tell me remission has a definition, and
yes,
use these scales to define that they have remitted. But if
yes,
you use the scale, there is a time limit. That is
yes.
a limitation of the scale. You cannot say last 6 months they have remission.
If the patient don't have any symptoms of like any episode of mania or depression in the past 6 months, and if if their score is less than HAM-D score is less than 7 and Weimar score less than,
it is a cross-sectional assessment using these scales. You have
yes,
not used it for 6 months, so you cannot apply like that.
Okay. Yes.
Next one, 40% they were better functioning.
Yes.
Better functioning. What about their neuropsychological findings, and what about the severity of bipolar?
Was also found with a period of hospitalization, sir, and also with the duration of scores, like how severe the symptoms were, how number if they had more number of episodes of
This neurocognitive functions, is there any specificity you found which is different in bipolar compared to studies where they have done in schizophrenia, or they have compared these two groups?
In our studies, sir, we have taken only patient with bipolar disorder patients, sir. Like,
so do you think it is different here compared to what you talk in schizophrenia?
Yeah, there few studies were also done in which the patient with schizophrenia and bipolar disorder were also compared, sir. Like it was found that schizophrenic patients have more number of, like they have higher percentage of neurocognitive deficits as compared to bipolar disorder patients in remission.
Do you think is there any need to study this in bipolar 1 and bipolar 2?
Yes, sir. Like
in your sample,
yes,
is
sir.
more of bipolar 1 or bipolar 2?
We have taken patients with bipolar, both bipolar 1 and bipolar 2, both the patients we have taken.
Do you think it will differ in case if you study them separately?
It might differ, sir, like because if the patient have full blown mania, like as in our study, patient who had severity of manic symptoms.
Thank you, Dr. Hema. Time constraints.
Yes, sir. Yes, sir. Thank you, sir.
Rohit, just one question, Rohit, because it's bipolar. Lithium is neuroprotective. So did you find any difference when you looked at mood stabilizer, or if a bipolar had only lithium versus others, or if there were two mood stabilizers, any differences like that in your?
Yes, ma'am. We have found, like we have concluded that like in my like in our study, like most of the patient, like majority of patients were on lithium only, but like significant difference, like we have not concluded, like if the patient were on like on any one mood stabilizer. Those findings we have not concluded, ma'am.
Thank you.
Oh, thank you.
Thank you. Next, we have Mr. Kapil Kataria. Mr. Kapil, I request you to share your slide. Okay, you may start now.
Okay. Good afternoon, everyone. The title of the study that I am going to be presenting today is Experience of Young Adults with Mother Diagnosed with Schizophrenia. I conducted this study as a part of my master's thesis under the guidance of Madhvi Rangaswamy. First degree relatives of persons with schizophrenia have a 10% chance of developing schizophrenia. Research has found that 50 to 40% of offsprings of parents with schizophrenia tend to develop psychotic disorder. So the vulnerability that the population inherits along with the family environment of having a parent with schizophrenia makes the experiences of the population unique and worth studying. Caregiver burden is a social construct that is experienced by people who take responsibility of patients with enduring illnesses like schizophrenia. There are two major types, objective and subjective burden. Let's briefly look at the review of literature. Children of persons with severe mental illness report lack of support, internal problems such as losing sense of self, difficulties with emotions, external problems such as fear of symptoms and stigma. Children of persons with schizophrenia report similar findings such as grief reaction to loss of parent, adverse effects on attachment and intimacy, low self-esteem, and resilience. So studies have focused more on caregivers of individuals with schizophrenia and less on understanding experiences of growing up and living with a parent with schizophrenia. The present study attempted to fill this gap and explore the experiences of individuals with a parent with schizophrenia. These are the major and specific research questions. The study used the qualitative method with phenomenological paradigm. A semi-structured interview guide was developed. Due to the time-bound nature of the study, data saturation was not achieved. I analyzed the transcripts using interpretive phenomenological analysis. Various strategies were used to validate the data. The interview guide was face validated by 3 experts. A pilot study was conducted to test the interview guide. Field notes were taken. Member check was also done. Clarifying researcher bias, I have a father with schizophrenia and the interest in the topic at hand emerged from that experience. A sample of 6 participants was taken with no preferences in gender. The participants are young adults between the ages of 18 to 25. The participants had one parent, mother, diagnosed with schizophrenia. Participants who had a second parent with a mental or physical illness were screened out. The process for screening was done through an online participation form. However, the medical records of the parents were not sought, hence it is not possible to confirm the diagnosis of the parent. So the themes that emerged were making sense of the illness. The participants experienced the phenomena of schizophrenia differently. Participants described schizophrenia as slow loss, egocentrism, living in an imaginative world, and simply seeing the world differently. The understanding of schizophrenia seemed to have developed through information from doctors, fathers, relatives, and even internet searches. The memories of perplexing symptomatic behavior theme. While growing up, all participants reported strong memories of positive symptoms in their mothers. Later, the diagnosis provided them a context to make sense of their individual experiences. The participants experienced delusional beliefs of their mothers and consequent acting out of those beliefs, sometimes to fatal consequences such as suicide attempts and attempts to harm others. Fear and abuse experience. During childhood and adolescence, the participants recalled being fearful of their mother's positive symptoms as they found mothers to be unpredictable. 3 participants described episodes of physical, verbal, and emotional abuse. Experiences of support and caring. 4 participants reported having support from their mother, uh, from, from others such as father and grandparents. However, 2 participants were left by themselves to cope with their mother's illness. The reaction of the participants towards the symptomatic behavior also changed as they grew older and gained more information about their mother's illness. It would lead to mixed emotion. One participant reported that she felt guilty about her anger and fights with her mother after learning her diagnosis. Uh, Chaotic personal life. 5 participants recalled having chaotic life which was stressful as a child. This chaotic life was contributed by lack of structure which is generally provided by a parent. 3 participants experienced a lack of parent figure in their life. They highlighted a need for social support either from the system or extended family. Role reversals and obligations. Participants seem to have added responsibility due to their mother's illness. The commonly added responsibilities were helping their fathers in caretaking, taking form of some responsibility regarding the treatment as well as household activities. 4 participants mentioned that they were concerned about their mother's deterioration, leading to taking up extra responsibilities to make up for it. The participants experienced role reversal, and one participant who had lost her father when she was 10 years old believed that she was filling her father's void. Effects on self more negative than positive. Two participants struggled to take help from others due to past negative experiences. Participants report unfulfilled emotional needs that a mother fulfills. Insecure attachment patterns were also seen, such as fear of rejection, fear of losing people, directly linked to the mother's illness by the participant. Participants reported positive effects such as empathy, patience, maturity, resilience, and self efficacy because of seeing their mother go through schizophrenia. Uh, Participants uniquely experienced the phenomenon of schizophrenia, which created a personal meaning of schizophrenia. Research shows that children are left uninformed about their parents' condition, and it was also seen in this study. It explains participants' misconceptions about schizophrenia and provides clues regarding lack of proper psychoeducation from mental health profession. Research has also found that people with severe mental illness lack capacity to parent, and it seemed to have contributed to the lack of structure in the participant's life. Their mother's positive symptoms seem to be at the epicenter of the unpredictability. Research shows that individuals who have a parent with schizophrenia report similar intrusive memories of positive symptoms. Research suggests that caregivers have fear about the ill person killing themselves. Participants also reported same due to suicide attempts and suicide threats by their mothers. Participants reported caregiver burden with an increase in objective burden, which has also been seen in previous research. Research has shown that there is a role reversal, which is also seen in this study. Participants who had support from father and grandparents had relatively less burden, and those who were sole caregivers had increased burden and high degree of role reversal. Participants reported that experience also led to difficulties in sense of self, emotions, and attachment. Attachment theory and previous research helps us understand the difficulties in attachments in the participants. Participants reported positive effects, and it has also been seen in previous research. These are some of the limitations of the study. Study found that children were lacking information about their mother's illness, and further studies can focus on quantifying the burden and the attachment difficulties and the reason for lack of information. And it is also
Thank you, Mr. Kapil. The time is up.
Okay.
I request the judges to take over.
Dr. Hema, your turn.
Kapil, if we just one question, if you used, I presume if this is grounded theory approach, what would your theory be at the end of this qualitative work with the data that you have?
I'm not very familiar with the grounded theory approach, so I don't think I can comment on that as much.
No. Do you think you did a grounded theory?
No, ma'am. It was more like the paradigm we had taken was phenomenology. So we were looking at the lived experiences of the individuals.
I get it, but why? Okay, so will you read up to check if what you did was a grounded theory approach?
Okay.
I know, see, your aim is qualitative. You looked at understanding the illness and you did interpretive phenomenological analysis, but will you check?
Yes, ma'am.
Because, yeah.
You said the themes were generated based on the interview.
Yes, sir.
Most of the themes are generated based on the interview. Interview
Yes,
was a structured clinical interview.
No, sir. It was a semi-structured interview which was developed based on the research objectives.
Okay. So the interview generated theme versus your analysis generated themes. Any kind of an insight? Analysis also can generate themes.
Yes, sir. So in that analysis, there is a interpretation comment section. So where you make interpretation. So I thought that there was the less support the participants had, the more enmeshed the relationship was, and the more difficulties they were facing.
Okay. And without research also, we have a kind of a bias or an understanding that positive symptoms and aggression, whether it is suicidal behavior or aggression, have a greater impact or it will have effect on the memory. So that in recollection bias and those kind of things, these things will be less compared to, say, negative symptoms. So you have any comments?
Yes, sir. So that's what from earlier participants mostly reported of positive symptoms. But at the current state of functioning of the parent, they were also reporting of negative symptoms. But it seemed it more like the negative symptoms were assumed as part of the personality rather than as being separate as part of the illness.
Okay. Do you suggest any other qualitative methods if people repeat this kind of a research which will help them? One is grounded theory, anything else?
I'm not very familiar with other approaches, sir. So
Okay, thank you.
Thank you. Next up, we have Dr. Tashita Sherry. I request you to please upload your slides.
Slides are visible?
Yes, you may start now.
Yeah. Good afternoon. My study title, The Impact of Duration of Untreated Psychosis on Various Aspects of Social Cognition in Patients with Schizophrenia, a cross-sectional study. By me, Dr. Tessita, third-year postgraduate. My co-author was Dr. Arun, HOD, Department of Psychiatry, SMBMCH, Pondicherry. To go into the introduction, schizophrenia, as we all know, is one of the most catastrophic mental disorder affecting nearly 23 million people, more in males than in females. And despite of the 50 years of pharmacological and psychosocial intervention, schizophrenia has remained as the topmost cause of disability in the world. And in the past few years, impairment of social cognition has received a great significance. What is social cognition? Described as the process through which we draw inferences about other people's beliefs, intentions, and how we weigh the social situational factors in making these inferences. It includes the social perception, theory of mind, attributional style, etc. People with schizophrenia present with specific deficits in their social cognitive abilities, which have a tremendous impact on their work, overall performance, and employability. And research suggests that these deficits are seen early during the course of psychotic disorders. Meta-analytic studies have concluded that the pharmacological interventions have a limited results on the social cognition impairment. Objective of my study was to evaluate the social cognitive status of patients diagnosed with schizophrenia, assess the impact of duration of untreated psychosis on various aspects of social cognition in schizophrenic patients. Methodology, it was a cross-sectional study conducted in the tertiary care center after approval from the Institute Ethical Committee. 56 participants were recruited after obtaining their consent. Data was analyzed using SPSS version 24. Inclusion criteria, patients diagnosed with schizophrenia taking treatment between 18 to 60 years of age. Exclusion, patients who did not give informed consent or with some other comorbid conditions. The patients were assessed using a preset performer to look into details regarding the duration of illness, duration of untreated psychosis, demographic details, etc. Social cognition was assessed using OSCAS, that is Observable Social Cognition Rating Scale. Something about OSCAS, it is an 8-item rating scale rated by the clinician and a high contact informant. Each question probes into a social cognitive domain, like question 1 for emotional perception, question 2 attributional style, question 3 jumping to conclusion, question 4 and 5 cognitive rigidity, 6, 7, 8 theory of mind. It's the score is rated on a 7-point Likert scale. It takes nearly 15 to 20 minutes. There are many studies that have proved the validity and reliability, which have ultimately concluded that OSCAS can be used as a fast and practicable applicability for comprehensive assessment of social cognition. If you go to results of my study, the mean age of the study population was nearly 35 years, more in males than in females. 32 were employed, 15 had first episode. And if you look into the mean duration of untreated psychosis, it was 22 months to plus minus 30 months. That is nearly 2 plus minus 2.5 years. And mean duration of illness was nearly 72 months. If we look into the distribution of the OSCAR question scores, mostly the ratings were between a moderate and mild range. And to look into the association between the duration of untreated psychosis and the OSCAR parameter using the Spearman's correlation, the OSCAR questions that are marked with stars showed a significant association. That means the OSCAR question 1, that is emotional perception, attributional style, cognitive rigidity, theory of mind, and the whole total scores showed a significant association with duration of untreated psychosis. Whereas question 3, that is jumping to conclusion, didn't show a significant association with duration of untreated psychosis. If you look at the scatter plot, that is plot 1 and 2 was used to assess the correlation between OSCAR question 1, that is emotional perception, with duration of untreated psychosis. Plot 1 is for ratings from informant and plot 2 is for ratings from interviewer. And we found a moderate positive correlation between emotional perception and duration of untreated psychosis, which was statistically significant. It means that as the duration of untreated psychosis increases, the deficits in the emotional perception also increased. Similarly, plot 3 and 4 to assess the correlation between attributional style and duration of untreated psychosis, it showed a moderate positive correlation, which was statistically significant. Plot 5 and 6 to assess the correlation between jumping to conclusion and duration of untreated psychosis. This was not statistically significant. Plot 7 and 8 correlation between duration of untreated psychosis and cognitive rigidity, which showed a moderate positive correlation, which was statistically significant. Plot 9 and 10 correlation between duration of untreated psychosis and theory of mind. This was statistically significant, but it just showed a weak positive correlation. And plot 11 and 12 shows a correlation between duration of untreated psychosis and the total score. This also showed a moderate positive correlation, which was statistically significant. So since it was rated by an interviewer and the informant, the agreement between the two showed a very strong correlation. So in short, the results show that social cognitive deficits were significantly present in schizophrenic patients, and longer the duration of untreated psychosis, worse were the social cognition deficit score. However, when the duration of untreated psychosis was compared with various aspects of social like theory of mind, jumping to conclusion, etc., we found that duration of untreated psychosis was significantly associated and showed a moderate positive correlation with emotional perception, attributional style, cognitive rigidity, and a weak positive correlation with theory of mind. And duration of untreated psychosis was not significantly associated with jumping to conclusion. Discussion. Social cognition has been considered as an important treatment target for functional improvement in schizophrenics. Although social cognitive deficits in schizophrenics have been well studied, there are only few studies that have evaluated the impact of duration of untreated psychosis on various aspects of social cognition. My study findings were in concordance with the existing literature. Hence, by assessing the duration of untreated psychosis in schizophrenic patients, we at least have an idea about which domain of social cognition should be intervened, thereby improving the social functioning. Like for example, there is a training program called Social Cognition and Interaction Training Program for Schizophrenic Spectrum Disorder, which was associated with improved emotional perception, improvement in theory of mind, and reduced attributional bias.
Thank you, Dr. Trishita.
Just the last line, conclusion. Okay, so the purpose of my study, since we have to include the social cognition in treatment target to improve social cognition, to improve the functionality, so I would know which domain should be interviewed, thereby improving the social functioning and quality of life. These are my references. Thank you.
Thank you. You started saying that schizophrenia is a catastrophic disorder. So
Yes,
would you like to comment?
Sir, because it's going to affect them totally and there is no perfect treatment for it, which is going...
There are many disorders like that in medicine.
Yes, so this is one of the catastrophic disorders. Sir.
So do you think it will further stigmatize?
So we'll have to remove the stigmatization by telling them this is the treatment and this is what we can do for it.
By telling that it is not catastrophic is better?
That's better, sir.
Okay. Okay. Do you think only patients jump to conclusions or researchers also jump to conclusions?
So that's a bias. Researchers also jump to conclusion.
Okay. Are there any scales to tap that in researchers?
I'm not sure about that, sir.
Okay. But this is one of the items in the social cognition you said, jumping to conclusion.
Yes, sir.
Next question is, how independent are these components, 4 components? Is there any overlap? And the item analysis of these questions, what you ask and all that, have looked into all that?
So actually studies say there's no overlapping as such.
What do you think from your study?
So for my study, I feel there is an overlapping in some domains at
What
least.
is your solution if there is an overlap?
Maybe, I don't know, sir, I'm not sure.
Okay, you said mean duration of untreated psychosis in your study is only for 2 years.
So 2 plus minus 2.5 years.
So you are compared within the sample.
Yes, sir, within the sample.
Okay. Do you think if we compare that with people with 5 years or 6 years duration of untreated psychosis, what will be the finding?
So as the study shows, it shows as the duration of untreated psychosis increases, the social cognition deficit will also increase. So
that
if
means
it's
there is a direct kind of
direct kind. Yes, sir.
Do you think it is like that in a heterogeneous disorder like schizophrenia?
The study shows that.
Okay. Okay, Dr. Hema.
Thank you, sir. Ma'am, I can't hear you, ma'am.
Why did you prefer Oscars and didn't take the validated Socrates?
Ma'am, Oscars was a new scale, and the validity and reliability was proven by many studies. So I used it, sir.
No, okay. The other thing is on DUP. Since what was your definition of DUP in your Indian setting? You mean totally untreated? You got total untreated sample, or was there a definition? Or what?
Ma'am, it's not definition. Basically, the total duration of when they were not treated, when they were first got to the hospital, what was the duration from the time the symptoms?
My question for asking that is because by the time people reach us, there is some. So I'm basically saying never treated. So you must define DUP also, because mostly people, yes, we do get 2 years of untreated many a times in chronic negative symptoms and all that. But usually there is, so it's always better to define what you meant by DUP in your study.
Yes, ma'am.
Look up Socrates.
Yes, ma'am. Sure, ma'am.
Yeah.
Thank you, ma'am.
Thank you. Next, we have Captain Ujjal Singh. I request you to present your slide.
Is it visible, ma'am?
Yes, you may start now.
Thank you. Good afternoon, all. I'll be presenting the paper on assessment of factors associated with internet gaming disorders in students from government school in Western Maharashtra. So internet gaming disorder has been included in DSM-5 in a section of condition for further study, and also is coming up in DSM ICD-11. And the prevalence has been seen between, it is variable, and it has been seen between 0.7 to 21% across various regions. And internet gaming disorders has also been associated with male gender, lower income, and lower educational levels of parents. Professional and academic problems and overall decrease in quality of life are consequences observed with internet gaming disorders. However, in our setting, internet gaming disorders and its factors hasn't been studied with standard tools. So with this thing in mind, we started a cross-sectional study to assess the factors associated with internet gaming disorders between November 2018 to June 2019 in a population of students of 8 to 12 grade in a government school in Western Maharashtra. The sample size was calculated with 5% error of margin and 95% confidence interval, taking into consideration previous study with 6% prevalence. The sample size was calculated to be around 83. The approval from institutional ethical committee was taken, then assent and consent of the students were taken, as well as informed consent from the parents were taken, and they were administered internet gaming disorder scale. This was a 9-item scale, which is in accordance with DSM-5 criteria. The 5 or more is significantly suggests internet gaming disorder, and socio-demographic pro forma was also obtained. Diagnosis of the cases was clinically based on DSM-5 as well, and evaluation was done using appropriate statistical tool, that was chi-square test and multivariate logistic regression analysis. Students, as inclusion criteria mentions, 12 grade students, and in exclusion criteria, the students with family history of psychiatric disorder and pre-existing psychiatric disorder in form of ADHD, depressive episode, mental retardation, autism, and conduct disorder were excluded. So the results showed that there were around 13% of non-gamers and 87% of gamers. That is around 18 individuals did not play games at all, and 124 individuals played games. Among these, the prevalence of internet gaming disorders was found in 15 individuals. That was among 142 individuals, that was around 15 individuals had internet gaming disorders. While looking at the gender, it was internet gaming disorders was associated significantly with male gender. There's around 15% of the males were found to have internet gaming disorders. But in standard, even though internet gaming disorders were more prevalent in 10th grade students, it was not significantly associated. Family income, the lower family income was associated with internet gaming disorder. Similarly, education of head of family, which was lower as compared to other, was also associated with internet gaming disorder. And also skilled and semi-skilled workers were, the occupation of head of family, which was semi-skilled and skilled, were also associated with internet gaming disorders. We also assess corpusomny socioeconomic status, which had not been done in previous studies. So we found that lower middle and upper lower socioeconomic status individuals were associated with internet gaming disorders. Owning an internet connection was not associated. However, individuals was significantly associated when they had smartphones. Almost all of the individuals who had internet gaming disorder used smartphone for gaming. Less than 6 years when the individuals started gaming, that is the age of first gameplay, they were associated with internet gaming disorders, and the consequences as with other studies, the marks obtained were decreased, that is there was deterioration in academic performance, and average duration of gameplay was more in people with internet gaming disorders. So after multivariate logistic regression analysis, we found that sex, that is male sex, was there were more odds of having internet gaming disorders, and it was significant. Age of first gameplay, that is less than 6 years, was assessed. Family income, which was lower family income, was had higher odds of having internet gaming disorders, and also education of head of family, which were lower, that is school and diploma, were associated with internet gaming disorders. Coming on to discussion, we found that the prevalence was 10.6, which is similar to previous studies, which was done in most of the part of Asia, and was also, but it was higher than some of the other studies. That was 1.8 in King's et al. Study and Lemon's study, that was 5.4. The possible reasons that may have been that age of sample. We taken the sample which had high prevalence of internet gaming disorders, that is the adolescent population. So this may be the reason. Second is recent increase in the availability of the gaming device in India. And gender, the higher prevalence in male population as seen in other previous studies. We know that the female may show better executive control than male when facing gaming cues, which may provide resilience against developing internet gaming disorders. Family income and education of head of family were factors associated significantly with internet gaming disorder even after regression. And similar results was demonstrated in previous study by Rowe and Wistrom. Internet gaming disorders were also significantly associated with lower and upper socioeconomic status assessed by Corpusomni socioeconomic scale, which had not been done in previous study, which they had used self-reported measures. All the students with internet gaming disorders were significantly associated with owning a smartphone device, but not internet connection. So even though terminology internet is mentioned in the disorders, gaming offline can also be associated with internet gaming disorders, as mentioned in DSM-5 criteria and ICD-11, which gives a different headings for each. Earlier age of at first gameplay, that is less than 6 years, was significantly associated with higher prevalence of internet gaming disorders, and internet gaming disorders was associated with academic deterioration, and higher average duration of gameplay was significantly associated. So a strength of my study is that it is one of the first study in India to assess the prevalence and factor associated with internet gaming disorders. However, there are some limitations that I'd like to mention, that it is a cross-sectional design, so the causal relationship remains unclear, and the data obtained may have been subjected to recall bias. And also, I've mentioned earlier, the sample was restricted to adolescent population, that is 12 to 19 age group. Prevalence of internet gaming disorder in students of 8 to 12 grade.
Thank you, Captain Mitchell. I request judges to
My recommendation is that we avoid exposure of gaming in early childhood and decrease the average gameplay duration for prevention of internet gaming disorders. Thank you, ma'am.
Dr. Hema, your turn.
A couple of questions. The finding related to the children, like hours of screen time or comorbid attention, see, when you say internet gaming, so because the finding is very, I mean, if I can use the word skewed, to only looking at income and education, and it's also the surprising finding of only lower and upper, what you have said about socioeconomic status. But what about individual factors? Were they not assessed, or comorbidity was not assessed, or
Yes,
just
ma'am.
clarification?
We haven't assessed the comorbidities in this case, ma'am. We've just assessed some of the factors.
Yeah, so because it's factors, I'm fascinated that the factors became only like a psychosocial, individual factors play an important role, right? I mean, in terms of, so why that wasn't assessed? Or,
It was just a part of my study, ma'am, which was assessed. Some of other factors were also assessed, but I haven't been able to compile it, ma'am.
and since it's 12 to 19, again, not only ADHD and conduct, other comorbid like substance, and since that it's a 12 to 19, I'm asking. Like people who use substance more, okay, like that. No other correlation and no other data was collected.
No, ma'am.
Okay. And also, see, when you say you're finding, just a comment, quick, lower socioeconomic status with smartphone, yeah, it's quite a contradictory finding. So yeah, I mean, I just thought you should. It's a good, relevant work, but I think you should just look into a lot of other variables in the study.
Ma'am, recent studies to find that availability of mobile phone is very high at present, ma'am, and even people with lower socioeconomic status are able to have those devices.
Acknowledged, but I'm so surprised that it's only in the lower smartphone, your upper, unless the schools. So when you're presenting findings like this, whether the school, because of the sample where you went and did the sampling, maybe they are predominantly lower. So that finding was a little odd to listen to.
Ma'am.
And the type of games, if you had highlighted, since PUBG's been banned, would have been interesting.
Yes. Thank you, ma'am.
Why this male student preponderance? What is your explanation?
So as I mentioned earlier, there is the cue-based craving in females. They have a better executive control over it, sir. So that may be one of the factors, sir. And that is the major factor that has been associated, sir.
If you were to do this study during COVID, when accessibility to these things are more to the students, and so do you think the findings would have been much more?
It may be possible, yes, sir.
Okay. And then what is the time during which they use this for games? School hours, after school hours, or at home, or outside?
I haven't this question, sir, but I believe that it would be more
the time during which time of the day or night they are using this more often, and how that has an influence on many other aspects. Okay.
I haven't assessed that part, sir.
Okay. Do you have any suggestions to game developers? Do you have any suggestions for regulators? Do you have any suggestions for parents and teachers?
Yes, sir. Recently, it has been found that the games which are reward based and they're trying more to attract the individuals than give the gaming experience. So those kind of games with game box, there's something called loot box and all. So these have to stop, has to be decreased. And for parents, do not introduce the gaming device early in the adolescent, and so this should be the major advice. And also that even if they are playing games, decrease the game time less than 2 hours per day, sir.
Teachers and regulators.
Sir, for teachers, I think the game time during school should be banned, or a mobile phone during the school should be completely banned at this point, sir.
Problem with internet. Yeah.
Sir.
The teachers, should they also protect those who have some of the exclusion criteria as you have, like ADHD, anxiety?
Yes, sir. I think this should be
The teachers and parents should protect those groups which you have excluded. Do you think that helps?
Yes, sir. Definitely, sir.
Okay. Okay. Thank you.
Thank you, sir.
Thank you. The final presenter for this segment, we have Dr. Zaid. I request you to share your slide. Thank you. You may start now. Dr. Zaid?
Hello.
Yeah.
Yes.
Is it visible?
No, it's not. Could you share it again, please?
Okay. Is it visible?
Yes. You may start now.
The title of my study is a clinical study of psychiatric morbidity in caregivers of inpatients with schizophrenia and its association with gender of patient. I did this study in the guidance of Dr. S.K. Diori. Coming to the introduction, schizophrenia is a severe and chronic mental illness affecting males and females equally. It results in impairment in functions in various domains. Patients become deprived of caring for themselves as well as become long-term dependent on their caregivers. This results in chronic stress on caregivers of patients. The study was done to find psychiatric morbidity in caregivers and to examine if psychiatric morbidity perceived differently by caregivers of male and caregivers of female patients. The aim and objectives are divided into two: to find the psychiatric morbidity in caregivers of inpatients with schizophrenia, and to compare the psychiatric morbidity in caregivers of male and female inpatients with schizophrenia. The study was done in Lokopriya Gopinath Bordole Regional Institute of Mental Health in Tezpur. The study population consists of a dyad of 50 caregivers of male patients with schizophrenia and 50 caregivers of female patients with schizophrenia. It is a cross-sectional study. The total samples makes 100, and the total duration of study is 1.5 years. The sample were collected using purposive sampling. The participants were informed about the study and the consent were taken. A semi-structured performer was used to collect the data after taking the due consent. A brief psychiatric rating scale was administered by the investigator, and a PHQ sets questionnaire was administered on the caregiver. This PHQ sets questionnaire primarily consists of 3 components: assessing psychosomatic symptoms, anxiety symptoms, and the depressive symptoms as a total. The relevant statistical analysis were applied while analyzing the data collected through socio-demographic profile, DPRS, and patient health questionnaire. The results, what the study found that the patient health questionnaire, I divided the categories into 2 broad categories, delineating from mild to moderate to severe. A score of 9 or less than 9 was considered nil or mild morbidity, and more than 10 is divided as moderate to severe intensity. So in my study, I found in the PHQ sites category, the caregivers of both male and female patients with schizophrenia have a moderate to severe morbidity of 36% and no or mild morbidity in 64% sample of the population. The same is depicted into the bar diagram. The bar diagram is also depicting that the psychiatric morbidity in caregivers of male patients is 25% and psychiatric morbidity in caregivers of female patients is 11%, constituting 36%. One individual component of the PHQ SETS score was analyzed using the individual component of the PHQ 15, GAD 7, and PHQ 9, which are the components of the PHQ SETS score. And the PHQ 15, which analyzes psychosomatic symptoms, has found in all these three components a significant difference between between these three parameters of psychosomatic symptoms, anxiety, as well as in depressive symptoms has been found. When the comparison between the caregivers of male patients and caregiver of female patients in terms of psychiatric morbidity was analyzed using the chi-square test, and it found a significant difference between the psychiatric morbidity in caregivers of male patients and female patients. This particular bar diagram is showing the different components of the PHQ SETS scores, depicting the number of patients suffering in each caregivers of male patient and female patients, as shown in this bar diagram. This is a table which is showing a study between the socio-demographic profile of the caregiver and the psychiatric morbidity. Two significant finding has been found in this study. One is that the psychiatric morbidity is positively associated with education of the caregiver and it is significantly associated, and the duration of illness is also significantly associated, but it is inversely associated with. Coming to the discussion, the study found high percentage of psychiatric morbidity in the caregivers. The reason I found in my study is because of the high unemployment rate, young patients, long duration of illness, high PPR score in the patients, and most of the caregivers are the parents and are the spouses who are primarily concerned about the future of themselves and their patient. And the low socioeconomic status of the patient, which I found 88% are from the low socioeconomic status, the high unemployment rate in the caregivers, as well as the low literacy risk. The literature has documented that the high symptomatology and poor functioning, which arise because of the high PPR score, as a factor which can result in both the burden and the prevalence of psychiatric morbidity in the caregivers. The genetic predisposition also increase the risk of mental disorders in the primary caregivers. In one of the studies, the major depressive disorder was found to be the major psychiatric morbidity. Psychiatric morbidity, as the patients who are admitted mostly are the acute phase of the illness, their current symptomatic status is also one of the factors which results in the psychiatric morbidity into the patients. The studies also has found that the caring for the male patient is significantly associated with emotional distress. This can also be explained with the poor prognosis in male patient in comparison to female patients. The psychosocial system, where the male still has been as the primary productive segment of the society, also found one of the factors which is resulting into the differential perception of the stress into the family. The early age of onset in males, more negative symptoms, more number of hospitalization in males, loss of financial resources in the form of patient and to the caregiver at the same time. Caregivers being old parents, and accepting the social role which affected a male was not able to fill. Whereas the caregivers of female patients has found to be relatively less psychiatric morbidity, which could be possibly because of the late onset of illness in female patients, pre-morbidity, better social adjustment, and less negative symptoms into them. Thus, it is also studies has found that the males are also seen as the breadwinners of the family, which those the caregivers who are male and staying with the family, they are only the main breadwinner of the family, and it is not the traditional role of the male to take care of the sick member into the family. Coming to talking about the duration of illness, which was found in the studies, found to be inversely associated with the psychiatric morbidity, and this does not match with the literature, where the nature of the symptoms and the prolonged duration of illness was the factor responsible for the psychiatric morbidity. This can be due to caregiver significantly distress in the acute symptomatic part of the illness, and then in long-term course, it is the patient's behavior.
Thank you, Dr. Zaid.
Okay.
I request the judges to take over the discussion.
Dr. Heba.
Zaid, who is the caregiver in your study?
The caregiver, The primary caregiver I have chosen with using the Perlich and Pollard criteria, ma'am, which is component of 5 components. It can be a parents or the spouse or anyone who is taking care of it. The person who is the who has given the contact in the hospital when if any emergency he needs to be contacted. He is the one who is taking the financial care of the person and who is at least for the 6 months taking care of the patient.
No, why it is important for you to define who the caregiver is, because all your findings which you say that it is true, since male patients are more, when caregivers of male patients have more burden, worry because of the financial reasons. So it's very important to define who the caregiver, and it is, I think if you just say that contact and all, but because the difference between caregiver burden also needs to be highlighted here. What the parent feels versus spouse, and there are a lot of studies from SCARF highlighting this. So I think it's very relevant if you could look into it in future.
Sure, ma'am.
Yeah.
Why this gender effect? Apart from employment, breadwinner, depending upon the geographic location of the study, why do you think this gender effect is seen in your study?
Sir, that was the beginning of that was only the reason like this study started with why exactly the difference.
Okay. My next question is 36% of the people had moderate to severe morbidity, psychiatric morbidity. What you have done for them? As part of research also, if you find something and there is also something you have to do for them.
True, sir. So for the patients, this was part of the malimitation which didn't come to it. The PHQ side scale is a screening questionnaire, and with this I screened the caregivers and the patients the caregivers whom I found to be having moderate to severe psychiatric morbidity. I planned their appointment into our OPD so that they can be properly evaluated and their management can be planned if needed.
Okay. So any studies you have come across, or do you suggest similar studies have to be done looking into the caregiver morbidities in other medical population, like neurologically ill patients or medically ill patients or cancer patients? Do you think, or should we compare, or we cannot compare?
Sir, they can be comparable as well as non-comparable also, sir. Like depending, like schizophrenia as a chronic mental illness can be having a heterogeneous course. Patients who are suffering
if your study has shown more of anxiety, depression than say a psychosis or other kind of thing, then these things can be also seen in those populations.
Sir.
So do you think will there be any difference here, because these are more chronic, or these are more demanding, or these are more poor compliance issues and those kind of things? The next question is, since 64% of them didn't have any kind of morbidity, are there any factors which can protect them to remain in that group, which you have identified and which we should do as clinicians? The 64% should not move to the other group. Can we do something?
Yeah, sir. The psychoeducation is one of the important part where all the caregivers need to be psychoeducated about the illness, as well as the social adjustment for the caregivers also need to be taken into the consideration, and they need to also be informed about if they are living in a system where this responsibility can be shared, can help in a better mental health.
Thank you.
Thank you, sir.
Thank you. With this, we come to the end of our award papers session. I'd like to thank ma'am and sir for joining us today. We are very grateful for you for accepting our invitation and for your valuable contribution to this award papers session. The results for this will be announced in the valedictory segment tomorrow. I request the paper students to log in for the poster session as well, which will begin in the next 5 minutes. Thank you.
Dr. Hema, nice to see
Hi.
you. All the best.
Thank you, sir.
Thanks for the moderators.
Bye. Thank you, guys. Thank you.
Thank you, sir. Thank you, sir. Thank you, ma'am.
Bye.
सब गड़बड़ हो गई, पता है स्लाइड मेरी खुली नहीं है।
I'll just call him. Good afternoon, everyone. Welcome to the award poster session. Today we have with us as judges Dr. Jyoti Shetty and Dr. Rishikesh Behre. Dr. Jyoti Shetty is the professor and head of the psychiatry department at Bharati Vidyapeeth Deemed University, Pune. And as well as that, she is the consultant psychiatrist at Dinanath Mangeshkar Hospital, Pune. And she's also been an ex-faculty of KMC. Dr. Rishikesh Behre is an associate consultant psychiatrist at KM Hospital and Research Center, Pune, and has also been an ex-faculty at KMC Manipal. A couple of quick instructions to the participants. You will each get 90 seconds for the presentation, the end of which will be marked by a buzzer. Following this, there will be 90 seconds of discussion time with the judges. To begin our session, first up, we have Dr. Manasa. I request you to share your slide, please.
Is it visible, ma'am?
Yes, you may start now.
Good afternoon, everyone. My topic is on knowledge, attitude, practice, and mental health impact of COVID-19 on healthcare workers. Over 8 million confirmed COVID cases have been reported in India by the end of October 2020, with numbers increasing day by day. High prevalence of mental health problems was observed among frontline healthcare workers during this pandemic. Globally, there are very few studies on this topic. My main aim is to assess the depression, anxiety, and stress among healthcare workers during corona outbreak and to evaluate the knowledge, attitude, and practice to the major disaster. An analytical cross-sectional study was done on specialists, super specialists, postgraduates, interns, and nurses of Ashram Medical College. I included age group of 20 to 65 years and excluded who had previous history of psychiatric illness. Socio-demographic data, set of questions targeting KAP and depression, anxiety, and stress scale were used. After informed consent, question is sent through online Google Forms and also printed forms. Among 167 field forms, 7 were excluded as their previous history of psychiatric illness. My results included 9.4% of specialists, super specialists, 21% of nurses, 20% of interns, and 49% of postgraduates. Prevalence of depression, anxiety, and stress are more in nurses when compared to others, as shown in the bar diagram. Severity of depression, anxiety, and stress are graded from normal to extremely severe in this bar diagram. And chi-square test depression is significantly associated with feeling of being ostracized, dissatisfaction with the facilities provided, anxiety with the female gender, unmarried nurses doing COVID duty at that time, frequency of hand washing every hourly, use of PPE, and feeling of being ostracized. Stress with the female gender, nurses, non-specialists doing duty more than 12 hours per day, feeling of being ostracized. In my discussion, prevalence of depression, anxiety, and stress were found to be similar to that of previous studies. My conclusion is adequate training on the use of PPE, strict infection control practices, awareness about COVID-19 to decrease social ostracism, shorter schedules, enabling adequate rest after shifts may decrease this burden. Thank you.
Thank you. I request the judges to take over for discussion.
Thank you, Dr. Manasa. I just needed a little bit of clarification because it was not really in the slide. The healthcare workers, with regards to, I mean, this was a COVID hospital to begin with?
Yes, ma'am. I was at a COVID hospital with patients till now.
How far into the pandemic, and since you first saw case in the pandemic, did you do this assessment of KAP?
My assessment in second week of September, ma'am.
Okay, so it was, when did you all start treating COVID patients?
We started from December.
Excuse me?
From the December 2019.
You had seen a COVID case in December 2019?
Yes, ma'am. There was a suspect actually to start with. Then the real cases started to flow from February to 2020.
Okay, so you did have a case in February also?
Yes, ma'am. From then we had regular cases to be admitted.
No, was it diagnosed?
Yes, ma'am.
Okay. Right. So you were talking about, Acha, you have given the breakup of professions. Barring the nurses who seem to have more of the stress and the depression, what about the other specialty? I mean, other groups like interns and PGs, because it has not been very clearly mentioned.
Actually, due to time constraints, I couldn't say about all of them, ma'am. As we can see in the second bar, in the second diagram, 44.3% of PGs have depression and 65.8% have anxiety, and 21% had stress symptoms.
Was it specifically related to being on call in the COVID wards?
Yes, ma'am. There were several factors because there were repeated time schedules for which we have to do the duties during that period, ma'am. There were duties for more than 12 hours per day also in some cases when regards to ICU setup.
For the ICU PGs?
Yes, ma'am.
Okay. Yeah, Dr. Rishikesh can ask.
Yeah, so in this study, I mean, how many did you identify who had significant psychological distress?
Sir, I didn't get you, sorry, sir.
So how many of the participants that you examined had significant distress, psychological distress?
In my third graph, you can see that 8.1% had mild forms of stress, 9.4% have moderate stress, and 6.3% severe stress, and 5% extremely severe stress.
Yeah, so your graph, your graph of depression says 8% had depression.
Yes, sir. Extremely severe forms of depression.
Right. So, and what did you do about these participants?
Sir, we have contacted those patients, those subjects, sir. Actually, most of them are nurses in my sample, sir, who had higher levels of stress, depression, and anxiety.
So, what did you do to them? These 8% whom you found had that they had severe symptoms.
So I consulted them and asked about the stressors, major stressors during the period, sir. The major concern was times of duty, sir, for more than 12 hours per day, and feeling of being banned from the society, sir. So I just behavioral therapy of stress management I have conducted, sir, to those nurses.
Did this study have any ethical committee approval?
Yes, I have contacted with the ethical committee of a college, sir.
Yeah, so was it formally approved by ethical committee?
Actually, no ethical committee is being conducted as of now, sir. The committee members have told me to go on with the study, sir.
Right. So from an ethical perspective, it's important that whenever you do any research, and if you're identifying people who have significant psychological distress, okay, then from an ethical perspective, it becomes important for you to have some kind of a mechanism wherein you're able to provide them with support.
Yes.
Was there any attempt made to sit and, since you had these findings and it was done in September, about people, I mean, the pandemic continues, so about addressing in terms of a preventive aspect, in terms of, having some sort of, as they go for their duties, addressing it with some sort of stress management programs for people who are being put into the pandemic duties?
At the time of my study, I couldn't do anything, ma'am, because it's a peak of pandemic and we do not have any facilities to track down some of the nurses. So
no, I'm saying that was there any attempt when we are sitting and educating about, simple things like there's training for PPE and all, which always goes for every new batch of interns, which, for example, comes in. So was there any sort of stress management or any inputs that was given before they go into their duties fresh? Knowing that there has been a round of stress and you have picked up cases who have been under stress.
Yes, ma'am. To some of them, I could reach by telephonic consultation in respect to interns and nurses, but couldn't reach on a large scale.
Okay, thank you.
Thank you.
Basically, madam is asking, what is the implication of your study? Okay, and how the results of your study could have improved the protocols in your hospital.
The training on the PP and awareness about the COVID to decrease this social ostracism.
Yeah, so these people who, once you're identifying that they have significant distress, so you could have offered them as a protocol, some kind of stress management.
I couldn't on a large scale, but being on the second wave, we can.
Yeah, so you're still a PG. Okay, so your learning is that any kind of a research should have some kind of a ethical oversight, and it should also have a implication, which so when you're doing research, you should also be able to give back to the community from beyond which you're doing the research.
Yes.
Thank you.
Thanks.
Thank you, sir. Thank you, ma'am. We move to the next presenter, who is Dr. Praveen Godra. I request you to share your presentation.
Yes, ma'am. Good afternoon, everyone. Myself, Dr. Praveen Godara. I'm presenting post on internet addiction in school-going adolescent, a cross-sectional study. Use of internet has increased exponentially worldwide, with prevalence of internet addiction ranging from 1.6% to 18% or even higher. And the aim of the study was to study the level of internet addiction and to identify the relevant factor of internet addiction in adolescent school-going students. The methodology was target population was school-going adolescent of Aurangabad city, and we done stratified random sampling, and the instrument used was individual demographic interview and internet addiction test by doctor. That descriptive and statistics were done, and the effect of internet addiction and its associated factor in school-going adolescents were found. In result, we found that 13.12% were addicted and 67.11% were at risk of getting addicted to internet. And the most common number of addicted students were at the age of 15 years, that was 69. And the primary reason for using entertainment was entertainment. Internet was entertainment, that was in 358 students. And in the distribution of students according to their preferred website, in which chatting was around 15%, blog was 14%, games were 12%, and journal website were 26%, and 27% said other. And in our study, we found that out of total 602 students, 79 students, 3.2% of.
Thank you, Dr. Praveen. I request the judges to take over.
Yeah, Praveen. Again, my question will again be to you as to when did you do this study exactly?
Ma'am, October 2019 to March 2020.
To March 2020.
Yes, ma'am.
So it was pre-pandemic.
Yes, ma'am.
Okay. With regards to the, I mean, this is also the question that was asked earlier by Dr. Bere to the student. This has been approved by the ethics committee?
Yes, ma'am.
Okay. So then what about, now this was school going. So
Yes.
Did you take an assent after a parental consent from the children?
Ma'am, the consent was taken from school authorities, and we talked with parents of the student also, telephonically. And the study was done in the respective schools.
So for the adolescents, did you take an additional assent? Assent. Because they are adolescents, you said. That is something that you would have to consider, okay? When you're doing with below 18.
Sure.
Since they are children who understand, additionally with the parental consent, you would have to take assent. Yeah, Rishikesh can ask.
Yeah, so in sampling method, you have mentioned stratified random sampling. So can you just explain to us how that was done?
Sir, in stratified random sampling, sir, to choose which student, as we have not taken the student from whole of the class and divided them in the random sampling, and after that we've taken the student of.
So how did you stratify them?
Sir, on basis of age.
Hello?
Sir, on the basis of age.
Yeah, so what is the procedure followed?
Sir, for stratified random sampling, sir, after that taken the student from that adolescent age, that is from in my study was from 13 to 16-year-old, and according to age, we that two group were made, that half of the student from that class were taken.
Yeah, so for each class, you took 50% of the students.
Yes, sir.
Yeah, and how many such schools were approached?
Sir, around 10 schools. Of course, that in MGM Aurangabad, they have 3 schools, and the school were 2 school were English medium, 3 school were semi-English, and 4 school were Marathi medium of Aurangabad city.
Yeah, so that is not exactly stratified random sampling what you are explaining. Okay, so maybe you should read about what that is.
Sure.
Okay, and so in this graph that you have shown, 260 in the age group of 15, 260 students were at risk. Out of how many?
Sir, the total student at the age of 15 was 260 plus 82 and of 69. That is 340. Around almost 400 students were at the of age group of 15, and in that age group of that 15-year age student, there in that 260 were at risk and 69 were addicted, like that.
Right. So in this particular graph, it would have been better for you to represent them as percentages.
Okay.
Right. So that is what you are interested in. What percentage of the population you have studied is at risk.
Okay, sir.
So that would have given a more clearer picture. I have no other questions.
Thank you, sir.
I don't have either. We can go to the next.
Thank you. Next up, we have Dr. Bobia James. I request you to share your presentation.
Can you see the slide?
Yes, it's visible. Okay, you may start now.
Okay. Good afternoon, everyone. I am Bobby James, presenting a case series on the causes of mortality in the patients residing in a rehab center during the period 2010 to 2020. Files of such patients were accessed for details and clarifications were obtained from treating members. Out of 8 patients who died, 7 were males, which constituted around 87.5%, and the mean age of death was around 45 years. 4 of these patients were suffering from schizoaffective disorder. 3 of them had schizophrenia and 1 had delusional disorder. 5 of these patients died due to medical causes that corresponded around 62.5%, out of which 1 died due to autoimmune disorder and its complication, 2 had seizure and choking, and 2 had cardiac arrest. 3 out of the 8 patients committed suicide, which constituted around 37.5%. People staying in long-term care centers may often underreport or negate symptoms, leading to undetected medical conditions or psychiatric emergencies. All these events occurred when least anticipated, and risks were identified only in 2. Periodic and regular monitoring for medical causes as well as suicidal risk, irrespective of the predisposing factors, may be opted as a strategy to reduce the mortality in rehabilitation settings. Thank you.
Thank you. I request the judges to take over, please.
Yeah, thank you. That's very short and sweet, and it's important. But then you said that there were only 8 deaths in the past 10 years, right?
Yes, sir.
What made you think of actually presenting this case series?
Ma'am, I was working in the rehabilitation center, so I wanted to know the causes of the mortality of patients. It is known that many people's there is more of mortality in and suicide known in patients who have psychiatric problems. So I wanted to know what are the causes of mortality when in a rehabilitation center, when there is adequate medical conditions. And
okay, what was the number of deaths? In how many patients admitted at the thing? You must be having a year-by-year breakdown, right?
Ma'am, in the last 10 years, around 450 patients were admitted, ma'am.
Okay, out of that, only 8.
Yes, ma'am. I have only evaluated those who died while residing in the rehabilitation center.
Okay. Any implication for this? I mean, apart from the fact that, of course, we have to watch for suicide and comorbidity.
Ma'am,
in terms of structure or SOPs for the rehab center, since you're anyway working there?
Ma'am, what I found interesting was that in rehab center, especially even if there is a medical, like we are looking for medical conditions and psychiatric emergencies, the patient seems to underreport or negate symptoms, which may be one of the factors which you have to keep in mind in order to prevent suicides or deaths.
Yeah, but then in a rehab, they probably maybe majority of them could be chronically ill.
Yes, ma'am.
So reporting may be a problem with them anyway. Is there
Yes.
anything in terms of, I mean, since if you were to manage a center, for example, is there anything that you would sort of, help? I mean, this study, how would it help in improving an SOP for running the rehab center? Like
Ma'am,
maybe some sort of physical structure, it could be about evaluation before being put in or whatever, or
Ma'am,
an intermittent oversight.
Ma'am, periodic measurement of periodic and regular monitoring for suicidal risk is one of the strategies that I have to keep in mind. The other thing is that even if the patient is having any psychiatric disorder, it is possible that during the course they may have some depressive symptoms which may not be considered during the stay. So we
No,
have to
which is
keep.
why I'm asking, do you feel that in a regular rehab center or where you have been working, is it something that may not have been done, or is it something that is something likely to be missed because of the way the work goes on?
It is
Or you
not.
feel that an SOP needs to, like every 3 months you do this assessment, 6 months you do this assessment?
Yes, ma'am. Keeping a regular monitoring of all the comorbidities and suicidal risk assessments 3 monthly may
Fine.
help, ma'am.
Yeah, thank you.
Yeah, so I think as ma'am said, it's important for you to give these percentages in the perspective of how many inmates have been there in the rehab center during your study period. Okay, so you should express that as a percentage of the total inhabitants. Second point is there have been 3 suicides,
Yes, ma'am.
which is 37.5%, so which is quite high among the causes of mortality that you have observed. So all these
Yes.
suicides happened within the center.
Actually, sir, these patients were having vocational rehabilitation. So they had going for daycare, like on day basis for work. So while going for work, they have committed suicide.
Yeah, but they were inmates of the center at the
Yes.
time of when the suicide happened.
Yes, sir.
Yeah. So did you also look into the mode of suicide?
So two of them had drowned and died, and one of them jumped from the top of a building.
Okay. So what is the protocol you think that can be followed in the center to avoid the repeat of these suicides?
Sir, suicidal risk assessment is one of the regular suicidal risk assessment is one of the strategies that can be done, because one of the patients had actually gone through the computer and searched for ways by which he can commit suicide, which was found out only after the death of the patient. So a regular monitoring of suicidal risk assessment may be one of the strategies that can be done.
So how can that be done, you think?
By asking the patients about what they feel and whether any suicidal ideas they are having
Do
while
you know
in
any scales or any clinical interview that can be done to assess suicidal risk?
Columbia's suicide rating scales.
Anything else?
I'm not sure, sir.
Is anything used in your center routinely?
No, sir, I'm not aware.
Okay, thank you.
Thank you. Next up, we have Dr. Gio George. I request you to share your presentation.
Is it visible, ma'am?
Yes, you may start now.
Okay. Okay. Myself, Dr. Gio George. My topic is all wounds are not external. The introduction is that emotional reactions are a consequences of and contribution to existing medical illness, and treatment of one improves the other. During the period of epidemiological transition with new health challenges, studying of comorbidities of chronic physical illness is much relevant since they represent a greater cause of death in the world. The prevalence of psychiatric comorbidity in general hospital setting is almost 20 to 40%. The aim and objective of the study is to determine the prevalence and recognition of psychiatric illness in patients admitted in internal medicine department. Methodology is a cross-section study done in the Department of Medicine over a period of 1 month. All the patients are admitted in the medicine department who gave consent were included, and patient critical care units were excluded. The study was based on a parent study, and sample size was calculated to 200. And data analysis was done during SPSS, and the sampling method was consecutive. All the patients were interviewed, and sociodemographics data were assigned. Mini as well as ICD-10 criteria was used for assessing the psychiatric comorbidity. The results came that the prevalence of psychiatric disorder is around 43% among the inpatients. However, the treating physician only identified 12% of them. So it seems that accompanying psychiatric problem is usually neglected because of the urgency of the treatment in primary medical conditions. So the conclusion is that the referral rates among medical inpatients is much low compared to the actual prevalence, leading to the underestimation of these disorders and worsening the morbidity. So in order to plan a healthcare system effectively, it is important to gain insight into the prevalence, severity, course of the psychological sequel and variable influencing them. So it is high time that the medical practitioners sense the importance of integrating medical health into their practice, mental health into their practice. And this is my references, ma'am.
Thank you. I request the judges to take over the discussion.
Yeah, thank you, Dr. Gio. Actually, my issue is with your title. Why do you pick up this title of all wounds are not external?
Actually, it was a part of a study conducted by me. Actually, there's a lot of patients were readmitted in the medicine department during the past 3 to 4 years. So during our peripheral posting, we find that many of the patients have psychiatric comorbidities, and that is not picking up by the physicians.
Yes. No. I'm not going to iterate about the content of the study. I'm saying why the title.
The thing is that actually we are noticing about only the external wounds. Actually, the psychiatric comorbidity is
Yes, but in internal medicine, you won't be having any external wound, right? You would be, it's not like medical problems are externally, unless you're saying that they are visible in some sort of lab parameter or something. Okay. So one is that I know like when you publish, you can give fancy titles, but then let it be a little relevant to the topic. Okay. That is just a suggestion for you. It's one thing. With regards to, you said that this was part of a larger study. Is that what I understood? That it's
Yes, larger study means actually we are assessing the amount of readmission, number of patients who are readmitted in the medicine department. So readmission was also comes in under one objective. So I eliminated that and only included the recognition and prevalence in this study.
Okay, fine. So then in the period that you conducted the study, how many you said you took 200 patients? That was because of the statistical derivation.
Yeah. I got 191 as patients, so it was corrected to 200 for round figure for rounding. That's
right. Since this was part of a larger study and you were also looking at readmissions, we all know that there's a significant amount of psychiatric disorders in internal medicine anyway. Was there any attempt made by you or your team to indicate?
Yeah, actually, this study was discussed in the clinical committee meeting in medicine. After that, all the first year residents in medicine were instructed to evaluate the past history little more thorough. So to pick up any psychiatric comorbidity or any other psychiatric illness, that psychiatric medications in the past history. So it is going comparatively better, ma'am.
Okay.
Now the first year residents
in medicine it has been included in some sort of SOP.
Yes.
Yeah, Dr. Rishikesh.
Yeah, was any sampling method used, and how were these 200 patients selected?
Actually, consecutive sampling method was used. All the patients admitted who gave consent was included in the study, and almost 50 patients were admitted per day in the medicine OP, and it was done during my peripheral posting in medicine the last November after obtaining the consent from research and ethics committee. So I took the sample in almost 25 days and concluded this on consecutive basis.
So do you think there may have been any bias in your sample?
There is some sort of a recall bias is there, but I try to eliminate it as much as possible with by creating a socio-demographic profile, socio-demographic performer.
And what was the medical distribution of medical diagnosis in these patients?
Most of the patients first comes with around 20 to 30% where comes with chronic pain and recurrent fever, tiredness, etc. like that. And they were admitted, and all of the medical evaluation was done. Some of the patients were treated with chronic diabetes, and other diabetes as well as hypertensive patients are also there. And it was
yeah. So I mean, probably just looking at a prevalence would not give you so much information. You could have put in a lot more data in your poster. You could have looked at different diagnosis wise. You could have separated them into infectious diseases, non-communicable diseases, and then seen how the prevalence is. You could have also looked at different factors that determine who are the people who have a higher mental health comorbidity.
Yes, sir. Yes.
Because this poster is not very informative because it only gives me one particular information.
Actually, for making this poster, I eliminated that data also, because since it's a psychiatric CME, I give more importance to the recognition of psychiatric illness among the inpatients.
You could have still seen psychiatric illness, but you could have looked at what are the factors that determine who are the people who have psychiatric comorbidity, or what is the that would have been more informative.
Yeah. Yes, sir.
And regarding the title, I also agree with Madam's observation that so because this is not, this is not really you're not writing a magazine article, it is a scientific presentation. So scientific presentation, there is a specific method how a title should be written. Just so ideally, just by looking at your title, I should be able to know what the study is about and what is the methodology of the study. It would be a good idea for you to look at how a title of a scientific presentation should be written. Okay, thank you, Ji.
Thank you. Moving to the next presenter, we have Dr. Harshita. I request you to share your presentation.
Hello, is it visible?
Yes. Can you make it into a slideshow?
Yes.
Yes. You may start now.
Yeah. Good afternoon, all, to the respective judges and co-participants. So I would like to present a study done in the tertiary care center, thyroid hormone dysfunction and psychiatric illness, done in EMHANS. So to build the context, hypothalamo-pituitary thyroid axis plays an important role in relation of neuropsychiatric manifestation. There is good evidence to show that psychiatric illness per se can cause alteration in thyroid function. There are also consistent evidences to support deficiency of nutritional indicator like vitamin B12 in neuropsychiatric illnesses, irrespective of dietary status, especially in old age. Nutritional psychiatry is a rapidly growing field of research, and there are lacunae in studies which look at the complete nutrition status in severe mental illness. Among our aims were to determine the distribution of TSH hormone levels and to determine the distribution of vitamin B12 schizophrenia and bipolar patients. A retrospective secondary data analysis of Tertiary Care Institute was planned in time period of 2013 to 20, consisting of patients with severe mental illness and their families. Among the 157 bipolar and 96 schizophrenia patients that we found, of total 253 patients, majority were male, and mean age group of them being 38. Information on baseline TSH hormone level were available for 141 and 69 patients respectively. Similarly, baseline vitamin B12 levels were available for 43% and around 6% of bipolar. Schizophrenia patients.
Thank you, Dr. Harshita. I request the judges to take over the discussion, please.
This was a chart review, right?
Yes, ma'am.
Based on the thing. What was the reason for doing this chart review? Was it part of a larger study?
Yes, ma'am. It's a part of larger study. It is so I've acknowledged the data from ADBS project that is done, and also I have collected data in this year in 2020. So I have worked as a part of it.
Yeah.
So
No,
the main this thing aim for doing the study is that there is literature that says that there is increased amount of thyroid and vitamin B12 deficiency seen in the psychiatric illness prevalence is high as compared to the normal population. And also there are studies being done that the correction of such micro and macronutrients which will help in betterment of neuropsychiatric manifestation. So doing screening procedure of these thyroid and vitamin B12 will help in better treatment of the patient. So it can have an impact on the health system as well in screening of the patients.
yeah, actually, I'm not very clear as to what was the hypothyroidism that you found.
It is tabulated. Yeah, it's around 2% was 2.84% of bipolar had hypothyroidism, and schizophrenia around 1.45%. More
Hypothyroidism as in having TSH low, or it was
TSH was high, ma'am.
TSH was more than 5.5 in all of them, but they were clinical. I mean T3, T4, everything, or it was subclinical.
Ma'am, it was both, including both clinical and subclinical. Ma'am, we have not segregated, analyzed that. So I have taken only the TSH level and tried to assess how many hypothyroid patients based on TSH level.
Okay. No, because your discussion was about, fine, B12 supplementation and, sitting and giving about micronutrients and improving the nutrition status. What about thyroid dysfunction? Because I think unless you know whether they are clinical, subclinical, it would be a little difficult to comment on how you address that.
Yes, true, ma'am. So we usually we treat hypothyroidism when it is when TSH level is more than 20. We treat more than 10. But subclinical, that the subclinical also detecting is very important because it goes undetected and untreated. If that deficiency is not treated, then the refractiveness of the psychiatric illness also will be high, ma'am. So it's important to treat subclinical hypothyroidism as well.
Okay, thank you. Thank you.
Thank you.
Hello, can you hear me?
Yes, sir.
Yeah, Harshita, how was the sampling done in this study? Because I see 253 patients were studied in a period of 2013 to 2020.
Yes, sir.
So how was this 253 subjects selected?
Sir, it's as I told you, the part of a project also. Apart from the bipolar and schizophrenia patient, other psychiatric disorders were also included. But among these, we could get only 253 patients of bipolar and schizophrenia having the data.
So are these patients only recruited under a particular project, or are these all patients who are, admitted in NIMHANS over this period, or what is the universe of your sample?
It is both IP as well as OP patients, sir.
No, but is your universe all the patients admitted with schizophrenia or bipolar in NIMHANS during 2013 to 2020?
No, it's not it's not only the IP, it's not only the inpatient, it's also the outpatient files we have seen, sir. And one more thing is that
but then in a period of 7 years, it is unlikely that you have found only 253 patients in
yes, sir,
NIMHANS.
that is true. And
So
one more thing.
Obviously, you have used some criteria to select these 253. So that is not clear what that criteria is.
The baseline patients who's having this baseline investigation of thyroid and B12, label were chosen.
So only those patients who had a baseline, who had a thyroid level
Yes,
measure.
sir. So that in order to reduce the confounding effect of the psychotropics and the course of illness, we try to include those patients who are at least who are the naive to the medicines or having a short duration of on psychotropics. That's why we took the baseline data of thyroid.
So they were
Again, in a period of 7 years.
Sorry.
Yeah, I was just saying that again, in a period of 7 years, difficult to believe that in NIMHANS there are only 250 patients who had a baseline thyroid level.
Yes, sir. There are missing data. The total number were around 1,250 odd, and we got only the patients with baseline data is around 253.
All right. Okay. It's still not clear to me. But moving ahead, your title says thyroid hormone dysfunction, but in your results you seem to have included B12 also.
Yes, sir.
So that's a little misleading. So what is your objective is to look at TSH and B12 both?
Yes, sir.
In your objective, you mentioned both TSH and
B12.
B12, right? And why only B12? Did you also look at other vitamins levels, vitamin D, for example?
No, sir. The thing is that we could not get vitamin D levels in our hospital data. B12 and thyroid profile and all the other hemograms and liver function, renal function tests are available in our hospital setup, and we get mostly this. And vitamin D, I could not get much data. That's why. We have to refer the patients to outside for the investigation. So we have not looked at that.
Okay. Did you also look at indication why thyroid or B12 was done in these patients?
The thyroid and B12, yeah, they were mostly the suspected the cases for nutritional deficiency and thyroid hormone. In thyroid, only when there is clinical suspicion, they would have screened the patients. Otherwise, it's not a routine investigation that we have done.
Yes. Could this have been an incidental finding? The distribution of TSH and B12 deficiency, could it have been an incidental finding?
TSH, no, because it is corroborating vitamin B12 and TSH. It is the thyroid dysfunction. It is corroborating with earlier literature that there is the high prevalence of thyroid dysfunction and also vitamin B12 deficiency in community-based sample and also the hospital-based studies that is done. So I think that it is these findings may not be incidental and might be true also.
Yeah, so to answer that question, ideally you should have also had a control group. Only then you would be able to answer that particular question. Yeah, thank you. I don't have any other question.
Thank you. Next, we go on to the next presenter, Dr. Janisar Javed. I request you to present your slide.
Is it visible, ma'am?
Yes, you may start now.
Hearty good morning to one and all. I, Dr. Janisar Javed, will be presenting my poster titled Study on the Usage of Psychiatric Helpline Number 9108919025. Coming to the introduction, mental illness accounts for about a sixth of all health-related concerns in India, but the means of addressing this problem is not increasing in a proportionate manner, as the existing number of mental health professionals are concentrated generally in the major cities. So our aim was to study the usage of 24-hour psychiatric helpline number 9108919025. Coming to the methodology, this was a one-year retrospective study conducted in the Department of Psychiatry, Annapurna Medical College, Mangalore from 14th May 2019 till 13th May 2020 after obtaining ethical clearance. All the calls which came on our helpline number were recorded in the helpline register and data was collected from that. Coming to the results, we received a total number of 203 calls, and one of the major findings of our study is that the majority of the callers were first-time callers, and they had not contacted any kind of mental health facility in the past. Calls were received on various psychosocial issues, prominent among them being stress among students, work-related stress, and relationship issues. Coming to the discussion, the reluctance to seek help is likely due to stigma. The fear of being labeled with mental illness results in resistance to seek treatment. Helpline services are a welcome addition to an ever-growing toolset for tending to mental health issues. Thus, we can conclude the existing mental health facilities in the country like India have a growing disparity in meeting the needs of the population. Thus, helplines provide to be efficient, cost-effective, easy, stigma-free environment which offers confidentiality and anonymity of the caller while seeking help. Thank you.
Thank you. I request the judges to take over.
Yeah, I would, yes. Thank you, Dr. Janisar. I wanted to know who actually mans the helpline. Are they psychologists, psychiatric social workers, postgraduate residents in psychiatry, or consultants?
The postgraduates on duty, ma'am. Whenever a call comes, the postgraduate on duty receives the call, ma'am.
Why I asked is because it's about do they have some training to handle? Are they given some sort of training to handle the helpline? Because
Yes,
a
ma'am.
first term resident may not be able to.
Yes, ma'am. All the postgraduates have been trained for receiving the call, ma'am. They collect all the relevant details and consultation over the phone is done. And if any doubt is there, the staff on duty is also consulted.
Yeah, because you're given a graph about they either called for OPD, they are followed up, or they are referred for to a mental health practitioner. So then, how is this division done based on? I mean, is there some sort of scale that you use in terms of asking some sort of questions, screening questions online?
No, ma'am. We just when a call comes, we take the call and we ask all the relevant details and the reason of calling on the helpline number. If it's our old patient, we ask them to come for follow. It's a new patient, consultation is done, and then they are also asked to come to the OPD. And if it's a call is coming from a remote area, ma'am, then we refer him to the local mental health professional over there.
Okay. No, why I asked about details is because helplines work for anonymity also. The advantage is the anonymity.
Yes.
I mean, of course, there are also minuses. So I just want to know what sort of details are taken. Secondly, you said that I understand that you have studied till 13th of May 2020. So that has been, into the lockdown actually. So was there any significant change in terms of increase or decrease of calls to the helpline? I mean,
Yes,
I
ma'am.
would understand.
As soon as the lockdown started, it was a 1 month period from April 24th till 13th May. So the calls.
Could you have shown a graph in terms of any sort of escalation in the lockdown because people couldn't travel, so more called up because it was available, or there was no change?
No, ma'am. Inquiries regarding the old patients asking for a prescription of can they continue the medications? For that, they have called, sir. The calls increased during the pandemic, ma'am.
So it was basically like a teleconsult.
Ma'am, if a small dose of adjustment needed, we have done with our old patient. No new medication was ever added.
No, because you have said that it's telephone counseling, right? So
Yes,
then it was use of the helpline. So was there any breakup of how many sought or new people sought help in terms of counseling versus OPD follow-ups who, couldn't travel, so just wanted a renewal of prescription, so hence just, wanted either to get it or to be told to continue the same?
Yes, ma'am. Out of the 203 calls we received, ma'am, in that 113 calls were new, the first-time callers, ma'am. They haven't contacted any kind of mental health facility in the past.
That whole year?
Yes, ma'am.
Okay. No, I just want to know whether there was any increase in the pandemic period. That is all.
Yes, ma'am. During that, the calls were old patients, ma'am. Usually, we were not able to come to the OPD.
Okay. Thank you.
Welcome.
I think the point that ma'am was trying to make is that, I mean, your poster could have been more informative. I mean, you have presented some data on how many have attended, how many have called, and how many have attended. What are the call timings, etc. But I mean, what is the scientific implication of this of your presentation?
So we feel that it is a good starting point, and because the helpline numbers and the caller who is calling, it is a good starting point for them for getting help regarding mental illness, since our postgraduates have been trained and they have the information, and they can provide support to the people who are in a crisis at that time.
Yeah, I mean, that is your assumption. Right. I mean, a good way. I mean, if you have to evaluate the utility of this service, scientifically, using scientific methodology, good idea would have been to contact these people again, after some time after they have sought help from a helpline, and get a feedback from them, as to what they felt about having sought help. Did the helpline really address the questions or queries that they wanted? You could even use a qualitative methodology to understand their experience, or it could have it can be an audit as well, right? So I mean, that kind of information would be more valid for you to make these the statements that you are trying to say.
Okay.
Right? I mean, so yeah, I mean, so basically, I mean, more I think more work is needed. It's a good thing that you have a helpline, but I think more work is needed to be able to analyze really, what is the utility of this. Okay. Thank you. Yes.
Thank you. Next, we have Dr. Manik Inder Singh. I request you to share your presentation.
I hope it's visible and you can hear me. Hello?
Yes, it's visible. You may start now.
Okay. Good afternoon, everyone. My poster for today is Development, Utility, and Current Status of a Mental Health App, here for you. The last decade saw a large surge of both mental health issues and awareness on the need to tackle them. In this new era of technology, we realized that the people were reaching out to social media and the internet to understand their mental health issues. This is one of the few apps in the country developed by mental health professionals. So it uses GAD7, PHQ9, DSS21, and BACE3 as screening questionnaires. The app was developed over a period of 6 months, and the suggestions received in the pilot study were incorporated and were received well by the university students on retesting. The results show that the lion's share of the 1,500 users were engineering students. The app was well accepted by its users, exemplified by a 4.8 star rating on Play Store and 5-star rating on the Apple Store. Mean score on mobile application rating scale was 4.5. The fact that the app was launched in the midst of a pandemic has played to its advantage, since traditional help-seeking measures were unavailable. Technological innovations such as this app have proven that young adults are keen to seek information and help from easily available, discreet, and trusted sources. To conclude, in future, the app will be updated to major Indian languages. Other centers which are interested in collaborating need to be identified so as the app could be used on a larger scale. These are my references, and I do not have any conflict of interest. Thank you.
Thank you. I request the judges to take over.
Yeah, thank you, Dr. Manik. It's an extremely interesting thing, and apart from the fact that it is extremely innovative also in terms of developing an app.
Yes.
My issue, I mean, with regards to your title, I mean,
Yes,
I know you must have had a lot of discussions, brainstorming on the title. I mean, the name for the app, but would here for you really indicate mental health? Because it may be a more specific title would also seek, as you said, engineering students are anyway very used to tech friendly.
Yes,
something that is much more user friendly would be for the lay persons who could also use apart from students, unless it's targeted specifically.
Yeah, the only reason we spent almost a month, brainstorming about how to name the app, because that was one of the last steps to do, naming the app. So we zeroed down on here for you because it is a non-stigmatizing thing. So we did not want a very stigmatizing name for the app, so that people only think that it is for people who have a problem, or people who have mental disorders, or big mental illness. It was meant to be for everyone to just screen and get to know about their mental health status. and seek help, of course, after that.
Okay.
So we wanted
But
non-controversial names. That's why we went for Here For You.
Okay.
We did a polling. We asked our students only, which we gave them a list of names. We had 15 names in mind which we wanted, and so we had a polling, and most of them chose Here For You. So we did a kind of a survey before naming the app.
Yeah, sure. Thank you. And another thing I wanted to ask was, you said that you have, use scales, right?
Yes.
So people who have sort of cut off, is there anything that directs them to a mental health professional
Yes,
or to your department?
Yes, ma'am. So,
And
ma'am,
how do they go about it?
Yes, ma'am. So, ma'am, if you look at the app, so it's easily available on both Apple Store and Google Play Store. So, initially, even when they open the app, we have given them an option to get help. Without even filling up the questionnaire, you can get help if you feel that you need help. So in that Get Help Now section, we have given them helpline numbers, and we've given them our helpline also. So so what we do is we give them a Google form, and one of the persons, the social worker or the principal investigator, contacts them as soon as we get a response from that they need help. And we've told them that in the consent form and everywhere that we've written that this is not a crisis intervention thing. And if you are in a crisis, or if you're suicidal, or if you're having any problems of that sort, we've given them Sneha's number, we've given them Asra's number, we've given Wonderwella Foundation's number, which are working on crisis management. So this is how we went about it. So they do, after filling up all these questionnaires, they do get a last thing is they get a diagnosis, not exactly a diagnosis, but a provisional diagnosis which say that you have symptoms suggestive of depression, and it'd be nice if you contact a healthcare professional. And then we have also given them articles to read about what is anxiety, what is depression, and it's a very small write-up which we had about the symptoms, how what is depression and how is it different from sadness, so that they know when to contact and who to contact. So all these options are given at the last when they are finished up filling up the.
Fine. Thank you. And congrats on the ratings also. Thank you.
Thank you.
Yeah, Manik, can you tell us what is DASS 21 BACE3?
Yes, sir, sure. So DSS 21 is depression, anxiety, stress scale. It is a 21 items scale. So it has 7 items on depression, 7 items on anxiety, and 7 items on stress. And so it is a non-clinical scale. It is used on the general population. It will not give you a clinical diagnosis. That's the fact that we use PHQ-9 and GAD-7 along with it. One thing is that it will increase the specificity and sensitivity, and the other thing is that when we were not giving GAD-7 and PHQ-9 to all the participants. We only gave the patient health questionnaire 9, which is identified and very well validated self-reporting questionnaire for depression. So we gave it only to people who scored a little more than the cutoff, who scored moderate depression on the DSS 21 scale. So it was a logic-based thing. So anyone who scores more in moderately on depression was given a PHQ 9. Who moderately on anxiety was given GAD-7. And BACE is a barrier against a care evaluation, barriers to care evaluation. It's a King's College London scale. It was formed recently validated in 2013. So it identifies what are the barriers which people feel and why do not seek mental health, mental health care.
Right. And in your discussion, you have said that being one of the only research-backed app in the market.
Yes.
Can you elaborate on that? What do you mean by research-backed app?
Sir, we did before making the app, sir, we went through all the applications which were there in the market, the Indian market per se. So which were already there and which were doing the same thing. So we realized that none of them had any backing by a mental health professional. So in none of the apps, the mental health professional, any mental health professional, particularly a psychiatrist, was not involved in the making of the app. So mostly it was formed by software engineers or these engineering people, and none had backing of any research backing. So since we did a pilot and then we launched the app has been launched only 2 months back, sir. So officially launched 2 months back. So all these apps, they only do beta testing and then launch it. We had a full research backed by before launching it.
Right. So where are the results of that?
So that was not in the scope of this poster. So this poster was only particularly to discuss about the development and of the app. That will be published soon, sir. I can send you the link as soon as it gets published, because most of these journals do not allow you to present before you publish the paper.
No, there is nothing like that. There is no. You can present any. There is no restriction on presentation in a conference. Has no link to publication.
Okay, sir.
Right. Right. I mean, I would be more interested because this is. I mean, this is a scientific presentation. I would be more interested in looking at data. I mean, this poster only tells me that there is an app like that, and the rating on a Play Store really is not scientifically valid in any way.
So we use the mobile application rating scale, which is a validated questionnaire which is specifically made for healthcare professionals who are designing mobile healthcare apps. So
right. Yeah, so it's a great initiative. There's no doubt about that. Yeah, but as a scientific poster, I mean, I would have wanted to look at more data here.
Right.
Thank you, Mani.
Thank you. We move to the final poster for the day. Dr. Shapna Hairu, I request you to present your slide.
Can everyone see my slide, ma'am?
Yes, you may start now.
Okay. Good afternoon, everyone. Today I'm going to present the clinical audit done on monitoring of blood pressure in patient prescribed with venlafaxine in psychiatry department. We all know venlafaxine is a dual reuptake inhibitor. Serotonergic actions are seen at lower doses and noradrenergic action is seen at higher doses. At doses exceeding 150 milligram per day, the adrenergic effects of venlafaxine become more prevalent and there could be increase in blood pressure and increased heart rate. Even at the doses below 100 milligram per day, it can also cause hypertension due to polymorphism of the genes CYP2D6 and CYP2C19, which are involved in the metabolism of venlafaxine and can cause adverse side effects at different drug levels. My aim is to audit on monitoring and documentation of blood pressure in patients who are prescribed with venlafaxine and psychiatric outpatient department. My objectives are to check whether documentation of blood pressure is done on initiation, during their treatment regularly, and during dose titration, and to ensure whether pre-existing hypertension was controlled before starting venlafaxine. My source of evidence is NICE guidelines and NG23. My study is a retrospective study done on 52 patients who are on prescribed with venlafaxine or psychiatric OPD, selected through convenience sampling from the period of July 2019 to Jan 2020, and electronic medical record checked for documentation with no exception. My results are on initiation, there is 77% of documentation. On during follow-up, it's only for 62%, and on dose titration for 150 milligram, it was for 44% it was documented, and 225 milligram for 48% it was documented. Among my sample sets of 50 to 23% had pre-existing hypertension and on control with antihypertensives. 58% was only documented. And to conclude, though there was better documented on initiation and during follow-up and during dose titration,
Thank you, Dr. Shapna. I request the judges to take over the discussion.
Okay, thank you.
At what stage did you, was this documented before you initiated venlafaxine?
No, ma'am, it's a retrospective study. During my period of July 2019 to study period, whoever on venlafaxine, I took that sample.
You took the sample as it, yes, but then you went through the case records and whether blood pressure was documented.
Yes, ma'am.
So at what periods was the blood pressure documented? At initiation, after it was reached 150 and 225? Is it a protocol that you'll have in your department?
No, actually, on initiation for every patient, it has to be checked according to guidelines.
Okay.
Only for 77%, it was documented on initiation. On follow-up, whether I checked that during all the follow-up, the patient records were documented for blood pressure or not. And especially during dose titration at higher doses, 150 to 25 milligram, whether it was documented or not.
Okay. So your recommendation is that it needs to be documented regularly?
Yes, ma'am. Actually, NICE guidelines, though it's arbitrary, even in my study, around 11%, there are side effects reported, documented in the case sheets. So that at least at regular intervals and during follow-up, especially during dose titration, better to document the blood pressure, because in a study done by Mbaya et al., 12.5% of patients developed hypertension during the course of venlafaxine. And even case study by Amar Bavle, he has reported QTC prolongation of 492 milliseconds in a dose of 300 milligram per day of venlafaxine in 2-week period. So it's better to document blood pressure regularly, at least at regular intervals.
Thank you.
Thank you, ma'am.
Yeah, Shafna, this sample size of 52 is out of how many patients on venlafaxine?
So during my study period, those in the 6 months period, 52 were on venlafaxine, which is I selected through convenience sampling. I cannot go through the electronic medical record daily. Whenever I able to take like who were diagnosed as depressive disorder, from them I took who were on venlafaxine from in a day, and from that sample was taken, sir, in a day.
Right, this is July 2019 to January 20, so 6 months period.
Yes, sir. Yeah,
so in the 6 months period, have you taken all the patients who are on venlafaxine, or you have selected 52 out of them?
That's like I'm not able to go through the electronic medical record daily, but I selected through convenience. Whenever, if I'm checking the electronic medical records, I select the patients who were diagnosed as depressive disorder. From them who were on venlafaxine, I took that sample, sir. It's not like daily I check the EMR. That's
right. So on an average in a week, how many days did you check?
3 days. Whenever I had OP day.
So 3 days in a week.
Yes, sir.
Right. So approximately so let's say in a 3-month period, you found 52 patients who were on venlafaxine.
Yes, sir.
Right. So did you also include desvenlafaxine or only venlafaxine?
Only venlafaxine, sir.
Right. And so this is only at the baseline before initiation of venlafaxine?
No, sir. On baseline, also during follow-up, and during dose titration also, and the pre-existing hypertension. One of my objectives is the patient who were on pre-existing hypertension, whether they were monitored regularly or not, and to check whether they are not started on uncontrolled hypertension. So the 23% were pre-existing.
In all the people, so in all the people in whom blood pressure was documented, how many were hypertensive?
Yes, sir, 23%. Around 12 patients were hypertensive, but they were all on antihypertensives. Not one.
I'm asking the other way around.
Yes, sir.
Yeah, all the patients in whom the BP was documented, how many were hypertensive?
BP were documented. I cannot get you, sir.
So you say that 23% it was documented, right? Or
no, sir.
77% it was documented.
23% were hypertensive. My sample size of 52, 12 were hypertensive, who had a known case of hypertension. That is 23% were a known case of hypertension. But they were on
just get a results pie chart which says 23% and 77%. 77% says documented, 23% not
so
documented.
That was on initiation of venlafaxine. Yes, 77% documented.
Yeah, so what I'm asking is that in this 77%, did you look at how many were hypertensives?
Oh, okay.
With a history of known hypertension?
No, sir.
No, okay. The reason I'm asking is that there can be a bias, because if you already know that somebody is hypertensive, then you're more likely to check and document there.
Yes.
Right? So otherwise, so somebody who may not be diagnosed, who may not be a known hypertensive, we may miss the diagnosis if they have it, or we may ignore to not check their BP. So basically, I mean, when you know that somebody is hypertensive, you are more likely to check and document.
Check the yes.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Shapna. Thank you, sir and ma'am, for joining us today. We're very grateful to you for accepting our invitation and for your valuable contribution to this session. The results for this session as well will be announced at the valedictory program tomorrow. With this, we come to the end of a very productive and informative day. A heartfelt thank you to all the speakers and the participants for taking the time out and to be here with us. We look forward to having you tomorrow for another enriching day. We will begin at 9 a.m. tomorrow with the final round of the postgraduate quiz. But before we call it a day, I'd like to request all of you to spare a few minutes to give us your valuable feedback using the link that was shared to you on the email that was sent. Thank you and good day.
Thank you very much.
Thank you.
Thank you. Thank you.